everyone. Good morning. All right, let's take our seats. Good morning, everyone, and welcome to our guests, both those who are here in the room and those who are watching us online. I'm Esther Krofa, Executive Vice President of Health here at the Milken Institute. We are here because this is a defining moment in the fight against cancer. More than 5 decades ago, President Richard Nixon signed the National Cancer Act into law, which fundamentally reshaped our nation's approach to cancer. That legislation mobilized government, scientists, industry, patient advocates around a shared mission, demonstrating what is possible when the country comes together for sustained, coordinated action against a common threat. We're so pleased that the National Cancer Act is physically here in the room and will be with us through the morning until 11:30 a.m. So please go to the corner if you would like to see a copy of that. Over the past 55 years, that commitment has yielded extraordinary progress. We now understand cancer at a level once unimaginable, down to the genetic and molecular drivers of disease. We have therapies that harness the immune system. We have tools that allow early detection and more precise treatment. And survival rates have improved significantly with millions of people living longer and fuller lives after diagnosis. But progress does not mean the work is finished. Cancer remains one of the leading causes of deaths worldwide. Some cancer rates are rising, including among younger adults under 50. And while scientific breakthroughs are accelerating, ensuring those breakthroughs reach patients remains one of the central challenges of our time. The next chapter in cancer progress will not be defined by discovery alone. It will be defined by how well we align science with delivery, how effectively we use data and technology to accelerate insights and improve care, and how much we prioritize and invest in prevention. Ultimately, it's by how we collaborate across sectors. Reducing cancer mortality by 2035 is an ambitious goal, but ambition has always driven the greatest advances in medicine. The progress of the last 55 years shows what is possible when leaders across sectors rally around a shared mission. And in fact, we did so at Faster Cures just 5 months ago. We brought stakeholders together from across sectors, life sciences to technology to finance to philanthropy to patient advocates, asking ourselves this challenge: how do we sustain the US leadership in biomedical research and innovation? We left with 6 sets of recommendation. And as we go through the course of today's program, I invite all of us to think about these 6 sets of recommendations, the bold principles that are outlined here as we look towards 2030 and the future. We have a full program ahead of us today. We have leaders from across research, technology, policy, and care delivery. I will be serving as your MC, so you will see me a lot today, helping guide us through today's conversations and talks. But before we begin, I do want to extend my sincere thanks to our sponsors at Amgen, AstraZeneca, City of Hope, Garden Health, and Merck for their partnership and support in making this convening possible. And with that, I would like to introduce Mike Milken, who needs no introduction, for our opening fireside chat. Mike, over to you.
So good morning to you, and we have 9 hours, and those 9 hours today, last night was a warm-up. Our goal is to take at least 10 years off cancer as a cause of death. That is 100 million lives. So there's a little pressure on you today. We're going to try to save 100 million lives by the work we're doing in the next hours. It is not, to me, far-fetched. Dr. Simons and Bill Nelson, who I met in February of '93, what they could do in one day, a $5,000 machine can do 1,000,000 times today in one day. And so the world has changed. Medical records exist, data exists that was never available before. And most of you have spent your life working in the field. So I'd like to introduce a young man who's a dual citizen of the United States and Turkey. He went to Harvard, Penn, and even got an MBA from Penn, not just an MD. He has a great ability to communicate, and we are so lucky that he's decided to serve as the head of CMS, the largest company in the world. Dr. Oz, can you join us?
What an honor it is to be here. The building gets more beautiful every time I walk in it. And for those of you at home who are at work, who aren't able to see this fantastic space, Mike has taken a building that's an iconic location and built it into a must-visit tourist attraction at this point. But many of us who know you as a friend just come visit all the time because you're here.
Well, you've been here before, and we thank you for that. You've been on the job for 1 year now. Kind of amazing, 12 months. What do you see differently today than you saw 1 year ago?
I always knew that CMS had a lot of influence in Congress because we pay the bills. I realized that we had regulatory prowess because so much of the basic functioning of medicine is dependent on the rules we put out to determine physician fee schedules and how much hospitals get paid, what outpatient services are reimbursed, and pharmaceutical pricing. But I did not appreciate the power of being a payer. When you're a payer, you have a lot more lever arms than when you're a regulator. And they're more nimble ones. You can adjust in a very fine way how much people get compensated to do things so they do more of them or less of them. And you have, for that reason, also obligations to protect the corpus that you've been given, the fraud, waste, and abuse that we're now seeing in America, which I think is about $100 billion a year out of a $2 trillion budget, is concerning for a bunch of reasons, but it drives up not just the price of healthcare, but it drives up the regulation in healthcare, which makes healthcare less fun to be in. And it leads to physician burnout, extra costs within the hospital system and insurance services, but it most importantly frustrates the average American who can't figure out what's going on, why with all these rules we not have a more transparent ability to identify quality and cost in the system, and what are the things that need to be done to take this morass of different moving parts and pull them together into a unified machine that can actually deliver on the promise that the American people desire and expect from CMS.
So AI, it's in the news, it's in financial markets, and I know this is a subject that you've been very focused on. What is your view of AI in U.S. healthcare? Biggest opportunities, biggest risk?
There's no question that when I'm asked if I'm optimistic about where we are in healthcare in this country, I am at the 10 out of 10 in optimism because of AI. And I say that with a much deeper knowledge today of what AI could do than I had a year ago. A year ago, like many, I had read up on the stuff. I had a bunch of friends. I'd made investments in AI, so I had a pretty good understanding of where it was headed. What I didn't appreciate was that the big barrier to AI is not technology. The big barrier to AI helping save American healthcare is actually the culture of healthcare. How do we get people to start to use it in ways that improve their day-to-day life so they start to experiment with it in ways that can improve the efficiency of the system and ultimately allow us to do things we can't even imagine possible right now? Let's just break that down a little bit. What are the key things that hold us back? Well, first off, it's imperative that we be able to talk to you, the American people. Right now, I've got probably 40 million emails in the Affordable Care arena. I've got about 25 million emails from Medicare at the beneficiaries. So I can send emails out, but I'm not really interacting with you in the way that I should. When you want to talk to me, what do? You call 1-800-MEDICARE. Is that the best way to do it? Best way to do it probably is to create an agentic AI that is your agentic AI, that knows everything about you that you wanted to know. It knows all your billing history, all the medications you're on, when you fill them, do you need refills? It'll know everything about the doctors you see. It'll be able to predict which new doctors you might want to see, whether they have appointments. It'll make the appointment for you. It'll follow up with you if you don't show up at the appointment. And any other little nuanced question about your beneficiary number not working, all that stuff, it could pretty simply just take care of with a tiny prompt from you, as opposed to what we have now. If I had that ability to talk to you and connect with you, I could nudge you. So we give a free annual exam to every American on Medicare. It's free. Just go see a doctor, get an evaluation. It's the core of the MAHA movement within medicine because it allowed me to at least pull together basic preventive information about you. Less than half of the beneficiaries use it. Think about that. I'm giving you a free doctor's appointment and less than half of people take it. There's a lot of reasons for that. We've looked into it, but fundamentally, it's a hassle. People don't prioritize their health, and if a little nudging, I know we could take it up to 60, 70, 80%. Frankly, if agentic AI would just do it using an avatar to connect with you and talk to you, and have you draw your labs real quick when you're driving by a facility that could do that, I could probably get to 90%. But we're not even exploring these options. The basic billing system of Medicare was built on COBOL. In 1979, I was just starting college. I can't find engineers who know how to program in COBOL. And it's never been changed. So if you ask me, audit the system and tell me where the fraud is, I can tell you in 3 months. I'll put some edits in, or I'll rush it, and within 3 months, we'll have the software up and running. That all should be cloud-based, and if it's cloud-based, now I can apply AI to it in ways never before imaginable. I'll give you one last little response to the second part of your question. Is there something to fear from AI? Absolutely. We have got to be super diligent in every way possible. But the benefits are so great that we don't have the option to say no. The question is, how are we going to do it, not whether we do it.
So I think you've given us a roadmap here that each of us, if we can find 9 billion mobile phones on the planet, we ought to be able to get a person recommending to you that knows you as your own agent here. And likewise, what we've seen, one of the challenges is if we have breakthroughs or changes in how you should treat a patient, how does the clinician even know? How does he find out what's occurring from that? If we sat down here a few years from now, we are very focused here on accelerating with the 55th anniversary of President Nixon's act on declaring a war on cancer. If we sat down here 5 years from now, will the U.S. still be a leader in medical innovation and patient outcomes? We have employees that make 80 to 90,000 who are, the healthcare cost is 40 to 50,000. So it seems like it's an impossible situation here today until we get our costs down and find a way to deal with these issues in America. We're all fully aware that we spend a multiple of what other countries spend, and we don't have life expectancy greater than them. What will it look like in 5 years?
We'll have made salutary advances forward in the next 5 years. And to address the question very precisely, part of the reason we're so much more expensive than, for example, Europe, is we're twice as fat as Europe. 43% obesity in this country, 20% in Europe. Life expectancy when I was in college, when COBOL was being launched at CMS, this country was equal to that of Europe. Now we're 5 years behind. If you're heavier with chronic diseases like hypertension and diabetes, changing your chances of surviving other illnesses like chemo, or causing their own slew of illnesses like dementia, myocardial infarctions, renal failure, hepatic pathology. All these are downstream from obesity, which is why I think there are massive advances that we can make both with technology but also with basic MAHA approaches to numbers of that scale. So let's give a concrete example of GLP drugs. The number one zip code for GLP drugs in America is Upper East Side of Manhattan, which has a fairly low obesity incidence, actually, but they have money. And so they use GLP-1s in ways that people in other parts of the country can't even fathom using it. And until we pass these series of contracts through the president, who's been adamant about this issue, that we pay 3 times more on average for pharmaceutical medications that are still on brand status than other countries. We were willing to pay more than we probably should have paid, and the other countries are paying less than they probably should have paid. So with these most favored nation drug pricing strategies, now they're launched on TrumpRx.gov, it gives Americans the opportunity for GLP-1 drugs and other cash-paying customers, like those buying fertility medications, to pay a fraction of what they used to pay. Our prediction is that with the pricing of GLP-1 drugs, let's say it's $250 a month, and there are less expensive ones coming that are, as you know, pill form, at $250 a month, we will recover the money that we spend to buy Americans GLP-1 drugs within 2 years. And I learned that at your conference last May in Los Angeles, because the head of Aon was there, and I asked him for that calculation, and they had done it for commercial insured patients. If patients stay on the medications, their healthcare expenses drop precipitously to a point that they actually are saving their companies money, even if the company is giving the medications away for free. So we're doing that on scale. We predict that we'll have 100 million pounds lost this year, just from allowing those GLP-1 drugs to be used if Americans use them consistently. If we use them sporadically and we don't partner them with lifestyle changes, like eating more wisely. I notice you have berries. He's such a show-off. He brings berries to the table, doesn't touch them, just left them there. If someone should tell me I have to go back to work after this, if he doesn't eat those berries, someone should send me a picture. But if people don't eat the right things, if they're not willing to do the physical activity that's so critical to our longevity, if we don't work on sleep and prioritize it, these factors, of course, will overwhelm any impact of GLP-1s. But GLP-1s do tend to make it easier to do those things. And so for that reason, we're optimistic that combo will work. But I believe in the power of technology and innovation to improve our care. The best example in my lifetime has been cancer therapy. This beautiful event that you pulled together that allows us to celebrate what has been a success, in that we now can get our arms around ailments we couldn't have even thought of dealing with, much less curing 55 years ago, happened because of technological innovation. And if you have cancer in America, and more advanced cancer in America, your survival rate is much longer than other parts of the world, because we have access to the most cutting-edge therapies and physicians who know how to use them. But not all doctors know how to use them. And if I had to pinpoint one glaring gap in the quality of how we provide care in America, it's cancer outside of major centers. There's a big difference. And we need to be able to help physicians practicing at smaller centers, at community facilities, to be able to keep up with the rapid advance in pharmacological approaches and other therapies, therapeutic approaches to cancer. It's almost, I have no idea. I went into heart surgery because I knew I could keep up. The oncologists, in my era, probably had 6 meds they would use, and most of them didn't work. But I didn't realize what would happen over my lifetime is that oncology would lap everything and become full of a robust slew of solutions. The problem, of course, is most doctors cannot learn about 3 new medications a week. So we've got to make it easier for the right thing to happen.
So you brought up an interesting point here. Aon did a study, 50 million people in America. The company, the employer, pays for GLP-1s. What happens to your medical costs as an employer? They go down. I think I just wanted to underline your point there. Number 2, we did a study, and it was first presented in 2004. The change in weight in America between 93 and 2004 cost the United States $1.5 trillion. So you've addressed another area here. I also want to point out, one of the first times we met, I was at raising money for cancer research at a baseball game, one of my 500 I've gone to, with Joe Torre, and you were doing a heart transplant on his brother. What do you remember? That was early in the day in heart transplants.
So this is, they made a movie about this, Mike, actually. They didn't let me act in it, thankfully. But I was a young surgeon at Columbia. This is the late 90s. And the Yankees, how many Yankees fans are there out there? Are there a couple? Yankees hadn't won a World Series in 18 years, I guess, 17 years. And so it's 1996. I'm called by Joe Torre because his brother is waiting on is in South Florida to die, and he wondered if we could do anything. brother was 64 years of age. I said, well, yeah, we can do a heart transplant. At the time, Columbia, where I was practicing, had the largest transplant center in the world, and I could practically see Yankee Stadium from my office because it's in Harlem, and where the Bronx, where the stadium is right across the river. So Joe brought his brother up, put him in the hospital, and we waited. You have to wait for a heart. And ironically, the Yankees, who are down 2-0, they lost both their home games. They come back, storm back, win 3 games in a row in Atlanta. And after the 3rd game is over, I get a phone call from the Bronx, where they're coming back to win the World Series the next day. There's a donor in the Bronx. And I accept the heart. I take Frank Torrey to the OR, and we do a heart transplant that finishes at dawn. And by the time it's literally dawn. It's like 6 in the morning when we finish, and the entire block is packed with cameras because it seems like it's a made-for-TV movie. Brother wins the 3rd game of the World Series. No one expected it. Managing brilliantly, brings his older brother. By the way, people don't know this, but Frank Torrey was Joe's older brother. Had won an MVP in the World Series before Joe, because Joe had never been to a World Series, and he was the one who saved the family because they had an abusive father. And so Frank was the one who threw the father out of the house, was a role model to Joe, who's obviously world famous manager as well as player. And so they won the next game, and it did cover the airways for a while, but it also changed people's perspective on heart transplants. They had thought of transplants as a palliative approach. Frank Torrey lived 22 years, and he didn't die from heart disease. And so it, like many other advances that we have made, have normalized recovery from illness. My hope, my prayer, and I think you're doing this, Mike, and I thank you enough for our entire nation. You are turning cancer into a chronic illness. You're actually curing it with the help of a lot of very bright people and some of the funding and research. And Mike makes all these great investments in pharmaceutical companies as almost charitable endeavors. But these advances are allowing many of us to seek wisdom and brightness in the world when sometimes there's darkness. And I went to do a Most Favored Nation drug announcement with the president a few months ago, and we did the announcement about how we're driving down prices, and someone asked about innovation, and would we curtail it if we dropped drug prices? And the president had very clearly said, we never want to compromise innovation. We just want fair prices, not low prices, fair prices. The same price here as they pay overseas. A few hours later, there was another executive order in the office, and 20 of these most beautiful, bright-eyed little kids came in. Everyone was a cancer survivor. And he signed the executive order to prioritize pediatric cancer treatment. And I looked at those kids, and when he asked me to say a few words, I said, this is an example of why a system works. You get the right price, a fair price, for the life-saving solutions. You don't hinder innovation at all, and you have people walking around who should not be here. And that's like putting a man in the moon for us. It's what we all aspire to. It's why most of us went into healthcare, and that is a part of the system we never want to compromise.
So let's take one question from the audience. Does anyone want to ask a question of Dr. Oz this morning?
It could be a personal health question about the person next to you. Oh, there we are.
That has brought a new cancer therapy, principally to glioblastoma patients, using a medical device rather than a pharmaceutical approach. And today at CMS, there is no pathway for reimbursement for medical technologies, because when the rules and legislation were put in, they assumed medical devices were canes and commodes and oxygen bottles. I was wondering, the administration in Trump 1 had established a rule that would fix this and ran out of time. And I'm just wondering if this is something that's on your radar screen.
Very much on my radar screen. I can't talk in too much detail about it, but I came out of the device industry. I wrote the patent for the mitral clip, the device to fix mitral valves. It took 15 years to get a device which, there was a New England Journal of Medicine article showing that it reduced mortality of heart failure in half at half the price. It's a pretty good trade-off. 15 years to get it through the FDA process. So I'm very aware, and it's a sensitive topic for that reason for me as well. We are looking at a way of working more closely with the FDA. As they identify breakthrough ideas, maybe we could partner with them earlier in the process so we could do what happens with pharmaceutical products, which is if the FDA approves them, they're automatically a CMS reimbursed. There are some caveats to this. Sometimes clinical trials are done for different patients. If you do clinical trials on a bunch of 40-year-olds, and I've got to prove something is meaningful clinically in elderly Medicare beneficiaries, I've got to match that. But there's a workflow on this. As you know, that Trump-era project was halted. A separate process was put in place. They're not working. We're not getting a lot of uptake from companies, and I think we can do better.
So one of the questions in closing, and there's a lot of concern that those companies are going overseas now for clinical trials. It's much easier. You can start them a lot faster, maybe as quick as 60 days. The cost is a fraction of the U.S. And our concern has been that those countries that are a leader in bioscience, and bioscience is agriculture, it's air, it's water, it's energy, that the U.S. is going to lose its leadership in bioscience. What can you do to assure that we keep that leadership here?
Well, first off, since I've been in the room when these conversations have happened, the president is laser focused on this. All of the factors you just brought up. And it's come about quite a bit in the news, interestingly, because of glyphosate, which is, and Secretary Kennedy spoke to this, I thought, beautifully in a post he put out on Sunday night. We have got to advance the technological approaches to problems that we have tolerated too long. When we have an approach to keeping our crops free of weeds that has, at least in court, not been faring so well, you have got to put a urgent message out there that we're interested in all the other ideas that have been floated over the last several decades, because farmers have been looking for better ways of raising crops. In the face of clinical trials that take years and years, with 1 in 20 drugs succeeding and a massive investment just to get to that point, it's evident that the system isn't functional. And as a result of that, the prices get jacked up because companies have to invest a lot more and take much more risk. So the FDA commissioner, who is superb, Marty McCary, and is tough, has made this a priority of his. He's looking at different ways of allowing hospital systems and healthcare systems to play a role in this process. And we have got to be able to accelerate the clinical trial process in this country, even for more advanced phases of trials, or we will lose this battle to China.
Last comment. For young people today like yourself, from graduating high school to going to college, to going to medical school, maybe getting a PhD, residency, internships, fellowships, there's a concern about what our system is today, and we might be losing our best and brightest who are quite concerned that there's not an opportunity after this investment of 10 or 15 years. What is your message to them?
Well, the message I gave to my kids, the youngest one of whom went to medical school at Columbia and is now an intern there, is that there is nothing in life I have found more fulfilling than looking at a person in the eyes, recognizing there's a problem, and making sure they know I'm there for them, and having them look back and acknowledge that. It is a unique opportunity that I hope many of you will have an opportunity in some capacity to experience in your lives, but if you're in the healthcare field, you get it every day. Which is why I highlight always, doctors do not leave medicine, nor do nurses or anybody else over the money. They leave because the job starts to suck. And so if we can make the job free of some of the hassles and headaches and coding and a bunch of stuff that doesn't really move the needle in terms of quality, and allow people to do what they want to do, which is to have that experience, that sacred moment where you're there for somebody else, people will flock to healthcare, they'll stay there. We're putting about over $200 million from the administration, matching governors, and going to train thousands of extra nurses, especially for rural America. We want those nurses to be in nursing homes, but we're going to have robots in nursing homes. We're going to have technologies that make the job a better job. So I think it's a great time to go into healthcare for that and many other reasons. And I am also optimistic that despite concerns over where we are vis-a-vis other countries, this remains the best place to follow your dreams if you want to be in the healthcare space, and it will remain so for the rest of our lives.
Thank you for joining us this morning, and thank you for serving.
God bless you.
Take care, guys.
So, Tony, can you join us now? So, as the NCI director, Tony was excited to know that Dr. Oz was the opening act for him at our meetings today. First, I'd like to thank you for serving. Thank you for joining us, not only on behalf of our attendees, but for patients and families everywhere. And so, as you know, it was 55 years ago. And we have in this room, across from the Treasury and the White House, the actual act that was signed in the room today to spur us on. And so it's been a long journey for all of us. 1 in 2 men in America get cancer, 1 in 3 women. You've got a lot of responsibility. It's 5 months, and we're about to hopefully ramp up our efforts in this area. So what reflections do you have when you think about the commitment 55 years ago? What have we achieved? How have we changed it? And is your view any different today than it was 5 months ago?
That's a lot to unpack. First, let me say that even 5 months is deceiving because the government was shut down for 2 of those months. With regard to how I felt 5 months ago versus now, I was an academic running a laboratory doing still some clinical work. I didn't know anything about the National Cancer Act. So anything I know about it now is brand new to me. But what I understand about it is it has a couple of real powers to it. One is it made a commitment to a specific disease or set of diseases at a national level. And I don't know that any country, certainly no country with remotely the sort of resources of the United States, had ever made a commitment like that. And I think it's telling that it was recognized how much cancer could affect people, but also we were starting to get an inkling that we could do things to actually impact the outcome of cancer patients. I'll say at a logistical level, it is immensely helpful to the National Cancer Institute. And the National Cancer Institute and the directors who've served over the years couldn't have gotten done what they have gotten done were it not for this statute. To be able to refer to actual direct statutory authority for what you're doing, for securing your budget, for doing the things that need to be done, is, as I've learned, something I was completely unaware of, but actually does offer some very useful power to get things going, to get things moving, and to clear impediments out of your way that wouldn't be possible were it not for this legislature. So I truly do believe that that is a piece of legislation that has affected our ability to focus our attention on cancer at a national level.
So before we get into how we're going to accelerate our efforts in making cancer a chronic, non-life-threatening disease, I would be remiss if I didn't ask you how those Winter Olympics were. Your daughter competed for the 2nd time in the Winter Olympics. How was the experience?
It was, so I got back, that's right, my daughter Julie is a short track speed skater. If you're not familiar with the sport, it's sort of like roller derby on ice. It's the one where you're on an Olympic-sized rink and there's somewhere between like 4 and 9 people all skating at the same time. And God help us if it's a relay and your daughter is involved because there's a lot of blades flashing around there. But my daughter did very well. She came out 16th in the world in the 500. She didn't expect a medal, but she actually skated really well. She just returned to the United States in the wee hours of this morning. I just got back to Washington on Sunday. And what I really need is another vacation after going on that, because it was one of the most exhausting experiences, just seeing your kid out there skating for your country. Really, I can't think of too many things I've been more nervous about in my lifetime. But it was a spectacular experience to meet other athletes from the United States, some from our childhoods, Bonnie Blair, Dorothy Hamill, they're all hanging out. You just get to see these people you saw on TV, but also to see the spirit of people who genuinely want to succeed not only for themselves, but also for their country. It was a very, I think, refreshing experience for me.
Okay, so I get even more excited when I'm with cancer researchers, by the way, Tony. So, what are the most promising areas that you see? We have 150 different opinions as to what the most promising areas are in the room today, for the most part. And we have asked people to submit, and we have a QR code that I mentioned to you. Instead of me passing out 10,000 pages here, and we have a simple QR code that you can get. But as we look ahead, what are the most promising areas you see?
I'll start with one. I imagine Karen may agree. I think immuno-oncology is something that is going to become increasingly useful in cancer. Of course, we already see the inklings of great success. So in cell-based immunotherapy, we can see originally children who most certainly would have died of their leukemia in short order, like a relapsed leukemia in short order, who were cured, absolutely cured, gone for good, living normal lives because they received a certain type of immunotherapy. In that case, it was CAR T therapy. That was a real wake-up call for me. I didn't work as that. I've always worked on the periphery of immuno-oncology. I worked on programmed cell death. And then I subsequently became interested in trying to figure out exactly how these immune cells are killing the cancer cells. And so I became more interested in it. But I've become more excited recently because different types of immunotherapies have shown impact, the first glimmers of impact, even in some really tough tumors. So we divide the sort of tumors that are relatively easy to kill, and leukemias are among them, and it's sometimes relatively easy to show some success in leukemia. Of course, we need to do better, but compare that with something like advanced solid tumors like pancreatic cancer, non-small cell lung cancer, brain cancers. They're way less sensitive to almost anything you do. But in the recent years, we started to see glimmers where even in these tough situations, we can see patients who have been rescued for what looked like certain death. Not enough of them and a lower percentage, but the fact that we can do it at all, I think should be very exciting. So when I think about this, I think the immune system is very complicated. And one of the challenges is how to test out. There's a lot of really smart people with very good hypotheses about how to improve immuno-oncology. So we're not just, say, rescuing 10% of people with advanced pancreatic cancer or whatever it might be, but we're rescuing 40, 50%. How do we do that? And there's a lot of good ideas. The immune system is so complex, though, is it's very hard to know whether your hypothesis is correct or not until you get all the way into a human being. So following that logic, what we need to be able to do is figure out ways to get to first-in-human trials more rapidly. And my vision is to see if we can find ways. These don't need to be large clinical trials because we're looking for big effect sizes. We're not looking at, a 1% benefit. The immune system is very sort of switch-like. If you get a great immune response, you should be able to see it. And I would like to work with, and different agencies, the FDA is certainly one of them, to see if we can speed first-in-human trials for some of these advanced immunotherapies. I know one thing I'm very involved in. I haven't talked to you about it yet, Karen, but you're probably aware of it, is cancer vaccines. So there's some very interesting early results in patients with advanced solid tumors where cancer vaccines appear to be effective in a significant percentage of people in preventing relapse. There's many diseases, I'll come back to pancreatic cancer, where if you get a resection of your tumor, and even if there's no evidence of disease, you're at very, very high risk of that returning. And when it returns, it's very hard to get rid of it. There are vaccines now that are giving us glimmers of light in not only that setting, but other settings of preventing relapse that I personally am excited about. So I'm trying out a new model. So working with the FNIH, the Foundation for the National Institute of Health, we convened a set of experts from around the country to give us their ideas about what can we do to, in the next 5 years, test some really critical hypotheses. And although the NCI will want to back this up with its own funding, to do it right, we're going to have develop some sort of a public-private partnership to generate the funds to actually do this right and do the first-in-human testing that's required. So this is, to me, something of a model of what I would like to do more of, which is sort of use our impatience to get first-in-human trials faster.
So today with us, we have many leaders in pharmaceutical, biotech, in addition to academic centers, members of Congress, philanthropists here. And so you're seeing a potential to give you a 1-minute story. Many years ago, more than 30, I visited the NCI. The director was taking me around. He told me that this was a promising program, but they lost funding for it. I asked him, how much is he said, it's a lot of money. I said, how much is a lot of money? He told me $250,000. So the next day, I sent him a check for $250,000 so they keep the program going. Then they told me they weren't equipped to cash a check at the NCI. I told them they should call another agency, the IRS. You send them a check. They seemed to accept it at that time. And about 6 months later, they accepted the check, but told me never do that again. So when you talk about these partnerships, if we think of receptors, how can we engage with the NCI? How can these different groups engage today, and that we see philanthropy playing a much larger role?
First, I would like to make crystal clear that we are well equipped at the NCI to receive any checks now that you would choose to write for us. And you can contact me directly if there are any hurdles whatsoever. I will hearken back to the FNIH, the Foundation for the NIH. That's what they're there for. They're a congressionally mandated organization, and they are there to do some of the things that the NCI can't do on its own. I'm still learning about what these limitations are, but there are limitations into the relationships that NCI can directly engage in with commercial entities, private entities, and so forth. But the FNIH is very good at organizing collaborations. It's already done this, but that's its job. And a lot of that we can do through the FNIH is working with companies, working with individuals, working with philanthropy together to solve a problem. And in fact, that's exactly what I want to use as as an initial test of this cancer vaccine project that I have in mind. But if that's successful, I view that as the first of many things, not only in immuno-oncology, but outside of immuno-oncology that I would like to test.
So that foundation didn't exist back then. I think it was
That's
an
correct.
outgrowth of learning how to cash a check. But let's talk about other areas. You've spoken about immunology, which is a very important, and we have many of the leaders in that area. And today at lunch, we're going to hear from both Jim Allison and Carl June, for example. One of the areas that increasingly has been focused on is early detection and also the role of your microbiome and what you eat, what you drink, etc. And this was not an area 30 years ago that the NCI was focused on it. Where do you see the area? How does prevention play into your thinking today at the NCI?
So Phil Castle leads one of our divisions, the Division of Cancer Prevention, and I think he has a great phrase, which is, the best cancer is the one you never get. And I think that the best cancer is the one you never get. And I think that it's undeniable that if you can prevent a cancer, you should do it. However, I think we're also realizing it's more difficult than you might immediately see. Those who might be familiar with the recent GRAIL results will see that. And detecting a cancer is not the same thing as preventing it. When you think about it, it's sort of a narrow window for preventive projects to work. You have to identify a cancer that, if detected, to have benefit from a screening program, preventive program, you have to identify a cancer that otherwise would have killed the patient if detected later. and you have to be able to detect a cancer that you're able to intervene on and do something about. And this turns out to be more challenging than we might immediately have thought about it. Just looking at it superficially, we think, well, of course, we want to just test everyone for everything and detect everything. But it turns out that there are real problems with that. Notwithstanding that, we do feel that prevention is a very important part of the NCI portfolio. We are developing a project right now that we are circulating around the HHS, where we actually want to start with a prevention program to test how well we can do this and start in the underserved areas. I think that we will have our best immediate impact if we go to the people who are already experiencing the lowest level of access to screening opportunities. And if we can show a benefit there, we can move it to larger areas. So this is something I think you'll hear more about over the next year. We do take prevention seriously, but I think we're also learning it's a little bit harder than we otherwise might have thought.
So Alice Walton's efforts here on rural health and to make sure we can provide that, and has been showing great leadership in the last year. But when we think about the clinician or the person treating the patient, maybe not at a leading cancer center, at one of our foundations, the Prostate Cancer Foundation, we have saw that with 13,000 urologists in America, how do we get that knowledge out to them? And we actually made a decision a few years ago to buy Euro Today. Gina Carruthers created, who's today the CEO of the Prostate Cancer Foundation. And last year, 6 or 6.5 million people went to that website to try to figure out what are the latest treatments for urologic cancers, so they could, one, treat their patients or be prepared for their patients today. How do you see both the dissemination of the most current information reaching the doctor who's treating people today?
So I think I'll first start, like at academic cancer centers, I don't think this is pretty much, that's part of your job. So I'll address and that's not so much of a problem. I think I'll address this more of the community oncologists who not only aren't in an academic center, but can't narrowly focus on, say, bladder cancer, but have to treat all the cancers all at once. I think the internet is a tremendous resource for this sort of thing, and there are freely available both governmental and non-governmental resources like the NCCN, where doctors can avail themselves of information. And this is also a place where AI is increasingly helpful. You can ask normal language queries and get reasonable answers out of AI, even regarding fairly sophisticated oncology questions. In addition, oncologists can inform themselves at the major meetings and keeping up with the literature, but it is a really big part of the job just to keep up. Just like Dr. Oz was saying, it's a very different world from when you had cisplatin and cyclophosphamide and they only work so-so, to have like, a couple hundred drugs, all of which are directed towards cancer, and how do you apply the right ones? I don't have a one-size-fits-all answer, but I would say this is something where AI and just improved electronic communication makes it much easier than it used to be.
So we put up the statistics showing the United States versus China over this part of this century, where the United States deaths per 100,000 have dropped. Their deaths have been increasing. The incidence has been increasing substantially. How do you see international cooperation today with the Cancer Center? What do you see as the role of the National Cancer Institute today, not just for the U.S., but for the world and that interaction?
First, I'd like to say that I would like to say that the decrease in mortality of roughly 30% since 1990 should be considered something of a victory lap for the NCI. The National Cancer Institute, we might not recognize it when one of your companies or other companies, Pfizer advertises, Lilly advertises in the Super Bowl some sort of cancer drug. That's great. That's how you provide it to people. It has to go through drug companies. But that started, in pretty much every case, that started with an NCI grant, maybe 10, 20, 30 years ago. That idea started with an NCI grant. So when we see cancer mortality go down like that, that is not a mistake. That is the American taxpayers' funding going to the NCI. And incidentally, that's a message I think we at the NCI need to do a better job of getting across to the American people, is that we are not sort of this faceless bureaucracy that doesn't use money wisely. We've accomplished our mission. We have a long way to go, but we have been performing our mission. With regard to disseminating it internationally, for the last 30 years, almost all the innovation in cancer, not all of it, but almost all the innovation has originated in the United States and then is sort of freely communicated to the rest of the world. So I think we've been doing an excellent job of getting better cancer care in Europe, just by the mere fact of getting it here first and then disseminating it. And drugs companies are, of course, multinational. But I would like to circle back to the issue of competition that you brought up with Dr. Oz. And we are, with regard to cancer, I'm very aware that we are losing out on especially early phase clinical trials being performed not only in China. You can sort of immediately see some advantages. If China wanted to expend, with its very centralized government, enormous resources, as they have chosen, to improve its biotech and early clinical trials sector, they're going to be able to do that in a way. Perhaps it's inefficient for the country as a whole, but it's going to be able to build up that sector, and that's what they've done. However, we are also seeing that a country like Australia is taking all of our early phase country in a fair way. I don't mean to taking like stealing, but how are they doing it? Well, we need to learn about this is actually an important project of mine, is to figure out what are they doing differently in these countries and why can't we do it? I think there's no one answer, but some of the answer is some of it we're doing to ourselves and does have to do with regulation. So we have to identify where these regulations are getting in the way of our initiating early phase clinical trials and fix that. And I think we're fortunate enough to have FDA and a leadership of the FDA that is well motivated to do this. But it goes well beyond that. And what I've identified is if you think about who's involved in this, well, there's biopharma, there's cancer centers, there's the patient advocates, there's individual oncologists, there's the regulators, there's the NCI. If you talk to just one or two of these people at a time, the fault lies with the people out of the room. And it doesn't matter who you talk to, that's the case. I think what I want to try to do is get all these people together, and the secretary is willing to help, get all these people together and convene them. And we're all very well motivated to solve this problem. Everyone wants to solve this problem. And I think there are readily available solutions to us. But we're right now in the process of identifying what are Australia and China doing differently, and how can we do that ourselves here in the U.S. And I think this is at least partially a fixable problem. We'll never be as cheap as China, and we will never have the population that China has. However, companies want to they need to do their testing, their clinical testing in the United States. And if they could skip that sort of preamble of going to China and then repeating in the United States, and we could make that cheaper, more efficient, and faster, then I think we would be able to re-import some of these clinical trials back to the U.S.
So when I look at some of our medical foundations, whereas we might have been funding primarily in the U.S. 20 years ago, today we are funding in 28 different countries, and Australia has brought great breakthroughs which have then been applied here. But the challenge we have, obviously, that you've touched on is how do we get clinical trials here quicker, at less cost, and getting coordination. Let me open it to the floor for some questions now. I'm sure we have some. Would anyone like to ask Tony any questions? So Karen, do you want to start? Aunt Margaret, do you want to start us off?
Yes. Hi. I want to know what your advice is to the young scientists right now and how NCI is looking at that issue, thinking about supporting them, and kind of what your vision is ahead.
So I spent the last 2 weeks in Milan watching my daughter skate with my other daughter, who is completing her PhD as part of her MD PhD program at Case. And I'm kept very closely in tune with the anxieties of the young scientists nowadays, I can tell you. I would say part of this is accurate communication. I'm somewhat dismayed to see the prevalent reports in all sorts of literature, including the major newspapers, major journals, about how the NCI and the NIH is cutting back on funding research. How many are surprised by the information to hear that last year, the NIH and the NCI spent more in extramural research dollars than at any time in its past? I don't think that message is getting across, and we need to get that message across that we are in no way backing away from the support of medical research, and we are not backing away from the support of early stage investigators, and the plain numbers support what I am saying right now. But unfortunately, there has been some inaccurate messaging, and I could say it didn't help that the government was shut down right at the time some of this was coming out. Part of my job is just to communicate accurately that there just is no evidence that we're pulling away. I hope in this fiscal year we're going to fund even more grants than we did last year. So we are absolutely committed to the young investigators. I will continue to say that. We absolutely need the young investigators to stay motivated. I want to also get the message, money aside, you young investigators, you have never had tools like this before. The tools we have for discovery are, exponentially more powerful than the ones that we had when I was just starting out. You have the chance to really make a difference, and this should also be exciting, I think, for young investigators, and we need to make that clear as well.
Nubar, Karen,
Yes.
introduce yourself.
Sure, Nubar. I'm Nubar Fain, Flagship Pioneering. You were talking about your daughter. I happen to have a son who just got a PhD from from Harvard, in immunology. So your former role building. And but as I sit here listening to it, I'm trying to think of his experience. For a year, his funding was cut off because he was at Harvard. He's been surrounded by an avalanche of scientific doubt about all sorts of aspects of the very science that he and others that were studying. And I think we're kind of facing a graver danger just than China, which is that there is a new generation of scientists who think that following science and making pioneering breakthroughs is not, in fact, the highest form of contribution they can make, because what they do is subject to fairly arbitrary doubt. So, I'm happy you took this role because you can do something about it. How can you, from your position, kind of counter-advocate for the validity of the scientific method and the fact that people have to debate science fact with science fact, not opinion?
Well, I'm not TR, and I'm not the president, but I do have a bully pulpit for cancer researchers, and I intend to use it. I think it's very important to communicate to researchers that the scientific method is healthy, and it needs to go beyond that, I think, to have its effect. And I do think we at the NCI need to do, and the NIH probably more generally, need to do a better job of connecting not only to scientists, but also to the American people more generally. I think we could do a much better job. I do think that the public health establishment in the United States is somewhat to blame. I'm afraid that during a lot of the controversies that have overwhelmed public health in the last 5-10 years, there has been a very dismissive, arrogant, and sometimes even insulting response to simple people who are not highly educated but have a question. Then they ask the question and they're derided rather than treated with respect. I want to treat questions coming from the American people with more respect and to explain scientific reasoning, not to deride, not to castigate, but rather to explain and inform. And I think we can do a much better job of that, and I personally am committed to doing that.
Karen, introduce yourself, please.
Thank you. Karen Knudsen, CEO of the Parker Institute. I couldn't agree more with everything that you said, and I violently agree with the concept about the promise of cancer vaccines. So as an organization that's, really future forward, making that a major priority of not just our cancer research funding, but also as an investor, our ability to capitalize companies that are moving to this cancer vaccine space and getting to that early phase clinical trial. What do you see in terms of the path forward, either from a logistic or political sense, about the ability of cancer vaccines to move forward into the regulatory space?
Karen, could you give your background prior to the Parker Institute for those watching online?
Sure, yes. I'm very proud to have led one of the major NCI-designated cancer centers, Sidney Kimmel Cancer Center at Jefferson Health, 16 hospital system, putting clinical trials into the community. across 2 states, and then after that, CEO of the American Cancer Society to transform that organization.
So Karen, I don't need to tell you this, but just I want to clarify the use of the word vaccine. So when we talk about infectious diseases, almost always you're employing a vaccine against a broad swath of people who are otherwise completely healthy, and you're trying to prevent them from getting some type of infection. Maybe it's measles, maybe it's COVID, maybe it's meningitis, or one of those. But you're treating a healthy population. Right. I know. I'm just sort of giving a little background to flesh it out, and I'll get there. So because of that, the safety characteristics of any vaccine, when you're giving it to millions of healthy people, has to be exquisitely good. If you're treating 1 million people or 100 million people with something, you can't have safety concerns about what you're doing, and your ability to absorb risk of that intervention is relatively low. It's a very different situation with cancer vaccines. In case of cancer vaccines, you're often talking about treating people who have probably far less than 1 year life expectancy. They are about to die of their cancer. And in these situations, one should be willing to be much more experimental, absorb much more risk, because that patient, in a way, has nothing to lose. I'm going through all this because I want to make it very clear that Secretary Kennedy recognizes this distinction very clearly. This whole project, I talk about these cancer vaccines, he's not only behind that, he helped initiate the whole thing. The whole conversation started in Senator Kennedy's conference room. So I am not concerned about the political backing for a cancer vaccine program because it is viewed very differently. I would also say, just biologically and medically, it's also just you're treating something rather than preventing something in a way. And if I had to turn back the clock, I would rename it something other than a cancer vaccine because it is so different, although there is some overlap in technology. So I am not concerned about that aspect of it moving forward. I think clinical trials where these have to be tested are expensive, and I look forward to talking to you and other people in this room, anyone who's interested, about helping us with our cancer vaccine initiative in the future.
Tony, I think in closing, this is a very important point. Many of us who are older remember people like Steve McQueen and others who went to other countries. And the idea that you're in end stage and we're going to protect you from taking something where you're going to die if it doesn't work. When I think of troops that we sent into war and battle who might be 19 years old, who have their whole life in front of them, we're very concerned about how to protect them. And I think this distinction you've made here is very important from the standpoint that it's essential to take risk when the person is at risk. And we're not going to move progress along without taking some risk from that standpoint. So let me conclude by thanking you for serving. Congratulations on your daughter representing us at the Winter Olympics. And we look forward to the opportunity that you've laid out here for cooperation with both for-profit, nonprofit organizations at the NCI. And thank you again for joining us.
Great. Thank you for inviting me.
All right. Thank you so much to Dr. Latai. Thank you, Mike, for that wonderful conversation. I would like to welcome to the stage Dr. Andy von Eschenbach, former FDA Commissioner and NCI Director, and Congresswoman Diana DeGette. She served as a chief architect for the landmark 21st Century Cures Act. They will reflect on that legislation and then talk about what's next, including a potential Cures 2.0. So welcome to the stage. Thank you.
Good morning. I am thrilled to be here with one of my heroes in Congress. And for the audience's benefit, I was quoted last night as saying that the National Cancer Act of 1971 was one of the most transformational pieces of legislation in the 20th century. But I also believe that the Cures Act is one of the most transformational pieces of legislation in the 21st century, and I'm thrilled that we have one of the architects of that transformational legislation with us this morning, because Congresswoman DeGette and Fred Upton labored incessantly to bring that transformational piece of legislation about. So many don't know, as I observed, that you spent more than a year traveling around the country, engaging in meetings like this, small and large, as you were formulating and conceiving the parts and pieces of that legislation. Tell us a little bit about that, what you learned in those interactions and those dialogues, and how this audience, made up of leaders of a cross-section, can engage and participate in that process even more effectively.
Well, thanks. Thanks for having me. And I don't really need to say that, Andy, because many of the people here were instrumental in helping develop 21st century cures. And what happened was Fred Upton, who, my dear friend, who I hear from on a regular basis, even now that he's retired, he was the chairman of the Energy and Commerce Committee, and he decided we need to update the way we do biomedical research at the NIH, and then the way we're going to deliver the cures to patients. And so he knew about my reputation for working in a bipartisan way, so he plucked me out of the minions of the Energy and Commerce membership and asked if I would do it with him, and I was delighted. And what we decided to do, and I always have felt this way, if you're really trying to fix it, by the way, I think this is a little unique in Congress sometimes, not to criticize my colleagues, but, we could do a bill that says 21st century cures and just have it be a messaging bill, right? But Fred and I really wanted to address some of these persistent issues that we had in cancer research and so many other areas. And so the first thing we did, I'll never forget this, we went over and met with Francis Collins, who I see his smiling face right there. And Fred and I, Francis will remember this too, we were sitting in his office, and Fred said, Francis, what do you urgently need to have fixed? And he said, well, I'd really like my young researchers to be able to go to conferences. If you will remember in those days, that was right after some researchers had gone to some conference. There was a scandal. So then all researchers were banned from going to conferences. And I said, Francis, we will fix that. But if that's all we do, we will have failed. And so, as you say, we spent the next 2 years going around to meetings like this, but also meeting with patients, doing roundtables in each other's districts. I went to Fred's district, he went to my district, and we really got a collaboration of people who said, this is what we need to do to fix and streamline biomedical research in this country. And then we put that bill together. We worked hard to get collaboration among our colleagues. It was not easy, especially since the Senate was involved, but that's a different story for a different day. And then we were able to somehow pass it in the waning hours, the last piece of legislation that President Obama signed. And P.S., that was 10 years ago now, so I think it's time for an update.
There we go. There we go. So thank you for that lead-in, because that was my next question. It's time for an update. And
We're going to go on the road with this. So.
You've talked about Cures 2.0. There were things that Cures accomplished, and by the way, most people know overwhelmingly in a bipartisan effort. You had 392 votes in the House, and there were only 6 dissenters in the Senate. So in a bipartisan way...
We have their names.
You have their names.
Yeah.
In a bipartisan way going forward, working again with this community, what do you think needs to be accomplished now? What maybe, looking back at what you did accomplish in Cures, could be amplified, or what needs to be added to that? You did things that introduced the idea at FDA that we should use real-world evidence and patient-reported outcomes. We've heard today about implementing AI to even take that further. So if we're going to be the architects collectively again. What would you like to see accomplished in 2.0?
So in the last Congress, at the very end, I once again collaborated with my friend and colleague Larry Bouchon, who now has also retired. I hope it's not me, but Larry now has retired. What we did is we tried to put together Cures 2.0, trying to pull some of these new ideas in, dealing with these updates. And frankly, then the election happened. But Larry's and my idea was we would have it all ready to go, and then I would find a new Republican partner and we would move it through. But this year, frankly, has been so, in case you haven't noticed, it's been so chaotic in the U.S. Congress that it has been very difficult to mount a real bipartisan effort like that. I don't give up. But I think that the prospects for doing it this year are waning. I do have several Republicans in the House, and of course my stalwarts in the Senate, guys like Senator Cassidy and others, who do want to work on it, but we're kind of losing our runway to be able to do it this year. But what we will need to do is we will need to go around to groups like this one and patient advocacy groups and other groups to see what can we do to modernize and improve all of our biomedical research and then systems delivery. One of the things we're trying to look at in our draft is improvement of CMS and how we can, with all of these fantastic new cures and treatments, how can we make sure that we can make those cures and treatments available to everybody, not just with resources, and how can we make them more affordable? And how can we incentivize companies and researchers to actually look at these? I think about this, one of my other jobs, I'm the co-chair of the Diabetes Caucus, and I in fact got involved in all of this, working on the stem cell bill with Mike Castle many, many years ago. And we're on the cusp now of being able to cure type 1 diabetes. And so the question is, how do we push that through, and how do we make it accessible to the millions of people who are affected by this?
I'm glad you brought that into play, because the National Cancer Act of 1971 drove an unbelievable transformation in cancer, which led to this biomedical revolution in which we're being able to see what we accomplished in cancer now can be applied to all diseases, understanding fundamental genetic, molecular, and cellular mechanisms. So as you approach 2.0, and by the way, recruit everyone in this room to help recruit your colleagues as well, how do you see us disseminating what we've learned in oncology to these other broader diseases like diabetes as you shape this next legislation?
Well, one thing that I think we need to look at in a really rigorous way is NIH still structured in a way that is going to help us do that research across the spectrum of the institutes and with everything, because we're now learning that there's so many impacts of research. And I was thinking the other day, I was involved when we did the NIH restructuring in 2006. Now, that's 20 years ago we did that. And former Chair Kathy McMorris Rogers sort of tried to do a Hail Mary pass right before she retired to do that. That's not the way you look at an institution like that. So I think that's another thing we need to do maybe in the next Congress, is put together a bipartisan, bicameral group to look at, do we need to do some structural changes to NIH to be able to do this type of research that we need to do. I have to say one more thing, though, because I don't think we can sugarcoat this. When I talk about Cures 2.0, the other thing we have to have, and there was a question over here about, Margaret asked the question about young researchers, and then someone else talked about the mood of the researchers right now. We cannot sugarcoat or underestimate the impact of what the Trump administration has tried to do on our preeminent research institutions. The cuts that DOGE tried to make last year, most of which were reversed by the courts, have led to, I mean, most of the money was gradually refunded to these grants, but like in Colorado at Anschutz Medical Center, some of them are still trying to get their research. Some of them had to shut down their labs because they couldn't get the money back in time. If you talk about FDA, the lack of public confidence in FDA, I'm really happy that there are efforts to rebuild that now. But when you look at Cures 2.0, we're going to have to be looking at revitalizing some of our institutions that were in pretty good shape before last year. And I know I win all these bipartisanship awards. I try to be bipartisan, but you also have to call it like you see it. Like with the young researchers, when the average number of NCI grants went down that were approved went down from 14% to 9%, which is what happened last year, that's going to impact young researchers. Mm-hmm. So.
Well, you're touching on a theme that's already come up a couple of times, and that is how do we invest, how do we commit to maintain the leadership that the United States has had because of the investments that we've made over time. And there are some that I've heard that figured, well, maybe it is time for the rest of the world to foot the bill, to take the lead, and we've done our part. But to your point, if we can recognize that because of our investments across that spectrum of discovery, development, and delivery, we have in discovery the world's leading academic institutions for research. In development, we have world-leading pharmaceutical and biotechnology industries. And in delivery, just take the cancer centers as one example. We have all parts and pieces. Right. So in 2.0, whether we're cross-cutting across the NIH's divisions or whether we're cross-cutting with all of our institutions, how can legislation help drive that, and how do the people in this room participate in shaping that?
Well, you're right. We have always been the gold standard in the world for biomedical research, and I'm so proud of that, and we need to keep that position in the world. I've traveled to Japan and Sweden, and I've traveled all around meeting with researchers who are working with U.S. researchers. So not only are we the gold standard, but we also are the engine behind research around the world. And I think I would posit that we want to keep it that way, not only for the people who then develop the research, the biomedical companies, pharmaceutical companies, and so on, but also to keep those standards very, very high. And so part of what we have seen lately is a lack of certainty in our international partners in their ability to work with the U.S. And I think that's part of what we need to really make an effort to reestablish in an urgent way.
Maybe we can take a question or two from the audience before we close. And it's difficult for me to see with the lights, but please just go ahead. A question for a Congresswoman? Michael, you go.
Wonderful to see you this morning.
Thank you.
Do you feel in the House today that there's the same energy for medical research there was as we all worked on this a decade ago?
I feel that there is strong bipartisan commitment to the research. I talk with my colleagues on both sides of the aisle about this, and I actually think with all the chaos that we've had the last year, there's a hunger to get back to some kind of regular order. My evidence for this will be the budget or the appropriations bills that we just passed, that were just signed into law, where the Trump administration proposed cutting NIH by 40%, and then Congress, on a bipartisan, bicameral way, actually increased the budget for the National Cancer Institute. And so I do think there's a hunger to both innovate and to fix the legislation and to upgrade it, but also to fund it. And I think that's good news.
Well, thank you so much for your continued leadership, and we're all indebted to you, not only for the Cures Act, but all the other things you've done on our behalf.
Thank you so much, and thank you for the work you do.
Yeah, thank you. That was excellent. Thank you. Well, thank you so much to Diana DeGette. Thank you, Andy, for that wonderful fireside chat. We will now have our opening panel session that will be moderated by Greg Simon. It will look at the next decade of defeating cancer and the vision for what's possible. Greg Simon needs no introduction. He served as the former executive director of Faster Cures as well as on our board. So, Greg, over to you.
Good morning, everybody. Before we get started on the actual panel, there are so many people here, including these three people, who have devoted their lives to public service. There's so many other heroes I see out in the audience who've done that too. Lee Hood, Francis Collins, many others. Can we give them some applause at the beginning of this panel? Now, I used to think being a moderator was a form of art. But I've learned to my dismay that it's really just a form of prompt engineering, which I have learned a lot about in the last month. And I realize now it's not an art, it's a science. So let's get going. We've had a lot of discussions this morning. I think it's pretty clear that we have an immigration problem in America. Dr. Oz is a citizen of the U.S. and Turkey. Dr. Makari was born in Britain. Dr. Jay Bhattacharya is running the NIH. Vinay Prasad is at Cedar. We've got a lot of immigrants running our healthcare system, and I think it's great. But let's get down to cancer first. Nixon started the war on cancer with no soldiers, no weapons, not really even any good battlegrounds, and we have come a long way in that. I'm a survivor. I'm sure many of you are too. But I want to start with Cliff, CEO of ASCO, and talk about what you've been doing to balance the need for access with the need for using AI in the way we do everything in healthcare, and cancer in particular.
Well, thank you very much. Before I start to answer that question, just a little bit of context. ASCO is a professional society, so I'm representing the clinicians and researchers who study and treat cancer and are at the bridge between basic science from the lab and clinical application and the advances that we're so desperate to see. It's important that I frame this in this way. ASCO is unlike most professional societies because we are not a single discipline and we are not just American despite our name. 40% of our members are outside of the US. 40% of our members are not medical oncologists, although we are often seen as speaking for the medical oncology community. In terms of the progress that we've made, and our theme today is where we're going to be in 2035 or how we're going to get there, and that's what ties into your question. In terms of the progress that we've made, I just want to remind everybody of the remarkable journey. When I was in high school, the first boards for medical oncology were administered. There was no board exam because there was no specialty until then. About a year after the founding of, or the expansion of the NCI under the act that we're celebrating here. We've gone from an era where you could write all of the drugs that were active in cancer on one side of one sheet of paper to a world now where you get multiple drugs per week almost being delivered into our community. And that's what you're really asking about. How are we going to get that knowledge out into this diverse community, not just in the US, but around the world, and with varying levels of training, skill, and experience? And that's, I think, where we can make a profound difference. So obviously, the revolution of our era now is AI, and it's a buzzword. We do not have, as a professional society, the resources to develop tools, to invest the literally billions of dollars that it takes, I think, to stand up useful, trustworthy programs. So we have to partner. And we have been extremely fortunate in that regard to have a close collaboration with Google, specifically Google Cloud. We heard about that last night. And it's been in 2 phases, aimed to bring our whole community along and accelerate their adoption and comfort with this space. First, all of our guidelines were converted into an accessible platform using a chatbot type interface. And I have to say this was a stopgap because I believe that the world will not just go to open evidence and other specific services, but sooner than later, just go right to the commercial, the big 3 AI tools for much of this. But our community is conservative. Answers have to be trustworthy. So we built a tool that relied solely on our expert vetted guidelines and highlights them and exposes the core source material to the clinicians so that they can trust the answer. I think it'll be dead before too long because nobody's going to interrupt their workflow to go to our tool. They're going to get it elsewhere. Second thing is with AI, we are converting all of our guidelines by the end of this year, we hope. I don't know if we'll make it, but that's our aspiration, into what are called living or dynamic guidelines, constantly updated on a nearly daily basis so that no longer will you have to wonder whether the guideline you're reading is 1, 2, 3, 4 years out of date. And then I'll just close by saying, going forward, I think the frictionless interaction, the agentic AI that we've already heard described this morning, that everybody's going to expect in all of their daily lives, our clinical community, our research community is going to absolutely expect the same experience in the world of medicine. And remember, we're still the world's largest users of faxes. So this is not a community that has accelerated historically into new technology. How are we going to make that happen? So our current collaboration with Google Cloud, which is due to be delivered this summer, is to open or to invert the entire web experience through which members access all of our content and services and make it into a full AI agentic experience, pushing tools out to our community. I'll close by saying I don't believe any of our members will be relying on us for that in the long term. We are the bridge to get them into that future. I think it's going to be ubiquitous and universal. I want to just say one last thing, I'm sorry, and I'll shut up. But the key thing to point out here is for all of the basic science advances that Mike has helped make happen, that so many in this room have contributed to, that we're all so excited about, it's important to remember that there is an estimated 20% improvement in overall survival for cancer available to us if we simply deliver current standard therapies as we know them. That's the gap that we can fill almost overnight if we do this right. And it's the first quick step towards improved survival for our patients with cancer.
Thank you. I got a question later. Karen, you've been at Jefferson Cancer Center, then you had a fabulously successful time at the American Cancer Society, which you left, the largest non-government funder of cancer research, and you left to go to Sean Parker's Immunotherapy Institute. Does that say something about where you think cancer progress is going to come from?
It definitely does, but I also think it talks about trying to not just solve for the science, but solve for systemic issues that prevent science from getting to people. So, the reason that I made that move is because I truly believe 2 things. One, immuno-oncology is going to be like saying telebanking in the next 5 years, right? All cancer therapies are going to have an immunology route. Everything from cell-based therapy to vaccines that we just talked about, to new implementation of ways to deploy checkpoint inhibitors to prevent recurrence. We're seeing exciting results there. But also from just the way that we deliver standard chemotherapy and radiation therapy, will be rooted in an immune component, and we're already seeing that. and antibody drug conjugates and radioligands. Basically, our knowledge of immunology is changing everything and really providing cures. We are curing cancers, and we will be poised to cure more. So being part of the leader of that, our organization leading that movement is something we feel very strongly about. But we also feel very strongly about a second premise. The science is not enough. We need to move the science off the laboratory floor and into patient testing. And there are gaps we didn't talk about today. How is it that a good idea finds resourcing to get to the point where that early phase 1 clinical trial can actually happen? Who is going to de-risk the science? And that really is our role. So we not only fund cancer research, but we also follow it, curate the IP, actually embed in the technology transfer offices of all of our Parker Institute sites so that we can realize the value of what's actually happening, not just with what one investigator does at Dana-Farber, but how that might connect to what Carl June is doing at University of Pennsylvania or what Jim or Pam are doing in Texas. That's the way we work. And then we either out-license that technology or we have to become an investor ourselves and start early stage companies. We have 17 companies in our portfolio right now. We as an investor are not small. In this stealth mode of the Parker Institute, over the last 9 years, we've invested more than $425 million in solving for this, to getting science over into patient testing. And investors, some of whom are in the room, have followed. So more than $4 billion raised there, several great exits of things which are now standard therapeutics, and many more coming. There are not enough organizations, I think, or public-private partnerships that are getting that science off the lab floor and into patient testing. And so our commitment, what success looks like for us, is accelerating and developing the next phase of curative cancer therapies. That's our lane. But reducing that time from an observation to FDA approval, which right now stands in the cancer space at 10 to 15 years. So success for us looks like collapsing that timeline, and I'm very thankful for all the key stakeholders in joining with us to do it.
Thank you very much. Mark, as you all know, is the director of the Duke Margolis Institute at Duke, otherwise known as Mark's Brain. And Duke will soon be known as the McClellan Duke Institute. Mark, you have been an architect of so much of our system in both Democratic and Republican administrations. You're widely respected. You were the architect of Medicare Part D. Now we have this issue of curative drugs costing 6 and 7 figures a year. If you were redoing Part D, how would you change it today? And please feel free in that answer to talk about what you're working on today to address this tsunami coming at us.
Yeah, thanks, Greg. And fortunately, the Margolis Institute is not Mark's Brain. The great thing about Duke is we have some tremendous researchers in cancer, clinical trials, many other areas, and a lot of infrastructure included based here in DC that the Institute has made possible for working closely with FDA, CMS, other agencies, including on issues like the ones that you're talking about, drug pricing, innovative approaches to preclinical and clinical trial testing. So this is an amazing time for cancer, and we are trying to spend more of our efforts in collaboration with Faster Cures and other groups to help make sure that the developments that you've just been talking about do translate to patients. If you think about putting together what Cliff and Karen just described, we're heading to a new era for cancer treatment that is much more individualized, that probably is going to rely on cell and gene therapies more heavily, as well as traditional tools and a lot more advanced diagnostics. Cliff and I have been talking about this more lately, and that's another big area for much more personalization, both in treatment and in prevention earlier. And our drug benefit and much of our healthcare delivery is not well designed for that. It's designed for covering particular drugs with particular indications. I was interested to hear Cliff say how fast the guidelines with NCCN are going to be changing. I'm sorry, ASCO I meant. Thank you. And I'm just trying to think through how that's going to play out in terms of coverage expectations, coverage on the label, and the like. I'd say that a big thing that we're seeing now, and Dr. Oz talked about this a little bit earlier, is moving away from thinking about individual treatments, visits, things like that on a fee-for-service basis, and thinking about much more truly person-centered coverage supported by AI that goes beyond what people are doing now, which is really helpful and empowering for patients in terms of what they care most about today, access and affordability. How can I easily get affordably the treatments that I need? And the AI tools have been tremendous for that, but I think we're just seeing the beginning of it. Dr. Oz announced last night a new CMS app store that's opening with beneficiary-facing apps that have been reviewed by Digital Medicine Society that are going to be paid for using the first ever CMS approach to treating apps as Part B providers. And that payment system is not going to be based on the volume of services, you know, how often people go to the app or go to the web and use it. It's going to be based mainly on how much those apps not only engage people consistently, but reduce measurable and important health risks. So this is not starting with cancer. It's starting with cardio, kidney, metabolic disease. It's starting with musculoskeletal conditions. It's starting with behavioral conditions that are not too serious and where it seems like big problems of access and where, at least with clinician oversight and monitoring outcomes and safety, these apps could make a difference. But they will be tracking the data that's most relevant for patients. So we have well-defined risk factors for all of those conditions. We have well-defined, often patient-reported outcome measures like improvements in functional status or mood that should be today the basis for payment, not just volume and not just, you know, discount from list prices. And that's going to be starting in Medicare this year. I haven't seen this whole concept really applied yet to the cancer space. You know, the conditions that are in this new sort of person-centered, person-empowering approach are really focusing on the other major chronic disease burdens facing Americans. So 70%, I think, of beneficiaries have those kinds of conditions that I just described. Another big share, though, have cancer risks, and I don't think we're yet taking what's coming in terms of personalized therapies and personalized diagnostics and reframing it in terms of what AI can really do, especially if you pay for it based on the results that it actually delivers for people in the community, to make a hopefully transformational change over the next decade in how cancer innovation, like all the stuff you're doing, if we try to pay for that the traditional way, you know, kind of traditional clinical trials, that's going to take a while. If we try to pay for it in kind of a new way, FDA just this week, for example, announced, I know something that Rick had been working on, is called plausible mechanism pathway for single gene allele defects, to point out that there are related kinds of treatments, say cell therapies in the future, that aren't exactly the same in each individual patient based on their particular genomic profile, but are similar enough that we can probably learn, if we're intentional about it, how safe they are, how effective they are, even if they're only being used for treatment for a few patients. Combine that with better post-market monitoring and the kind of more personalized steps that I've just described, you got a very different model for bringing the products that you're developing into actual use at a more sustainable and impactful cost.
Great, thank you. Karen, can you give an example of how you have de-risked some major breakthrough at the Parker Institute?
Sure. Let me give you a recent one. So one of our more recent portfolio companies that just came out of stealth mode is one called Dispatch Bio. Dispatch Bio is a perfect use case for the Parker Institute. So born at one of our scientific retreats from 3 different investigators' ideas. The whole concept is, can you actually use viral infection to, in a cancer-specific way, decorate the surface of a cancer cell with proteins that make it amenable to an off-the-shelf therapeutic or an off-the-shelf agent? In fact, Carl is one of the founders of Dispatch Bio. So it was one of his discoveries that got connected with 2 others. So the way that this actually worked was to not only form that company, it's Parker Institute Build, but to bring a syndicate with us and other investors to come along so we could get to the point of patient testing still and even in stealth mode, to show that you actually could get to that first step. You could actually do the viral infection, that you could actually paint the cancer cell, and that that signal was durable 100 plus days post-infection. So all of that happened, and we needed to de-risk the science along the way. We don't find our founders in the wild, right? We've been seeing the science from the beginning. So we've developed a very good reputation in the investment community, and we have consistent co-investors that come along with us to get to this point. That was a great moment in time just before JP Morgan earlier this year to lift Dispatch Bio out of the stealth mode that it was in. Very successful oversubscribed Series A immediately thereafter, and the IND to now do this, to get to this next point. And if you follow the science of Dispatch, this can solve for a lot of the things that we were just talking about in some of the, the cost, accessibility in low resource areas. If you're not looking for a neoantigen or something that's unique to a cancer cell that arises as a result of it being a cancer cell, but rather forcing that event, now what can you do? Off-the-shelf imaging, off-the-shelf cell-based therapy, off-the-shelf antibody-directed conjugates, off-the-shelf radioligands. These are the kinds of things that are possible. And so where we struggle is you can't unsee it when you see those discoveries, and when you see them, but you can't get them to the point of being capitalized and actually tested in a way that patients could benefit. That's where we see really the struggle. So we're trying to solve as much as we can as an investor. We're trying to solve for the dearth of clinician scientists in the US by partnering with ASCO. We just lifted up this year our first ever jointly funded ASCO and Parker Institute Early Career Physician Scientist Award that will happen every year, no matter what happens in the world. So, we're trying to solve for these, but we want it, for every Dispatch Bio, there are 10 more that we didn't get funding for. And so that's where our next phase will be.
Incredible. That's incredible. Cliff, the dean of the new Alice Walton Medical School is in the audience in my home state of Arkansas. My hometown, 20,000 people, didn't have any cancer doctors in 2001 when my dad got diagnosed. They don't have any today. They have to go to Memphis or they come to you. How is what you're doing with AI and the ground shot that you talk about of making things accessible and accurate, how is that going to change medical school training for the next generation, especially if they end up doing a residency in Arkansas, which doesn't have a lot of the major tools that the major cancer centers have? They have many in Little Rock, especially in melanoma. But how are we going to help rural America with your plan?
So this is a practical challenge, and there are a number of green shoots, little experiments already that try to address it. For example, the number of medical oncologists in the United States right now is pretty flat. It's in the neighborhood of 14,000, 15,000 practitioners total. Population not only continues to grow, but it also has aged, and the obesity challenge that we've spoken about already this morning directly adds ultimately to the cancer burden. I'm optimistic that GLP-1s will reduce that, but that's going to take years to decades to actually play out. So the challenge of geographically accessible care is unfortunately, I think, going to remain. Yeah. So then the question is, are there technologies that can fill the gap? Before we get to AI, there's actually something simpler. We just saw an extension of the telemedicine special coverage provision for another 2 years. Ultimately, telemedicine brought in during the pandemic has been a huge boon to a lot of patients in rural America who can now access expert care at a distance over state lines and so forth. That's a low-tech way of addressing this. We have run now for about 5 years a demonstration project in Montana where a hub site, which is not what you would call a major mecca, but a site that has a local cancer program, partners with a rural site that's a couple hundred miles away where family docs and nurse practitioners and PAs are guided in administering care prescribed at the hub. And I think that's a model that has broad global potential application. We're proving that it's not only viable and feasible, but it's sustainable financially, which ultimately is a requirement. So I think that's the second way. I'll just close by saying you can't talk about the future without considering again the contribution of the AI tools. And you asked how we're going to train students. I'll just back away and say I have a very different vision perhaps for what's going to be by 2035. So if you have a modern car today, you have the sense that you're driving the car. However, there is AI running all the time in that car, or at least what you should call AI. Drift out of the lane, the car nudges you back. If you want to go over the lane, you have to fight it to do that. Kid runs out chasing a ball, most cars will auto brake nowadays, right? I think clinical practice is going to resemble that. You're going to be working in the electronic medical record wherever you are. You're going to be perceiving yourself to have a degree of autonomy. But when you try to drift beyond what is increasingly recognized as appropriate care, both by our guidelines and millions of patient experiences now recorded, you're going to be nudged back into your lane. I think that's going to allow a lot of clinicians to do a much more consistent and better job in the long run. And they won't always even know that they're in an AI environment, is my point.
Yeah, that's a great answer. Okay, 2 lightning round questions. Number 1, and I'm going to start with you, Mark. We hear a lot about the fact that we spend so much more money and have so many worse outcomes than other Western nations in particular. Clearly, the United States doesn't suffer from a lack of science, for a lack of research, for a lack of innovation. But the first big, beautiful bill put the medical establishment and science research establishment on the Titanic. A lot of that funding through efforts of some heroic people in Congress is now on a lifeboat, but it ain't on shore yet. If you look at our outcomes, and you can't blame science for that, it's the system. And now with the system under increasing strain with the budget, if there was one thing we're doing that we could stop doing to make the system better, what would that be?
I'm not sure there's one thing. I do think that one thing that the system is clearly failing in, and heading into the next election and beyond, is going to be front and center. It's access and affordability for needed care. And you all have talked about that. And there may be a couple of ways to get there. In the short term, we could try, regulating prices and reduce payments to the cancer specialists and so forth. That hasn't really worked. It hasn't done a good job. And we've seen hospital margins decline. HR1, OBB3 is going to have bigger impacts on exactly those more rural and stretched hospitals that Cliff was talking about in their Montana ASCO pilot. That is a basis for resilience too. Those systems are not going to be able to staff up, hire new oncologists, deliver better preventive care for cancer, engage their patients. Those are going to be the places that we're either going to see continued increasing gaps. If you look at the urban-rural differences, underserved, well-served communities, those differences in outcomes, screening, cancer outcomes, et cetera, are getting worse. And that is only going to change if we adopt some of the really innovative models like Cliff was just describing. There is an opportunity to do that. HR1, for all of its huge reductions in Medicaid payment, included a lot of funding for states like Montana to implement transformational models. That bill was passed really fast, so it's kind of in the ready, fire, aim stage of people now figuring out what to do about it. I've seen a lot of innovative ideas around preventive care, specialists backing up at hubs, backing up community-based, tech-enabled care models. I haven't seen as much of that in the cancer space as in, cardiometabolic disease, musculoskeletal, some of these other conditions. And I think that's a really urgent opportunity. So that's not one thing to fix, but it is one opportunity to leverage technology, the new ideas that we've been talking about here, and some funding right now to implement new models, because we just really need them right now.
Karen, what's yours?
Lightning round. Stop throwing up barriers to prevention and earlier detection. I have this conversation with CEOs all the time, as cancer has now become the #1 cost of healthcare for all mid and large size self-insured organizations. And the math is very simple. The cost of care and outcomes are better when someone's diagnosed with stage 1 colorectal cancer versus the 4 times cost of someone diagnosed with stage 4. So there are always going to be people who develop a cancer that's complex, that's going to need a potentially curative but expensive therapy. Limit that number by getting more patients into prevention and early detection.
Great. Love that. Cliff?
Standardize the delivery of high quality, evidence based care
Everywhere.
everywhere.
Okay.
All the time.
Okay, now, last question. So, war on cancer. When I was asked to do the moonshot, a lot of people said, please don't use war as a metaphor in cancer. It puts patients in a bad situation if they lose the war. People want to fight, fight, fight. Sometimes we find out that fighting the cancer rather than containing the cancer makes it worse. What should we call the next 50 years of our work on cancer if it's not going to be the war on cancer? Cliff, start with you.
So I also appreciate the dropping the war metaphor because, of course, patients don't choose to be combatants, and not everybody is comfortable with that. I actually think that's maybe not even the right question. This is inevitable scientific human progress that we're making here. I don't know that what name for it is going to, what we call it is going to be important. I think the critical thing is our shared commitment.
Karen?
Yeah, I'm probably the wrong person to ask this question because I came up from a military family. So I'm all about the war on cancer. And from my perspective, we're winning. So I may want to be an outlier here. But the bottom line is, where I think we need to focus is on something you heard from the NCI director earlier today. Science is improving health. And science is curing cancers in this country, and we are poised to do more, full stop.
Mark?
Agree with not the war. I'm not the marketing person either, but it really feels like we're in a time where empowering patients is really important, where people are feeling like they can't get access, they can't afford care, the technologies, the missed opportunities to apply evidence-based practice that are going to become exponentially more complex if we don't center care more around people and leverage technology and everything else that this group can bring together to do that. Empowering people have a right or need more fight it and support for them to get the care that they need as easily and affordably as possible.
He's still talking about fighting. I just want to point that out.
I didn't say war, though.
One short question. Who wants you, sir?
Foundation. I have a response to your question. I think I was asked by King Charles to actually address that question at a conference in England last year. I think we need to switch from the war against cancer to the era of healing the patient, and that'll actually be appropriate to immunotherapy and both micro and macro environmental treatments, and also embraced the idea of environment, diet, and lifestyle.
Thank you very much. Okay. Thank our panel. Thank you all.
All right. Hopefully, is this on? All right. Hopefully you can hear me. Well, wonderful to be with you, Senator Capito, on this fireside chat conversation. I think we're celebrating Duke today. I'm also a Duke alum, as was Mark just mentioned just a few minutes ago. You have spent just tireless energy focused not only on cancer, but on Alzheimer's, on funding for science, and for all of these agencies that really have, as we've talked about throughout the course of this event so far, led the world in scientific discovery. We have saved millions of lives, not only here in the US, but truly, in fact, around the world. So what I wanted to start with in this conversation is around science funding. I think first, as was mentioned in the earlier discussions, we do ought to celebrate the fact that Congress really came back and championed high levels of funding for NIH, for FDA, and across NSF, et cetera. Can you just walk us through a little bit of what that process was like in Congress after you received the president's budget that initially suggested cutting NIH, for example, by 40%? Congress really had a strong response to that.
Well, thank you, Esther, and I want to thank the Milken Institute for having me here today, and all of you for the heroic research that you do every day to save lives and make things better for many of the people that I love and that all of you all love. So I chair the subcommittee on the Appropriations Committee, which deals with health, education, and labor. It's a massive bill. It's the second largest bill next to the Department of War. And it is a passion for me, and I see Francis Collins out there, so I mean, he could probably get up here and give us the lowdown here. So here's what happened. We got the new administration, new areas of emphasis, and the administration came in with a drastic cut to NIH, shockingly so. I visited NIH. I have taken a great interest in NIH and in the institutes, and particularly in the areas of substance abuse and Alzheimer's, but also cancer, because of the state I live in has some of the highest cancer statistics in the country. And so we just went to work, and I said, this can't be. I mean, we're not going to let this happen. And many visitors into my office nationally, institutions, researchers, hospitals, universities, making the case of how absolutely essentially important the NIH research is across the country. Something I already knew, but reinforcement is always, and repetitiveness is a good thing for somebody like me and those of us who have a lot coming at us in different areas. So basically, I just said we're going to have to make adjustments elsewhere in the budget, trying to hold the budget at least level. We actually cut 1% out of the entire labor H budget, so that was considered a victory. And but I said NIH is not going to be where the knife goes here. And so what happened was we got it to $400 million, and it came back from the House at about 400, and then we found an extra 15. So we ended up at $415 million, which was an enormous victory for NIH. And thank you for everything you did. I do think Dr. Bhattacharya, quite honestly, was when he came to testify before the committee as the newly confirmed head of NIH, he very strategically would answer questions on how trying to defend a 40% budget cut by saying the administration has a position. He was pretty clever at it, but you could sort of see the little body language of how do I defend this? And I don't think so I think he's extremely glad and excited about the 415. But this is the fight that we're going to have to do. It really hinged. There were a couple issues without getting into the details. The indirect cost issue that many of you know about through researchers, if you do research in your institutions. The indirect cost issue was a major issue. It's still a major issue. We didn't make adjustments. We're going to have to make adjustments, and that's what's going to have to happen. So there was a separate group that tried to come up with some good ideas and did have some good ideas, but we weren't ready to make the leap. And the other thing was on other things such as forward funding and all of these kinds of things that I had to learn about. But anyway, we achieved a big victory. The president signed the bill. In questioning the president, why are you cutting medical research? I believe in medical research. Well, your budget doesn't show that. So hopefully they'll come back with something that makes a little more sense, but I think it shows you Congress has the power of the purse, and we exerted our power here.
Well, it was certainly demonstrated and executed in a profound way with what we saw. As you look across your state, what are researchers saying to you in terms of how those funds are being distributed? Oftentimes what we see is that federal research dollars go East Coast and West Coast very less frequently to the middle of the country. What are the researchers and research institutions looking for?
Well, I can tell you 86% of the NIH dollars goes to 20 states, one of which is not mine. And 50% of the NIH dollars goes to 4 states. there are answers in every state. There are great researchers in West Virginia and in Arkansas, we heard, and other states all across the nation. And so I think I heard from the previous discussion the challenges of rural America. Well, you need to research in rural America. You need to, the researchers, I think, in a lot of ways, if they're closer to the actual where the problems are occurring and the patients are there, can yield great results because you see the family dynamics, the travel dynamics, the other dynamics of how do you get to a pharmacy, all of these things that are challenges. It's not just what the physical diagnosis is. As you know, it's a whole ecosystem of trying to treat a patient. And so our university, West Virginia University, is trying to get a National Cancer Institute designation because the statistics are just jarring when you realize you have 30%, you have less mortality if you're near a center, you have better results, earlier detection, all these kinds of things. Well, why should that be only in certain parts of the country? It should be in all parts of the country. But, I'm not naive to think that a place like a small state like mine can be the answer to everything, but we have centers of excellence. We have a great neurological institutes that's doing really remarkable, innovative work in the area of Alzheimer's. So I think there's a lot to be found in the centers of the country and not just on the coast. I'm going to do everything I can. There's the IDEA program, which moves money out into around universities around the country, but it needs to be bigger, broader, and more robust. And so that's where my area of focus is going to be.
We have made significant progress in cancer research. We've seen mortality come down, although we do see incidence still up, of course, as the population continues to grow and age. Where have you seen the most significant impact on cancer research for patients? You've been such a staunch supporter for pediatric cancer research. Are we making a difference in that space? Where do you want the next levels of investment to be?
Well, I think we're making a big difference in childhood cancers. I joined with Jack Reed from Rhode Island for what's called the STAR Act, which was really the first, it was probably 5 years ago, the first really highlight into the uniqueness of childhood cancers. They don't occur in as large numbers. Children are not small adults. They have different reactions. They have different manifestations after treatment. They have a whole life in front of them. And what does this mean to a child and childhood cancers? I'm really proud of what we've done with the STAR Act and with childhood cancers, and I think we are making a difference. One of the things we were able to, Jack Reed and I actually put into the appropriations bill this year was to make sure that the studies, since you don't have as many patients, it's hard to get the amount of studies, and you want to have banks where you can go and find the research of children so you can do better research for children. And there's supposed to be an accountability for the pharmaceutical companies to be able to make sure that they're testing on children at these, and they're not testing as children as small adults. Well, the enforcement mechanisms weren't really there. So we're asking the FDA to be more aggressive here to make sure that that facet of childhood cancer is being covered in terms of the research.
We talked about the U.S. being a global leader in biomedical research and innovation, and certainly we're seeing challenges come out of China, particularly in early phase 1 clinical trials. What is the mood in Congress? How are we thinking about competition with China as it relates to medical research? Is it an area of focus? We did a convening here just in this center about 5 months ago. We brought together leaders from across life sciences and patient advocacy and other parts of the ecosystem. And one of the things they talked about, and we collectively wrote about, is the fact that the U.S. does not have a national life sciences strategy. China does, Australia does, even the UK. They have a strategy around attracting clinical trials. Will we at one point as a country galvanize around a strategic national life sciences strategy, recognizing what we have contributed not only here in the US, but really globally towards scientific research?
Well, I'm going to go out on a limb a little bit here because I don't have the exact answer to the question. If you ask me, are we worried about Chinese competition? I mean, heck yeah, on just about everything. Space, communications, military, health sciences, chips. There was a headline, I didn't read it this morning, but on what's going to happen with chips. And so all of this is exceedingly important. And you see this even in the trade and tariff debate that's going on right now. Are our products being disadvantaged, and what's going to happen there? I think a little bit of what's happened here, why we don't have a national strategy, and you all the experts, so tell me if I'm wrong here, is that we kind of been fat and happy here. We have been the innovators, the researchers, the top tier scientists around forever. I mean, that are bringing the cures, that have the answers, that have the talent, that have the technology. And so I think maybe in some ways, since we've had this sort of more diffuse system, it seems to be working. We haven't thought, well, maybe we need a national strategy. What I think was jarring on the NIH debate to me and brought to my attention was what's going to happen to our pipeline of researchers. If a university is having to cut 20%, who are they going to cut? They're going to cut their lower line researcher or their starting researchers or their PhD students because they're not going to be able to sustain them through the pipeline. So the easiest thing to do is to not have as many slots, not have as many people. And I think this happened all across the nation in anticipation of major cuts. Well, that's a problem because they're going somewhere else. They're going to Europe. They're going to China. They're going to wherever they're going. But yeah, and where?
Australia.
Australia, and I think that's a path we don't want to keep going down. And so hopefully with this funding, although I did hear the last panel say we don't really know what's going to happen next year. No, but that's pretty much the way it is around here. And so I think that is a real red light warning sign to all of us that we've got to make sure that we have that pipeline of researchers and that they have the certainty that they're going to be able to grow into their professions and be able to make a difference.
Do taxpayers recognize the value of scientific investment? You know, when you saw that initial proposal for a 40% cut, did patients come to you and say, I cannot believe that we're going to lose the potential to participate in an NCI trial? You know, how do taxpayers, everyday citizens, respond as you're trying to put together appropriations bill? Is it too technical for them to understand?
You know, no, I wouldn't say my phones were ringing off the hook. Please don't cut NIH. That wasn't happening. I do think that the folks with the knowledge were certainly coming and making us aware and bringing patients and families that have been the beneficiary of this. That's the best way to get to the heart of us, is to bring a family or somebody that you know or that you know from your state in to talk about, well, if I hadn't had this, wasn't in this clinical trial through NIH, my lung cancer, I wouldn't have the personalized medicine that I would be able to have. So I honestly, I think here again, because we've had such incredible advances in healthcare, people take it a little bit for granted. They don't think about who's behind the discovery and who's behind the remarkable and speedy way that we move things better and forward and find cures. So I think if we didn't have it, I think that would be something we prevented that from happening.
As we think about the next 5 to 10 years, we are asking for this room and those that are watching, what is the call to action over the next 10 years? How do we ensure not only do we protect science funding as we just did, but that we accelerate the potential for treatments and cures for patients all over the country, whether you're in rural America, whether you're in urban parts of the country, we are at the cutting edge of technology. We just heard about it from the panel before, perhaps science that we've never contemplated before. But when we look at health disparities, for example, and look at patients, we still see some patients around the country who are dying 2 to 3 to 4 times the rate that they should not, right? Just because they don't have access to an academic medical center. What is that call to action in 5, 10 years? How do we transform the face of cancer for those who don't get a chance to be in rooms like this?
Well, I live in an area that is exactly that. So I think you have to look inwardly as a region to try to figure, you can't maybe solve it state by state, more regional, more, as I said earlier in the last answer, centers of excellence much closer to where the problems exist. I would say this, I learned something in the NIH fight that I think we all need to realize. Nobody likes change, but change is coming in this area, and we have to be willing to do it. We have, how many institutes at NIH? 27, that's too many. I mean, that, so we have to, and it's so hard. We tried to change the name of one of the institutes every year, and we can't do it. That's how hard change is. But so as I had the parade of researchers coming in with big concerns about NIH, it's the first thing I said to them is, the system is not going to stay the way it is. So be a part of the change. Make the suggestions. Find out the ways that things can be improved. And this is where I think you all in this room know those answers and have those thoughts. And so I would say, don't fear change. It's coming. Be a part of the change. Include the rest of the other 30 states that get the only 14% of NIH funding and some of the best medical service delivery. The rest of the country should have equal access here to that. And then I think things will flow better. And I think instead of just resist, being a part of that change, I think is what my big suggestion of the next 5 to 10 years, because everything's changing so fast. And, the promises of AI, we don't really know. But that's not going to be the be all and the end all, because at the heart of it, AI doesn't have a heart. And every patient that you see has a heart and a family and a son and a daughter, mom and a dad. And I don't care if I put it into ChatGPT, which is, I'm going to admit, I use it all the time just to find out little things. And, it's great, but it doesn't have a heart. And you do. And those patients we care for do. So that's what we have to keep in mind every step of the way.
Excellent. Why don't we open it up for 1 or 2 questions in the room? Okay, Francis will come to you in a moment. Over here.
Thank you. Bruce Klarman, Fred Hutchinson, Seattle. So first of all, I wanted to thank you. When the Senate appropriations news came out last year, it was at a time of enormous stress across, at least at our cancer center, and I think across the country. And the bipartisan support for the work that we do was unbelievably uplifting. So I wanted to thank you for that. Listening to your descriptions of the future, though, we are a cancer center on the coast, and we are very dependent on the federal government. Do cancer centers need to fundamentally rethink the way that we depend on the federal government and how we move forward in what's going to be changes in appropriations?
Well, I think the system that was developed, and as I said, I learned a lot during this process of a public education, private kind of partnership that has developed over 60 years, since the 60s, for research has brought us some incredible innovations, and does keep us, has brought us to the pinnacle to be really the country that's the envy of the world. So I think we have to say to ourselves, that system of not relying on one single aspect of funding or pipeline of researchers, I think we've learned that having more than, having sort of a cluster of help is a lot better than depending on one. I think that, we're in lean times. We have a $37 trillion national debt. I mean, that should weigh on everybody. I think it does. We got to find a way to solve it. Some of the drivers on it are healthcare all the way around. And these are tough political decisions. And you saw what happened in when we made some adjustments through Medicare, or Medicaid, excuse me, over with I still call it the One Big Beautiful Bill, which I voted for. And, that was a hard political decision that you can see is being used as a sledgehammer in a political way. That's our fight. That's not your fight. So I would say just continue to refine the way federal dollars are used, be more transparent, be the idea factory on how to do it. I think the federal dollars are always going to be there. And I can't guarantee in what amounts, but I think it'll be pretty robust.
Excellent. Francis.
Senator, I just want to thank you for your leadership, and especially in this past year and what you've just told us about
That was a very difficult endpoint to achieve, and you and your colleagues stood up for a bipartisan support of medical research as a genuinely good thing that America has led the world in, and made what could have been a really devastating outcome into something we can all celebrate. And I totally get what you're saying about the fact that we in the medical research community should not assume that the answer is to just go back to the way things were exactly before. Now, this is an opportunity to consider what kind of changes can be made. But at the same time, it's hard to think about renovating your house when it's on fire. And thank you for putting out a big part of the fire. I wanted to ask you about one specific thing, which still, unfortunately, has led to very low success rates for people trying to get funding from NIH, even though the budget has been kept in a stable place. And that's this whole issue of forward funding or multi-year funding, which is a step that's been taken, which has the direct result of dropping those success rates by significant numbers. Last year, we only funded 1,144 early stage investigators. That's our seed corn, that's the future. These are the young scientists just entering the field. Substantial drop from what we have had in past years. The legislation says that for 26, no more forward funding can be done than was done in 25, but that was a lot. That's a ceiling, but I'm hoping it won't be the actual outcome. Is the Congress interested in that issue and trying to see whether there's a way to drop that percentage that is multi-year funded? Because that's our best hope for getting those young scientists who are incredibly troubled right now, the confidence that they've got a path forward.
Well, I had an evolution on this whole topic because I just assumed in some thinking about myself, thinking if I was a researcher, if I could get all my money up front, wouldn't that make me plan better? And wouldn't that make me, if I knew it was right there, wouldn't that be to my advantage as a researcher? This is what I was thinking until I had a lot of people tell me, no. That's not actually the result of this forward funding. It actually shrinks the amount of beginning researchers, and so I changed my mind on that. So that's a good thing. I do think that we did the best we could in terms of holding down the numbers. And I think what they do, 56% or something like that last year. And I think it's in the 30s, I think, the figure that we ended up with. Quite honestly, my colleagues don't know anything about this. Very few of them do. It's just a niche issue that unless you have a research or you're on the appropriations committee, which is basically 30 people, so that's a third, I doubt that many of them really know, unless they have a big research institution in their state, really know or understand the issue. So this is what I would say that's a challenge to you. You say, what would you do? You need to educate more of our members on what the implications of something like this is. So I'll say really quickly, because I know we're at the end of the time, but Susan Collins and Patty Murray, who are the chair and co-chair of our committee, the full committee, at the very beginning when the 40% budget came out, had a full committee hearing on medical research. That was pivotal. And I think
The story was fantastic.
yeah, and that little girl sat there the whole time. I'm like, what the heck? What is she on? I've got 9 grandchildren. They wouldn't sit for me for anything. And so that was a critical, so it's an education aspect of what are not just our members, but one of my fellow members was questioning on the idea of indirect costs, which is a significant issue. And so I'll leave it at a he was pulling information that's 30 years old of the abuse of the system. So and I literally, I'm leaning over to him going, that's 1995, or, adjustments have been made, and the abuses of the system that were turned up in 1995, somebody buying a boat or something like that, with the money, that's old news. But what you're dealing with when you're dealing with us on a dais like that is a 30-second or a minute soundbite for one of the political stations. I mean, so you have to be able to help us get through that and get the right information. And that was really frustrating for me because I had dug deep enough and knew enough, but most of the people on that panel didn't really know. Now, I'm not talking about the ones that were testifying. They knew. I'm talking about the other senators. They didn't really know.
And we're just talking about a few months ago, right? This is not old
this was in-
history,
right,
right?
like
So
6 months
the
ago.
idea of constant education to members in Congress, it's real. It's daily, it's constant, and it's the responsibility that all of us have. Well, thank you so much for this wonderful
I didn't realize you
conversation.
went to Duke too.
Yes, I
I'm
went
sure
to
we
Duke.
weren't there together, but
Well, thank you so much for the conversation.
you.
Thank you for being here. Thank you for your leadership
All right.
as well on medical research.
Right. And
Yeah.
I have Dana Richter here with me, who's my health. She is awesome. And that's another thing as you go to the Hill or when you're interacting with offices. We rely so much on our staff in terms, especially the ones that are knowledgeable in the certain areas of health. It is critical. So don't ever think, oh, I'm talking to the staff or I'm not getting to talk to the senator. And sometimes it's better because they can distill the information for us and then bring it to us because we have a lot coming at us. Like tonight we will. Yeah.
All right. Thank you so
Thank
much
you.
again. Take care. Okay, let me welcome to the stage Nubar Afayan, who serves as CEO of Flagship Pioneering, for a short talk. Look forward to that. Thank you.
Thank you, Mike. Thanks for including me. This is a little bit of a change in format. I'm going to squeeze a whole lot of information like Mike always does in his talks in a very short amount of time. So hang on. What I'm going to try to do is just give you a glimpse of a number of different approaches that are being developed within the world that I operate in. And we heard last night, and it was this, oops, let me just move this along. Can we get the slides up, please? All right. So we heard last night about the kind of launch point of this being 55 years ago now with the war on cancer kind of description. And as I look back, I've been involved in the biotech industry now for 39 years. A lot has happened. I think we kind of feel like we're still in the beginning stages. And while that's an okay feeling because there's a lot more to do, I just kind of lay out here the kind of things that I think are major human accomplishments that drive so much of the progress and the 30% reductions we heard about. And those are laid out in the bottom. I'm going to kind of skip ahead and kind of tell you how we see things happening. One of the things that my talk's going to address a little bit is what's about to change. And I think that if you look at the past, you could look at the world as largely being things that have been discovered or engineered. And I think it's fair to say that we're entering a world in which a lot more will be generated. In life, in biology, generation usually happens in nature. And the amount of generation I think that we'll be able to do and use the capabilities that we're learning from nature to create all sorts of novelty is about to hit us. And that's where I think AI will play a big role. And I'll kind of end my talk covering that topic. But I do want to ground us in one thing, if you've never thought of it this way. All of us working in biomedical research and biology are essentially information science people. Biology is the original information science. It happens to operate based on DNA, converting to mRNA, proteins, and then function. But we didn't think of it as much really until the genome sequencing efforts. But even after that, we've not really grasped the complex information science nature it is. With machine learning and AI, that's beginning to change. And I'm going to end my talk on that topic. But I would just suggest to you that the merger of these capabilities, human technology that's given us ways to capture, model, emulate nature, is going to make a huge difference. And we'll look back at the first 55 years on the war on cancer and be amazed at how much we did, given how little we knew. That's would be my contention, and we can debate that if you'd like. The thing I think will change, should change in the next 50 years, this was a question that was asked, is that we, I think, need to go from fragmented battles we've been undertaking, everybody with their own modality, everybody with their own idea, essentially claiming and sometimes funding, picking winners, which a lot of us don't really appreciate because we'd like the winners to be picked by nature or by what works. I think that more and more we should think about the future as really a comprehensive, coordinated campaign to throw a lot of different approaches. A lot of you heard about immune, I'm going to talk a little bit about that, but many, many, many different approaches. I think we're at a time where more will be better, but at some level in a coordinated way and with a regulatory framework that allows that type of diversity. So I'll also touch a little bit on that. I think in addition to the coordinated campaign, we're also going to need to rely on much, much more what I would call human miracles. These are human-made miracles of ingenuity, things that seem unexpected, supernatural when they happen, but ultimately we realize once we can explain what happened, that in fact it's consistent with the trajectory of science and technology. And I think we need to be much more investing in that. Sometimes people call that basic research. I don't. I think it's enabling research. But if we cut off our ability to do imagination-based work, that is work that you can't tie to an immediate use, but enables thousands of uses, I think that would be a difficult thing. So what I was going to tell you, this is going to sound a little bit crazy, is that among the biggest faculties we need to invest in humans today is our imagination. Our hard work and the automation of that we can talk about, but our imagination, I think, is what's going to drive the actual cures for cancer we're looking for. So imagination in what I do for a living starts with us being able to ask what-if questions and not feel embarrassed in the scientific community that it sounds crazy, because most of the things, Jim will be up later today, that turn out to be really disruptive start out crazy. So imagine what if we could discover a whole bunch of proteins that are only really expressed in cancers and be able to find thousands of new targets that we didn't even know exist in the protein databases. Imagine if we could detect cancer reliably much, much before there's any symptomatic evidence of it. Imagine if we could program a patient's own cells to be able to better mount an immune response. I can go on and on. These what-ifs that you see here each represent a scientific leap of faith. And I'm using those words very carefully. Faith in a non-religious sense just means belief without facts. And if we cannot invest in things that we have to first believe without the facts, only to get the resources to go get the facts, we will not make leaps, we will not have imagination used, and we will be stuck doing the same things ever so slightly better. And I don't think that's what the patients who are relying on us will want us to do. Now, if all this sounds completely unreasonable, I just taunt you with one question. Those of you who are in the boat already of being unreasonable may appreciate this. I would simply ask the question, why is it that the world, why is it that Mike, why is it that lots of people expect extraordinary things to be done by reasonable people doing reasonable things? That sounds crazy, right? On the other hand, what do we do when we invest, when we give grants, when large companies do partnerships? We ask the current experts, how likely is something going to work? That's what due diligence is. And when we get a consensus of how likely something is to work, we decide that's what we put our money into. That's the definition of reasonable, as defined by people who haven't yet done what's not been done. And in fact, those people became experts by doing something that hadn't been done, but ironically, they then defend that status quo. So if I can just say one thing, if you're sitting there thinking, should I join the reasonable camp? Should I join the unreasonable camp? I think in the administration of medicine, certainly reasonable is really important and reliable and reproducible. But when it comes to inventing things that people haven't yet thought of, if you don't start being unreasonable, you will get completely dominated by thousands of others who are doing reasonable things. So with that in mind, let me just skip ahead. What I want to do in the next few minutes is just to give you instances, little glimpses. All those what-ifs that I showed are actually today contained in companies that we've been involved, my firm Flagship's been involved in the founding of, some 45 of them, across about 10,000 researchers in the Boston area. So what I'm going to talk is on behalf of all of that. I'm not going to talk in every single instance, but when I switch from one topic to the other, don't wonder why that's kind of happening. I should have moved the slides up. So let me start out with one of the companies that we were involved in the founding of in 2010, Moderna. And all of you will know about Moderna in one way, that is in the case of making infectious disease vaccines. But it turns out the technology was not developed, in fact, to go after infectious diseases, but was to basically enable, we asked the question, what if a patient could make any protein they wanted in their body? And what would you need to do to instruct the body to make a protein of interest? So get rid of biotech factories, get rid of all that. And on that simple question, We looked at every way of doing it, and we found that mRNA was possible, but had been completely ruled out. Funding had been cut out, largely because it had a big immune response problem. Roll the clock forward today, and over the last 8 years, we've been working in the field of cancer on effectively using this capability of tuning and informing the immune system with a neoantigen approach. And let me just show you what we're doing in this space. So intismeran is the name of the approach we use. In fact, we call this individualized neoantigen therapy. It's interesting, this morning was mentioned, that we should move away from the use of the word cancer vaccine. Well, we did. We used to call this program personalized cancer vaccines, PCVs, and after a while we realized with all the attack of vaccines that people can't quite explain where it started, but nevertheless it continues, this is a therapy, this is a treatment. And you're seeing on the slide what it is that this process uses. This takes an individual cancer patient's tumor, sequences it, identifies neoantigens, takes up to 35 individual neoantigens that our computational AI algorithms can predict will be very specific and very immunogenic, puts it into a single LMP mRNA construct, just like the vaccines that we use, and administers back to the patient within a 3 to 4 week period. We've done this now thousands of times. And we have done this with individuals in a phase 2 trial that I will show you the brief results of so you get a sense. In melanoma, in stage 3, stage 4, resected melanoma, high risk, what we showed is some 49% improvement of risk-free survival over Keytruda alone. This was a combination Keytruda trial. And so basically what was a 75% response that we saw in the combination trial would have been a 55% response with Pembro alone. This was encouraging. This was across 150 people in a phase 2b trial. This was 3-year follow-up. Just a month ago, so if this conference was a little earlier, I wouldn't be able to say this, we had 5-year follow-up results. And 5 years after the treatment, what we saw was a 49% improvement in survival without recurrence or death, basically, and of 49% over Pembro. Now, yesterday we heard a little bit the beginnings of definitions of what cure looks like. 5 years of persistent effect with basically one initial set of treatments is encouraging to us. So we're doing a phase 3 trial, but not only are we doing a phase 3 trial in melanoma, we were doing it in 8 other cancers with our partners Merck. I think their sign is up there. You'll see all the different cancers in which we're seeing some early encouraging results. We'll have a lot of data to share. Our phase 3 trial is expected hopefully to read out by the end of this year. And we think this represents yet another part of the armamentarium that we could use to go after cancer using our patient's immune response. But mRNA doesn't just stop with that. mRNA allows us to do this with great rapidity and ease because it's a programmable molecule, it's a programmable approach. But then we're also going after shared antigens, not just individualized. That's the next lines. We're making T-cell engagers out of mRNA. That's the next one that's in phase 1 trials. And we're also helping T-cells through T-cell enhancers. All of this comes out of a basic innovation research that was done decades ago, NIH funded in part, followed by the companies stepping in and making it more of a therapeutic modality. So a good example of an American technology, hopefully helping American patients and global patients. Let me just kind of switch gears a little bit and tell you little bits now, much less detail, on a bunch of other things that are happening. Kind of, I'll call these, sorry for seeming immodest by saying the next human-made miracle, but that's clearly what we're trying to chase. Whether it happens or not, time and data will show. We have a project called Profound that's now 5 years into it, some 75 people basically who've been working on identifying a missing set of proteins that we've never known are heavily involved in various tumors. We've identified them, we've characterized them, and we're using them as a new set of targets in cancer. This is a whole kind of a new approach where we've hit dead ends, particularly with shared antigens that we're finding. We have a very interesting new approach for going after making a new category of proteins. You all know, well, those of you who do biology, that life is based on L amino acids. And you also know that sometimes people stick in some D amino acids to mess with the properties of a peptide. We have basically taken on the challenge of making all D amino acids. This is not an all D life form for those of you who are working about it. It's just a protein that is made of all D amino acids. The result of which is that if you can actually get it to bind to an arbitrary target, and for that, turns out you need AI. There is no AlphaFold way of figuring out how a D protein peptide will bind to an L protein. We've solved that problem with AI in a large extent. But if you take that, that's not a peptide that can be antigen presented. That's not a peptide that can be protease degraded. All of that requires ill amino acids. And so it has very interesting characteristics. So throw that into the battle, kind of a set of molecules that can bind target specifically, but have a much longer intrinsic half-life and therefore some potential new capabilities. Let me keep going. We're working on patient-derived tumor-infiltrating lymphocytes that we've taken out and multiply engineered using CRISPR to go in with the patient's own immune cells, but overcoming some of the things that cause exhaustion of these T cells in clinical trials as we speak with a company called KSQ. We have a very large effort where we've essentially been decoding the epitope and the antigen that's being presented with the complementary MHC so that we can essentially get the immune synapse figured out across millions and millions of such synapses at a sequence level. And we're using that to inform very different way of selecting much more immunogenic peptides. It's a company called Repertoire that's being used by multiple pharma companies now to develop the next generation of drugs. This, again, if this is seems superficial, if you look at all of them at once, and those of you who are interested, we're happy to show you, you'll realize there's a lot ganging up around cancer as we speak, all using new human-generated but technology-enhanced technologies. We have an approach to basically rewrite the genome of T cells in vivo by a single treatment that can essentially make CAR T cells in vivo that's entering trials relatively soon. In the early detection space, we have found that just epigenetic markers, the way the first generation of companies were finding, could be supplemented by biological markers. We found biological signatures usually activated during development, in placental development, that if you find in a person who's not pregnant, it is highly associated with cancer of all kinds, many, many kinds. And so we're doing trials to show that perhaps the biological signature on top of the statistically derived epigenetic marks could make a difference. So let me just kind of accelerate and just tell you, I'm going to skip a couple of things to get to this. Now, we've talked a little bit about AI. There's many more examples. And these are just our examples. There's many more of tons of great companies that are working in this space. So let me talk a little bit about AI. AI is being used just about everywhere when it comes to large data sets and creating models around them. But one of the projects that I'm very excited about is a company called Lila that we started 3 years ago, where we set out to say, what if we could actually implement all the steps of the scientific method? Hypothesis generation, experimental design, running the experiment, interpreting the data, and iterating in an AI kind of embodiment. And that, you might think sounds like science fiction. It turns out that both the cognitive part of hypothesis generation using generative AI and the experimental part using automation and robotics, which has existed but has now become much more effective, the combination of the two is beginning to show some very interesting signs of what will be an autonomous capability in science. And if you want a mental framework for this, because this could also sound scary, we liken it a little bit to chess. If you look at what happened in the game of chess, and you might say, well, science is not a game. Turns out you can basically formulate science as a game by adjusting the rewards, just like we do in science, namely grants and publications. Well, that's just the reinforcement learning reward. It turns out that you can actually get science, the computational algorithms, to play the game of science. That is to do experiments and do other experiments and do other experiments and see what can learn better how to explain what is being observed. In chess, that's what happened. So when, I think I lost the slide. That might be a signal that I should hurry up. But if I can get the slides back, that would be great. Okay. Oh, it's taken over. Virus. It's an AI virus. So let me just say, just to keep this in the back of your mind, if you think about what happened in chess, people developed algorithms that were playing humans, and they got better at it, and humans went, wow, that's the equivalent of AGI, as far as I'm concerned, in chess. That is something that's better than a human at what a human can do. But when you allowed these computers to play chess against each other and never played a human, they literally played hundreds of millions of games, whereas all humans have ever played, it's been estimated, is about 300,000-400,000 chess games, ever, that humans have played. So the learning of hundreds of millions of these games fed back to the next game turns out to be a completely futile exercise for a human to play against. Now you might say, why is that a good thing? Well, what if we actually let the scientific process run hundreds and thousands of times, come back with findings that would essentially take us now a century to do. And before you think that's not going to be possible, the technology bits and pieces all exist to do that. And we as humans have to decide, how are we going to govern it? How are we going to deploy it so that we don't wait years to find the next neoantigen or to test the next new things? But actually, at least at the discovery side, we are actually quite enthusiastic by the early data we're seeing. And you can follow it over the years yourself. We're literally setting up these what we call automated science factories, think Waymo for science, and we're trying to use generative AI to direct this. This is not to say that the humans will not have both a controlling or motivating aspect and interpretive involvement. This will be a partnership, but we think this is another thing to try. Let me spend the remaining couple of minutes that I have on a couple of topics that have come up before, but I just want to emphasize. One is that I am concerned. So I consider myself a paranoid optimist. And so I've told you about the optimist part so far, but I haven't talked to you about the paranoid part. And I'd say 39 years into my journey, I'm more paranoid about where we are today in this country than I have ever been. And that is because I see a pretty frontal attack on the scientific method. I asked the question earlier, but it's everywhere you look. I wrote a paper on this topic that is in your materials if you choose to read it. It's called Choosing Science. And the basic points that I make are these. I list human-made miracles that are happening at an amazing level, funded a lot by NIH, NCI, other funding. And on the other hand, I would argue that what is underneath a lot of the skepticism and doubt and opinions that are being thrown at science is a questioning of the scientific method. Now, I, as a scientist, don't really know a better way to do science than what we have as a scientific method, including fact-based argumentation. But that doesn't stop the debate from becoming very much focused on not who has more facts, the better facts, the more deterministic facts, but rather whose opinion has behind it power. And that is a difficult place to make science, let alone science policy, happen. So that's one thing that I want to just warn us about. At a time when it seems to me like the Chinese government is doubling down on the scientific method in a huge way. They're not having these debates about whether the preponderance of data should govern the next step. So I think that's an important thing to keep in mind. I'm not in the field of politics, but it seems to me from what we sit as investors, my firm alone deploys $2–3 billion a year doing this whole activity. And if we're going to stop and say, wait a minute, we might think this is the science that should be done, but then again, it might not be. That's a pretty scary place to be. And before you say, well, this will take a long time to unwind, we've got such a lead, I would say that the impact on disease, whether it's in measles or whether it's in any number of infectious diseases that we're seeing, will be pretty rapid in my view. We've already had measles essentially break through again, and it's officially not under control, and many other things will follow. And by the way, we're talking about cancer today, and if I may, with Mike's permission, I will put out a warning that what is today's skepticism around childhood vaccines or mRNA or what may or may not cause autism will tomorrow raise the same skepticism on a number of approaches to cancer. Because if you don't have to defend the approach by facts, then you might find, well, at least they haven't touched us. But I would say that as a scientific community, we kind of have to step up and say, show the science, show the facts, and let's have an open discussion. And I think that the urgency is very real. The other thing is we've talked a little bit about China in the last couple of days. For those of you who are also interested, this is an area that we've put out some observations on. Indeed, it is a bit of an unfair fight. If in fact you can actually go in and do 10 times more trials in phase 1 in China in a fraction of the time at a fraction of the cost, it's kind of hard for biotech in the US to compete. And we need to think about, as a both government, private, public partnership, what do we do about that? We don't want to suppress their creativity and ingenuity, but we do need to figure out ways in which patents are protected, data is available so that we're not dealing with a massive data inequity so that they can get access to data that people here cannot, et cetera. And those of you interested, happy to share our views, including putting it on the Milken Institute site. Look, the biotech industry, which is basically developed in the whole 55-year arc since the Nixon announcement we saw yesterday, is contributing, it's estimated, more than $3 trillion in 23 alone to the economy in general. And it's impacting many aspects, as Mike said, not just in health, but also in agriculture, water, and many other things, including health security. I think we just learned a lesson during pandemic that our health security isn't quite that secure. And if we have any more of these breakthroughs, whether natural or human-made, the ability for us to stand up and defend, I think is something we would have to put some energy into, and we're not. At this point, all of those systems, basically, as best I can tell, have reverted to where we were before. I have a bunch of policy recommendations that I'm out of time to discuss, but we do at Flagship look carefully at these issues, and whether it's how to kind of streamline the regulation of biotech products, how to create certainty around regulation and consistency. Look, the immigration thing that we heard about yesterday from Mike, I'm an immigrant, and so are probably half the people that work within Flagship's ecosystem. And by the way, I'm not just an immigrant, I'm an American by choice. I supported Mike's project in this building because I felt like I have a bigger duty to ensure America's future than even people born here. Because I chose to be here and I owe it something because I'm now here. But if in fact the sentiment becomes that it's not clear whether that's actually regenerative enough, the way President Reagan said, then I think, again, all these things get unnecessarily unstable. And so given I have the podium for another 30 seconds, want to implore you on this. So look, my bottom line message is, we've made 50 years of progress, but lots of fragmentation, a focused, more coordinated, but multi-pronged approach, not to pick winners and let the data tell us who the winners are. We have, as humans, now an unprecedented ability to make miraculous breakthroughs. It's a bit of an illusion because miraculous breakthroughs appear miraculous only because we don't understand them at first. And by the time we do, it seems obvious. That's what happens wave after wave in science. And so, but we're poised to do that, aided with AI. We have to choose science. We have to choose to back the scientific method. And the last point I want to make, which is my last slide, is it's a topic you may not have heard about, which is what I've termed polyintelligence. So let me just say one thing that makes me extremely optimistic, having been paranoid for quite a while, about in the last little while. So look, when we hear about AI, we look at this as a Silicon Valley tech approach that's going to sweep all jobs, and let alone in life science and medicine, et cetera. And what it is basically machine intelligence. Now, what's interesting to me is that humans have made room for anything else on the planet to seem intelligent. We've made sure that animals are deemed non-intelligent, although that's being now scientifically quite defeated, by the way. There's some very interesting new papers that have come out showing Bayesian reasoning in a bunch of animals. But to put that aside, the interface between human and machine intelligence is the new biology. The interface between nature and human intelligence is what we know as biology. But what I would contend to you, and this I think may define the next decades of how we do science, is that nature is just another form of intelligence. We just never deemed it that way because humans control language and we don't think anything else is intelligent. But if you think about, and we heard yesterday from Jim and others that have made this point that the immune system is more intelligent than humans, well, there's intelligence everywhere you choose to find it in nature. And the reason for that is that all evolution is reinforcement learning at the level of DNA. That's what Darwinian evolution is. So if you start thinking about a virus that almost took down our immune system 5 years ago, or our immune system going after cancer, or trees that kind of blossom every 50 years on the clock as forms of intelligence, now you might say, oh my God, humans neither understand that form of intelligence nor the artificial form of intelligence. But the good news is that the artificial form of intelligence, the machine intelligence, I think can handle the complexity that's resident in nature. So what I think is going to happen is that we're going to be entering into a phase where human intelligence will guide partly the AI and partly the nature's intelligence to start revealing essentially how nature is doing what it's doing without being limited by our own ability to speak or write papers. Like a proper paper describing one little bit of cancer in the future will probably require thousands of pages in its full complexity. Well, AI is very, very good at these kinds of billion parameters, 100 billion parameter models. So if this makes any sense, and so I warned you I'll be unreasonable, I would argue that polyintelligence, the interface between these three forms, will define human progress. And we'll be hard pressed to say that we're ready for it, but we're going to get ready. And I'll leave you with one last quote for those of you who do the kind of things that I'm sure many of you do, which is basically this. And I'm arguing vehemently for the ability to use imagination within the safeguards of the scientific method. Imagination is the beginning of creation. You imagine what you desire, you will what you imagine, and at last you create what you will, which is a quote from George Bernard Shaw. Thank you very much.
All right. Thank you so much, Nubar. That was an incredibly compelling talk. We are going to take a 10-minute break. We will start sharply at 11 o'clock. So please join us back in 10 minutes. Thank you so much.
Francis. You did. Good. Okay. Lee did, yeah. All right, let's get back. If we could just get back on our seats, we'd like to get started. So while we're settling down, I thought I might just update you on Greg Simon's question about the war on cancer. So in the early to mid 90s, I went to see Walter Isaacson, who was the publisher of Time magazine, and told Walter that they've had war correspondence. We now need to have a correspondence on Time magazine on the war on cancer. And cancer was claiming far more deaths than any wars that we've had. So he told me it's an interesting idea. He'll check it out. So we went to the team at Time, and their response was 29% of their readers believe they've met an extraterrestrial. And before he signs a reporter for the war on cancer, he's going to have to sign a special department for extraterrestrials. So that never happened at that time. So I want to take you back. It's 1995. We're having the first ever cancer summit here in Washington, D.C. And most of the other people have gone to sleep, and the young Lee Hood and his sidekick, me, stayed up to the middle of the night trying to figure out what are the 10-point plan we want to give everyone to think about how we're going to change the future of cancer research. And these were the 10 points we came up with as the program kicked off for the first annual summit, first actual summit on cancer. And it's interesting when we reflect on these, where we are today, internationalizing the war on cancer, not just U.S., invest more, recruit a world class. We have to get great people, coordinate cancer resources, accelerate technology transfers, push the technology envelope. Newbar just challenged us in imagination. Create a world library of organic materials that people could address. Accelerate approval for new drugs, get product to market faster, and mobilize patients and families. As part of that, shortly thereafter, we went on the Larry King Show. Lee, myself, Dr. Holden, and the goal was that Hopkins had done a study. I don't remember exactly. I let's say it took 10 years, maybe 12 years, to identify 800 families where more than 2 people in the family had prostate cancer. So can we compress time? We had this idea, why don't we use this new invention, television? Why don't we go on television and ask for people to dial in? But if we wanted them to dial in, myself, even Lee or Dr. Holton or Larry might not get them, so we asked General Schwarzkopf to join us on the show. And in a short period of time, 3,000 people called in, and in 1 month, we had more than our desire of families with more than 2 patients that had prostate cancer. We did have some call in and ask them, how many members of your family had prostate cancer? No, we don't have any. Why are you calling in? We saw General Schwarzkopf and we're reporting for duty. So the idea was he was successful. In figuring out more than 30 years ago how we make an economic argument, obviously every single life is important. We did all this research led by Nobel Prize winner Gary Becker and many others. And it shocked the House and the Senate and others as we presented this data showing that public health and medical research was accountable for more than 50% of all economic growth in the last 2 centuries. And as people wondered why, one of the simple things we showed them was the extension of life. And the extension of life was really accountable for most of the growth in the world's population. And the world's population for a period of times did not grow for 1,000 years. But as we went in 4 million years of evolution, we increased average lifespan by 31 years. And then in the next 120 or so years, we've increased average lifespan by 42. So we have my young mentor, Lee Hood, and in the years we've worked together and known each other, science tries to catch up with Lee, and just when he gets close to where Lee is, Lee moves ahead again. And so, Lee, we're looking forward to your remarks, and thank you for joining us today.
Well, thank you, Mike. What I like about Mike is innovation, scale, thinking out of the box, and depth. And I think we've all seen it in spades. So, can I have the first slide, or do I do it? I clicked. Anyway, I'm going to talk about a journey that I've taken, thinking about cancer in a very different way than almost all of you have thought about cancer over the years. I remember when I was an assistant professor at Caltech in 1970, sitting down and asking, what am I going to do with my career? And I'd always been interested in human complexity. And up to that time, I'd done molecular immunology, which was a marvelous first step in thinking about human complexity. But at that time, it was clear to me there were 2 major challenges in thinking about complexity. One was there was no way to generate all the data you needed to begin to understand that complexity. And even if there weren't ways to think about how to analyze that information. And it was those 2 thoughts that actually set me on a course through a series of what I've called paradigm changes that I'll talk about. So The first thing I did at Caltech was develop a lab that was multidisciplinary in nature. And over a 20-year period, we developed 6 instruments for reading and writing DNA in various ways. And these instruments, the automated protein sequencer, highly sensitive, clone genes that opened up new fields of biology. I remember one issue of Science, we had 4 papers on new clone genes in different areas of biology. But the second thing it did with the automated sequencer was made it possible to start thinking about the Human Genome Project, the second endeavor. And went to the first meeting in 1985 at Santa Cruz. 12 people considered the whole thing. 6 were in favor of it, 6 were against it, and those opposed were terrified big science would take over small science, which was anything but the truth. And the evolution of that was a fascinating process. But the genome gave us the fundamentals of starting to think about human health in a data-driven way. Because on the one hand, it told you what you could do maximally in optimizing your potential. On the other hand, it clearly laid out deficiencies that we had to be able to deal with. The next stage of my thinking was my lab grew to be very large, almost 80 people, and most of them were a lot of cross-disciplinary biologists. So I proposed to the Caltech Department of Biology that I start a new Department of Biology where the faculty members were the individual chemists and physicists and mathematicians and biologists, and biology categorically turned me down. So Bill Gates made it possible in '92 to move to the University of Washington Medical School, and there we started that department, which for 8 years was spectacular. Phil Green wrote the 2 major software programs for the Human Genome Project, Quality Control and Assembly. Rudy Abersol and John Yates started the field, basically, of proteomics. It was just emerging at that time. And we developed inkjet technology for rapid DNA synthesis. And I'll talk about why that's important in just a few moments. But what was really clear is a big bureaucratic institute really resisted fundamental changes. And the change I wanted to make at that time was systems biology. And I remember the time the head of computing at the University of Washington came and showed me a small janitor's closet and said, "That's all a biologist will ever need in the way of computing." So I started the Institute for Systems Biology. The idea that you took a global, holistic view of things, and it's there where we had the first really interesting ideas of how to take a systems approach, A, to disease, and B, to cancer. And the point I'm going to make is cancer, when diagnosed, is unbelievably complicated. So let me show you exactly just how bad it is. We used 2 mouse models, one on scrapie, which is neurodegeneration, and the other was a mouse model for glioblastoma. And the scrapie model was interesting in the sense, see, I'm not pressing the buttons. Oh, there we go. In both models were impressive in that you could start the disease at a particular time and you could follow what happened to the organ of relevance as you went through. And in scrapie, I won't go into any of the details. You used prions to initiate the onset of disease. And we could show in C57 black, in about 20 to 25 weeks, you had a full-blown disease. And 300 proteins changed in dramatic ways. they mapped into 10 major networks, which collectively and dynamically explain the pathophysiology of the disease. And this just gives you a window shot where the red are the changed proteins that are relating to one of the 10 subsets of networks that were there. And it led to prion accumulation, it led to glial activation, it led to synaptic degeneration, and finally the neuronal death. And the really important point was the pathophysiology was reflected beautifully in the systems. And the other thing that was absolutely fascinating was at each of these major events, you could see in the blood proteins that had been modified in accordance with the disease-perturbed networks. So that then we did exactly the same for glioblastoma in the mouse, and I won't go into it, how we designed it and everything. But the bottom line was there were 18 disease-perturbed networks that explained most of the pathophysiology of the most aggressive form of glioblastoma. And you can see at 1 week, at 2 weeks, at 8 weeks, and then at 16 weeks where the disease was diagnosable, one of the 18 subsets, and how manifestly different these changes were. And it leads to the idea, if you're to deal in a systems way with this kind of complexity, we don't begin to have the tools for dealing with the systems way. But I'll tell you about an approach at the very end that talks about that possibility. What happened next is in 2014-15, I started a data-driven health program for individuals. And let me say, I think cancer has to be done at the level of the individual. Population cancer doesn't work for individuals in many, many different cases. We gathered 5,000 individuals over 4 years. We had data points of genome, the phenome, the microbiome, and the Fitbit, and so forth, that gave us fundamental new insights into individuals across that 4-year period. And we could translate those data bits for each individual into actionable possibilities that could either improve wellness and or let you avoid disease. And I'll really talk about the whole idea of avoiding disease, because to my amazement in this population of 5,000 people, there are 3 different ways now we can think about early diagnosis of disease. And let me just say, I think virtually all the diagnoses you've talked about are late diagnoses of disease. They're stage 1 or stage 2 or stage 3 or something. The earliest things are much, much earlier that when you have only a very few disease-perturbed networks. So one of the really interesting possibilities that we showed, as I showed you in the 2 mouse models, with the onset of disease, you have an increasingly complex array of disease-perturbed networks that lead finally to a clinical diagnosis and so forth. And of course, what we have the possibility of doing now with the Airvale population, because we were able to show for 167 out of 5,000, they transitioned to major chronic diseases, 35 to cancer. We took 10 that transferred to cancer, and we looked at the bloods prior to the time of diagnosis, and we showed 2 things. Number 1, we could make the diagnosis in 10 out of 10 cases of elevated proteins, and the elevated proteins obviously mapped into the earliest disease-perturbed networks that were present in these different types of cancer that we looked at. And I will say, for the 2 people we looked at with prostate cancer, there were common features and different features. So there are unique features for this disease. So if we think about phenomic medicine, then we now have the ability, if you're tracking people on a regular basis at the protein, at the protein level, you're going to be able to see these early transition points. If we could have the slide back again, it'd be great. Anywhere between 4 years and 1 year prior to diagnosis. And of course, this gives us the idea then of being able to focus on some type of targeted therapy that can reverse disease before it becomes manifest. So that's one approach to being able to think about early detection. And a second approach that I think is really interesting is we looked at 54 polygenic scores in the context of your genetic risk for these 5,000 individuals. And we were able to show for the population that there was a linear from very low risk to high risk. And then what we did was we looked at 1,000 analytes for each of those 54 things and showed in every single case there were analytes that were elevated or depressed in the context of increasing genetic risk. And for the major ones that we looked at where we knew them, the elevated analytes correlated to the analytes elevated in the frank disease. So what it means, you can use polygenic scores and high risks to say this individual is at risk for this disease, and you can watch if you're at high risk for the elevation of those analytes that indicate you're getting close to a transition point, and think about the kind of disease reversal we'll talk about in just a moment. And then the third approach, which I think is one of the most general, is we were able to do deep transcriptome analysis of 25 different human organs from a whole host of different papers. And we were able to identify for each of those organs transcript-specific organs for the brain, for the prostate, for and so forth. And we called those, and some of those were secreted as proteins in the blood, and thus they became sentinels for the corresponding organs. And we defined roughly 1,000 of these organ-specific proteins across 25 different organs. And the brain actually had way more than half of them. But what was interesting about the brain is only about 10 of them showed up in the blood, unless you had a disease in the brain that reduced the membrane permeability across the brain. And then proteins were released that could be specified to particular areas of the brain where the disease actually was located. We did the same for a study we're doing in pregnancy with the placenta. There were 37 organ-specific placental proteins. But the really important point is these give us the ability, one, to look at state transitions in each organ with regard to disease, physiology, whatever you'd like. And number two, this is a superb way at looking at complications of drugs that may arise off target from where you want them to go in the future. So anyway, those are possible therapies for early detection. And I think immunotherapy is going to be a superb kind of possibility. I think lifestyle correction is really going to be important in the future. And I'll tell you, I think one of the most important lifestyle things we have to focus on is the gut microbiome, because it's the source of major inflammation, and inflammation triggers all sorts of things that can both compromise the immune system on the one hand and or trigger the induction of cancer on the other side. And the other possibility is the use of drugs and so forth. And I'll close by saying that the latest thing that we're thinking about is starting a drug company called P4 Bios, which uses large-scale DNA synthesis to synthesize millions of different drugs. And these are peptide drugs. Generally, we're making them in the order of a 30 to 40 residue size. And of course, these drugs are really interesting now. One, GPL-1 agonists have opened up all sorts of new possibilities for us to think about drugs. But two, there's been an enormous revolution in proteomics, realizing 50% of the proteome is unstructured. It does not have three-dimensional structure. And number three, there are at least 20,000 small peptides that are encoded in the genome, 100 residues or less. And most of these are unstructured in nature, and they open up all sorts of new possibilities for drug discovery. And I will say, without going into any details, we can use these peptide drugs now to give a new type of data for drug discovery that I think is going to be really revolutionary in the context of AI. And revolutionary because for the first time, you can really think about rational multi-drug approaches to dealing with complex biological perturbations. Thank you.
Thank you so much, Dr. Hood, for that incredibly fascinating talk. At each of the tables, there are QR codes for all of the slides that we went through today, from all of the talks from Newbar and all of those that will be following throughout the course of the day. So please use those QR codes to access the materials. I would like to introduce Mark Goldsmith. There you are, Mark. And Mark is going to give us another talk as he is targeting an elusive area of cancer biology. We look forward to learning more. Thank you.
Thank you, Esther. And thank you, Mike. It's a real honor to be here today. Bring up some slides. I heard the term proto-oncogene first in 1984 in a medical school lecture by Harold Varmus. He explained that a proto-oncogene is a natural gene encoding a normal protein that is centrally involved in normal cell replication and for which a mutation or some other alteration can cause it to become a proper oncogene, a driver of cancer. At that time, I had no appreciation whatsoever for the truly monumental significance of these profound concepts, and I surely did not predict that this new framework would enable the coming era of precision oncology and targeted therapeutics aimed at selectively blocking the products of oncogenes from sustaining cancers. Just a few years earlier, the first human oncogenes had been discovered by Bob Weinberg and others, oncogenic variants of 3 genes that encoded normal, essential, intracellular, on-off switches called RAS proteins, KRAS, NRAS, and HRAS. These proteins act as binary molecular switches that regulate normal cell replication. They can turn from on to off. More than a dozen oncogenic mutations in RAS proteins were discovered that bias these mutated cellular switches toward their on or active state, thereby driving cells into hyperactive replication and toward malignancy. RAS oncogenes and their oncoprotein products are the most common drivers of human cancer. Nearly all pancreatic cancers are caused by oncogenic RAS proteins. Likewise, most colorectal cancers depend on the RAS pathway, including 50% that carry a mutation. The majority of non-small cell lung cancers also depend on RAS signaling, among which 30% carry RAS mutations. Similarly, RAS and RAS pathway mutations are common in melanoma, cholangiocarcinoma, and so on. These deadly cancers arise from the corruption of this very central growth signaling system that had evolved specifically to maintain cell growth and differentiation at the optimal set point for sustainable life. And sadly, more than 40 years later, standard of care for patients with RAS-driven cancers continues to rely heavily on non-targeted cytotoxic chemotherapies, blunt tools that lack selectivity, cause serious side effects, and often are only marginally effective. To win the war on cancer, we must conquer RAS. Conquering RAS will require safe and effective targeted therapies. For decades, RAS proteins eluded traditional drug discovery because they lack obvious druggable pockets into which chemists can engineer a small molecule. And in 2013, a convincing drug discovery approach finally emerged from Keyvan Shokat's UCSF laboratory for selectively inhibiting one particular mutant form of RAS called KRAS G12C that causes about 12% of non-small cell lung cancer. Keyvan and his postdoc John Ostrom cleverly uncovered a hidden pocket they could use as a landing site for the very first drug candidates to inhibit the KRAS G12C protein, and subsequently 2 products that built on this foundational academic work received accelerated approval by the FDA for treating subsets of patients with lung cancer or colorectal cancer carrying this mutant allele. With this traction, the race began with 2 main goals. First, to improve the efficacy profile of these early products for RAS G12C cancers, and second, to target the remaining 85% of RAS-mediated cancers that are driven by even less chemically tractable RAS mutants. Several colleagues and I founded Revolution Medicines in 2014 to harness the rich chemical space inspired by natural products, molecules refined by over 1 billion years of evolutionary selection. Natural products often have unusual, even ingenious mechanisms for binding to their cognate proteins that don't depend on pre-existing druggable pockets. Our vision was to use advanced structural biology, computational methods, and sophisticated chemistry to mimic these lessons from nature and to fabricate drugs customized to bind to disease targets lacking traditional drug products. Ultimately, we focused on tumors caused by RAS, what I consider to be the notorious royal family of oncogenes. We began leveraging additional technology that we had acquired from another imaginative biotech company called Warp Drive Bio, founded by Harvard biochemist Greg Verdine. Through this acquisition, we became able to apply natural products like chemistry to RAS proteins. And somehow, we talked ourselves into committing everything we had at Revolution Medicines to the nascent technology in an all-out focus on RAS proteins, RAS cancer biology, and RAS-targeted drug discovery to serve profound unmet needs for patients living with these RAS cancers. In many ways, this was a high-risk decision, one that would ultimately require an enormous effort supported by billions of dollars to mature the technology and discover and develop potential new medicines. So what's special about Revolution Medicine's approach? Go back to this. First, our drug discovery platform targets the on or active state of oncogenic RAS switch proteins that are the drivers of oncogenesis, while the biopharma industry had exclusively produced binders of the KRAS G12C protein in their off state. Recalling that oncogenic proteins tend to be locked in their on form, conceptually it makes sense to try to target those proteins, and in fact, that hypothesis proved to be correct. Second, the RAS on form has long been considered undruggable because its smooth surface is not amenable to drugging. It's like trying to grip a bowling ball without finding finger holes. Our compounds enter a tumor, bind immediately to a ubiquitous cellular protein called cyclophilin A. This creates a new composite surface that can directly engage the RAS-on proteins like a molecular glue in something we call a tri-complex, in which the RAS-on protein is instantly sterically inhibited from interacting with its downstream effectors, and growth signaling shuts down immediately. What once appeared structurally inaccessible became druggable through this engineered or neomorphic interface, an approach that we've now used to generate more than 25,000 compounds, that is, inhibitors of the RAS family. And third, these efforts led to successfully developing bolder compounds targeting RAS proteins carrying other oncogenic RAS mutations. And today we have potent, selective, oral inhibitors of essentially all oncogenic variants of RAS that we're investigating. In 2022, on the 40th anniversary of human RAS oncogene discovery, our scientists presented 7 oral scientific presentations at the AACR meeting on 4 new breakthrough compounds embodying these concepts. In one example, we described an especially revolutionary molecule. It was then called RMC-6236. It's now called daraxonrasib, as a single compound capable of inhibiting all forms of RAS, KRAS, NRAS, and HRAS, including every oncogenic human mutant form we've tested, and even the wild type or normal forms of these proteins. We had crossed a number of stubborn technical lines. In many preclinical models, daraxonrasib induced marked and sustained shrinkage of tumors of diverse types, lung cancer, pancreatic, and colorectal cancers, with a tolerability profile in these animal models that supported clinical advancement. And treatment led to marked and sustained slowing of disease progression in most of these models. And that same day, we filed our first IND with the FDA for a RAS-on inhibitor to conduct a clinical trial relying on patients with RAS cancers who volunteered to try this entirely new class of investigational RAS-on inhibitors. We have studied daraxonrasib in patients with a very wide variety of different tumors, but I'd like to highlight here a cohort of patients with pancreatic cancer, a particularly devastating disease. It's a prototypical RAS-driven disease. It's poorly responsive to chemotherapy. Daraxonrasib at 300 milligrams given orally once a day showed an acceptable initial tolerability and safety profile, with the most common side effects usually manageable and with few patients discontinuing the treatments due to side effect. Encouragingly, the vast majority of patients showed some level of tumor shrinkage on treatment. Disease control was observed in 90% of patients, and up to 35% showed enough regression to declare a formal response under the widely used RECIST criteria. The findings in this early single-arm study were highly encouraging in the context of the well-known, much lower benchmarks for standard chemotherapy regimens. In these patients, daraxonrasib also demonstrated encouraging progression-free survival and overall survival signals in the phase 1/2 study. Last year, the FDA granted breakthrough therapy status to this investigational drug. As an early phase trial, there was no control arm in this study, but the single-arm data were sufficiently encouraging to justify initiating larger randomized trials. The first global randomized control trial is known as RASolute 302, and a readout from this study is expected during the first half of this year. A few months ago, daraxonrasib was the first oncology product to be granted a Commissioner's National Priority Voucher by the FDA to speed review of the pending data from the 302 trial. We also evaluated daraxonrasib in combination with standard chemotherapy, gemcitabine, and nab-paclitaxel in patients with first-line metastatic pancreatic cancer. The rationale is straightforward. Cytotoxic chemotherapy reduces tumor burden broadly, even though it is a blunt approach, while the RAS-on inhibitors directly suppress the specific oncogene that's causing the tumor. And possibly the two together would provide further benefit than either alone, as we saw in preclinical studies. And as you can see in this early cohort, we observed quite encouraging initial anti-tumor activity, including high rates of objective response and disease control. These data remain preliminary, and our RASolute 303 trial will formally determine the magnitude of clinical benefit in a randomized controlled global phase 3 trial setting. Quite remarkably, mutant forms of RAS are devious in a second way. Not only are they directly oncogenic, but their aberrant signaling also alters the tumor microenvironment to reduce the visibility of these tumors to the immune system, essentially shielding the tumor from natural immune defenses. Hence, RAS mutants are both pro-oncogenic and anti-immune defense. In this context, I want to highlight a second profound paradigm shift in oncology during the last quarter century, which is the introduction of immune checkpoint inhibition as an anti-cancer therapy. As we'll see and perhaps talk about later in today's agenda, the work of Jim Allison and others fundamentally changed the trajectory of cancer treatment broadly in part by identifying cell surface proteins that were often induced by tumors and that mediate local immune evasion in tumors. Jim and others showed that relieving these checkpoints can take the brakes off the immune response with beneficial therapeutic effect. And of course, monoclonal antibodies directed against the CTLA4 and PD-1 axes, for example, are now widely used in treating melanoma, lung cancer, and others. This raises an important scientific question. Could combining direct targeted RAS-on inhibition along with checkpoint blockade further enhance anti-tumor activity? Early evidence from RAS-off inhibitors suggested that the answer might be yes. We've conducted initial studies of RAS-on inhibitors combined with checkpoint inhibitors. For example, in an early study of patients with RAS mutant lung cancer, we've seen high rates of tumor regressions in patients with daraxonrasib plus pembrolizumab or Keytruda, the PD-1 inhibitor, or daraxonrasib plus Keytruda plus chemotherapy, as shown here. These findings support the promising convergence, then, of two major paradigms for patients with RAS tumors, that is, combining precision oncology targeting the oncogenic driver along with reactivating an immune response through checkpoint inhibition. And in recent years, bispecific antibodies with two different functions or even trispecific antibodies have entered the scene, some of which are intended to expand on the well-validated checkpoint inhibitor theme. And in collaboration with Summit Therapeutics, we've now begun the potentially exciting work of clinical testing of RAS-on inhibitors in combination with ivonescimab, a leading example from the bispecific class of antibodies targeting both the PD-1, PD-L1 axis and the VEGF axis. Over the past several years, we have now advanced 4 distinct RAS-on inhibitors into clinical development, and we've treated more than 2,500 patients with one or more of these investigational agents. We've announced 4 large phase 3 trials underway and plan to have initiated a total of 8 by the end of this year. What began as a high-risk, early scientific idea now drives an organization of nearly 1,000 people, collaborating with many others globally in a shared and tireless commitment to confronting and eventually defeating RAS-driven cancers. In the 5.5 decades since President Nixon's administration declared a war on cancer, the oncology field has made extraordinary progress in understanding the biology of cancer through publicly funded academic research, as well as industry-driven research and development. For many years, though, RAS proteins, the most common oncogenic drivers of human cancer, seemed beyond the reach of drug hunters. Today, we can selectively inhibit RAS in its on or oncogenic state, and we're no longer asking whether RAS can be drugged. We're now asking how best to use these medicines to change global standards of care. If the first half century of the war on cancer was in part about understanding RAS biology and developing initial tools, the next decade must focus on exploring the most effective combination agents in combination strategies to harness multiple biological axes. And we intend to play a leading role through continued science-driven innovation on behalf of patients. Thank you very much.
Thank you so much, Mark. That was an extraordinary talk. I would like to introduce Gina Gaithers for a panel focused on prevention, early detection, and interception. And Gina serves as president and CEO of the Prostate Cancer Foundation. So hopefully you'll help us understand the last 2 talks that we've had relative to prevention. So thank you.
Thanks, Esther.
So we're the only thing that stands between you and lunch, I think, is us. And we're probably what I think, a little bit biased perhaps, is an exciting follow-on to Lee's discussion about prevention of cancer. And as most of us realize, a tremendous amount of our resources are spent looking at how to treat cancers that are there. And what we're going to take a talk time to talk about today with this esteemed panel is ideas and work that's being done on prevention of cancer, not just the prevention of the first stage, but the prevention of recurrence of cancer and progressions of cancer. So with that, it's a pleasure to introduce you to Charles Bulk, who is leading cancer prevention today through a society. And rather than focus on our past, we're going to stay current to really thinking about what we're doing today, Charles, in terms of driving prevention of cancers. We know it's occurring in our younger population. We realize our younger population are our workforce. It's not the same as when we get cancer in our late 70s and 80s, right? And not that we ever want any cancer, and we know we want to eradicate these diseases, but we also want to make sure that we're able to understand ways to prevent this disease, to prevent it from impacting our younger population. So with that, Charles, I'm going to turn it over to you to lead us through the beginning of this conversation.
Well, thank you, Gina, and thank you, Mike Milliken, for all you've done through the years, and for Andy Van Eschenbach, my dear friend, who invited me to come and participate. You know, we've heard this morning and we celebrate successes, but I think we still have to remember that in the United States, 2.2 million people will develop cancer this year, and 600,000 will die of cancer this year. That means that the population for the city of Houston, where I'm coming from, will develop cancer every year. The population of the city of Detroit or Washington will die every year. Those are big numbers. And I think we really need to redouble our effort to go beyond what we're doing now. And I think that next wave, if we're going to get to 2035, is in the area of prevention and screening for early detection. Now, in the projections in the future, in the next 10 years, the increase in cancer is going to come in our young and middle-age group. That's our workforce. Those are the people who are teachers, our executives, our moms and dads who are trying to raise children. And unless we address those individuals, the young and middle age, we're going to have a detrimental effect on our gross national product and our economic well-being. So we know now that between 15 and 20% of the young and middle-aged people are at risk for a future cancer somewhere in their future. It's estimated there are 100 million people between 30 and 60 years old, and 15% of those would be 15 million people right today. We could identify with today's knowledge who's that individual's at risk. And part of that is doing the genomic testing, which is now affordable. It's not just good enough to talk about the genes you inherit. You have to add to that the lifestyle, the family history, and the age in which people are embracing cancer prevention and screening. You can't benefit the population by going to the 60-year-olds. We have to get to the 30 and 40 years old before they get cancer, and not being reactive when they get cancer, but being proactive before they get cancer. So I've been working with a company called Novi Health, and we're now working with CEOs and businesses to try to develop a healthy workforce. And what we're finding is pretty astonishing. We're finding that between 15 and 20% of the healthy workforce under the age of 40, outside of the age guidelines for doing screening prevention, are at risk, high risk, medium to high risk for various types of cancer. And getting them into screening and prevention programs that are people in their 30s and 40s. And I think as we get to 2035, these are the kind of things that we need to be working for. And part of our statement is 50% of all cancers can be prevented or diagnosed at a curable stage. That's number one. And number two, we need to get away from the one size fits all, and we can't afford to study the entire population, but to spend our money identifying those at high risk and putting our efforts into those individuals before they get cancer or heart disease. Countries are doing that. The country of Singapore now is taking their whole population and dividing them into high risk, low risk, and medium risk, and partitioning the delivery of their healthcare system based upon their risk. And I think that's where we should be doing this. We should engage the corporate community and say cancer prevention and screening is a corporate responsibility, and we need to fold that into the workforce in a health benefit, in the changes of their insurance programs. And then the last thing, it's not good enough to give them gyms and nutrition training, smoking cessation. You have to give each individual a personalized risk for their specific risk and engage them to participate in it, and not just provide the gyms, but to get people to go to the gym. And the best example of that is the wisdom trials that were just published in JAMA Oncology in the last month, a large randomized study on breast cancer that used genetic testing and risk-based screening to find, doing less mammograms on the low-risk individuals, more mammograms and MRI in the younger people who need it. And then the follow-up publication showed that those that they counseled in medium to high risk were actually exercising more, drinking less, losing weight. So I think when we give people personalized risk assessment, they may do something about that risk instead of a general message that you just need to be healthy and modify your lifestyle. I think we have to go beyond that and give each individual a personalized risk assessment that includes their inherited risk and their lifestyle risk.
Thanks, Charles. That's it reminds me a little bit of when you end there on obesity in our population, and that was something that was talked about a little bit last night. Nubar, in his presentation earlier today, he brought up what if, using our imaginations. And as I go to you, Dr. Lee, I think it's amazing that you created our menu last night. And what if we change the way we think about food and we interpret food into our lives? What can that do to help us with the prevention of cancer?
Well, thank you. I also want to thank Mike for organizing and convening, as well as the Nixon Foundation for continuing their vision to bring together thinkers and leaders for the future. My area has evolved into food as medicine, but my background is actually in drug development and developing those preclinical, translational, and then clinical trial methodologies to be able to take new paradigms to conquer cancer and other diseases as well. We know that actually good science drives progress, and that progress can lead to products for people. I'm also involved with cancer vaccines and some other remarkable ways that we've been able to reverse cancer from stage 4 to stage 0, single patients right now. However, those are not solutions for the present. What is a solution is our nutrition, our diet. And I want to speak to the fact that food as medicine is a terminology, it's part of the national global lexicon now. My approach has been is to take the lessons of drug development, the rigor of science, and apply the study of food, specifically using those same methodologies so that we can actually have real scientific data. That is going to be the future of nutrition, and especially when it comes to cancer, it is something that not only can prevent cancer, but food and medicine at the microbiome and other polyphenol levels can amplify immunotherapy, amplify targeted therapies, as we just heard about, and can provide a way, convenient, accessible, fair way to be able to have secondary prevention for those cancer survivors. So this is not a sidebar topic. This is a central issue. To tell you how interested people are in this topic, I wrote 2 books that wound up become, for the public, that wound up become New York Times bestsellers. So it forced me into the social media stage. unlike many social influencers, I have a real scientific background, 30 years worth. I also am a fully trained clinician in internal medicine, with vascular medicine being my specialty. I'm also a deep scientist that happens to enjoy translating complex information for the broad public. So, a few months ago, I posted a single static image of what you can do to avoid cancer message and showed some simple graphics. And that single post had 36 million views, showing that credible people with real scientific knowledge can distribute through social media, a new channel we didn't have before that can actually impact on public behavior. And many of you actually who know me have already talked about how that's impacted their own lives. Now, I want to actually just say one thing about the polarization of our times is actually preceded by the polarization of the topic of nutrition. There are intuitive things about our food that people talk about all the time and believe to be true. But if you actually take what I just said, that we can use science to study our food at an individual level and understand which is not only better foods, I think there's a lot of emphasis on bad foods. That needs to happen. As Dr. Oz mentioned earlier today, my focus is on what are the best foods we should have, inclusion, not exclusion. Within inclusion, one would argue that fruits and vegetables, eat the rainbow, makes a lot of sense. However, not good enough for us. In this room, we have the brain power to really think about the future. So I've been doing work at the Angiogenesis Foundation to take a good food and to figure out which is the best of the good foods. So I want to show you, I promised I wouldn't show a lot of slides. I want to show you one slide of a non-controversial healthy food with cancer-fighting ability, blueberries. And we compared blueberries you can buy online in a grocery store, and I've blinded the trade names because that's not what this is about, to look at what is the highest levels of cancer-active polyphenol, in this case anthocyanins, and you can kind of see that they handpicked wild blueberry at the very bottom is the highest in terms of anthocyanin level. This is side by side, but when you look at other types of blueberries, organic isn't necessarily the best. That's counterintuitive. And you can see, however, that cooking here into jam, taking the last bar, the highest bar in the bottom, and you cook it and you boil it, and turn it into a commercial jam, you actually destroy most of the polyphenols. So this is an example where the God is in the details. We as scientists can find those details. We can communicate the details. It has implications for agriculture, ag policy. It has implications for supply chain. It has implications for consumer choice and messaging. This is what we need to do from a research perspective, as well as collaborative perspective, as well as a communication perspective. Now, I want to show you just one more example of an intuitive thought that might not be true until you do the research. Using this same bioactive anthocyanin, which has cancer-fighting, anti-inflammatory, anti-angiogenic, anti-growth factor, lower inflammation ability, we looked at purple sweet potatoes. Purple potatoes, this is the natural dye to make it purple. You would naturally assume that the uncooked raw version is going to have the highest Mother Nature instilled amount of anthocyanin. And we plotted this on the bottom. You would assume that cooking and roasting the food would actually degrade it. Makes total sense. But yet we found that you can amplify it by 88% if you roast the same raw purple potato, same varietal. Big surprise. Probably because the heat unpacks, loosens the bioactive from the starch matrix in which it happens in a potato, but not in a blueberry, necessarily. Now, we also assume that processing foods will not be good for us and destroy polyphenols. In this case, we show if you put it into a can, steam cook it, pressurize it, have a chef work on it, make it commercially available. This is going to be a product that should be available later this year. We're not making it, but we're just testing it from commercial sources, that you actually still save you have still have 42% higher levels of polyphenol that you would have assumed would be degraded. So my message here is that food as medicine is become a real science whose time has arrived for us to invest in the brain power, the resource, the funding, and the collaboration that we need in order to be able to make the same commitment and to deliver on what the National Act on Cancer promised back in 1971. Thank you.
So, Bill, it's a pleasure to have you here. And with the backdrop of what we've just talked about, cancer prevention in terms of where we are with genetic and genomic testing, where we are with food as medicine, what is your perspective in terms of clinical practice? What can we translate into the patients and the care we're getting today to prevent cancer?
Well, I have to say, I don't think I could be more enthusiastic about early detection and prevention than I am today. Michael Milken talked to Tony Latai. He said it's hard, and it's been hard. There's no question about it. But I decided to, in thinking about this panel, to think about the original early detection test. About 100 years ago, Georgios Papanikolaou, working with his wife at the Cornell Medical College, applied the tools of what we would think of as cytopathology to exfoliated cells in the vagina to be able to detect and diagnose cancer of the uterine cervix. You know the end of this story. It becomes obviously the pap smear. But remember, when they were first deploying it, it was what we think of as prevalence screening. They were detecting cancers, and not that early, really. It wasn't until they started to see women who had negative tests repeatedly and then a positive test, so-called incidence screening, that they were really detecting things early. And look what this can teach us. They weren't really detecting cervical cancer. They were detecting a pre-malignant condition that has equivalence in almost every one of our cancers. And the interesting thing about that is I had a chance to catch up with Jim Allison and Pam Sharma last night. Most of those pre-malignant lesions go away on their own because the immune system eliminates them. High-grade cervical intraepithelial neoplasm, 70% of it goes away on its own. Here's the opportunity to harness the power of the immune system. We can detect and define pre-malignancy. It's asymptomatic typically, not a problem most often, and we can treat it. We already do that effectively when we can. I was with Monica Bertagnoli last night. Polyps in the colon, we remove those. Most of those aren't going to become colon cancer, but we remove them and we reduce colorectal cancer. So can we tune our technologies to detect pre-malignancy in a way that we can treat it, activate the immune system to eliminate it, and the best prevention, somebody said earlier, is don't get the cancer at all. Can we prevent people from getting it altogether?
That's excellent. So with that, I appreciate our panelists. I want to open it up to questions in the room or comments or thoughts that you might have about cancer prevention. Karen.
So this is a business question. So, because I think you and I might be going down a similar path. So many individuals in the U.S. that are in that age of needing to get prevention and early detection get their health insurance through their employer. So I've been working for many years with an organization called Color Health, which is a go-to-employer strategy to essentially take on the role of reducing the friction points for early detection and for actually navigating people into cancer screening. But over and over, what we get told from some of these major employers is that their workforce turns over every 2 years. So they actually don't want to engage in a prevention or early detection program. What they're really saying is that they hope that someone gets cancer while they're on your payroll, not mine. And so I've heard it enough times in these meetings to realize that we have a perception problem. I mean, already just from a logic perspective, it doesn't make a lot of sense, right? There's a defined workforce, and my employee of today is your employee of tomorrow. So it all falls out in the wash in theory mathematically, but that's not moving the dial in the C-suite. So how do we work with the business community to talk about the importance of human capital on productivity and really make a movement?
Well, this is a very good question, and it goes to participation. It's not good enough for us to say, we want you to be healthy. We have to help people, arm them, one, with information, and then two, advice about what to do about it. An employee I'm working with right now is in a high turnover industry, And he's going to do this because he thinks this will promote retention, because nobody else has the employee benefit that he's going to promote by giving each person a personalized risk, including their genetic risk, their lifestyle risk, and counseling, ongoing counseling about what to do about it. So I think these, our biggest gap right now is we have the knowledge. Remember, 50% of all cancers could be prevented or cured with early detection. We have the knowledge. It's now a matter of how do we get the well person, they're not healthy, 10 years before they get cancer and get them into screening and prevention programs. And I think the other part of that is going outside our usual age dictated guidelines for screening and identifying the young and middle age who are at increased risk and put them into screening and prevention programs, because that's going to give us between a 3 to 10% return on investment by putting that money into that age group, identifying the minority of people, which is where your cost is, and getting them into prevention and screening programs. Remember, an individual who presents with stage 4 breast cancer in the first year, an employee, is out of work 100 days. They're still paid, but they're not working, and then to keep them alive, they continue to cause an expense, but they're out of work. If you diagnose breast cancer at stage 1 or stage 0, they're out of work maybe 23 or 25 days the first year, but then their costs go down because they don't have recurring cost of delivering their care. So it makes so much sense to look at productivity in the workforce and working through the employer for prevention and screening as a health benefit. And then getting their employees to participate. That's going to be the next big barrier. It's not just good enough to give them information. We have to tell them what to do. Just for one example, we're all talking about GLP-1. That's great. GLP-1 does not reduce your weight unless you change your lifestyle, what you eat, when you eat, and how much you eat. It's not good enough just to take a pill to lose weight. Takes away your appetite, but then you have to have a lifestyle change, and that's going to take modification. Just like people who smoke, we need to encourage them to participate and not smoke because of their risk for lung cancer. Now we're finding the risk for 14 different cancers is related to obesity and the foods they eat.
I also want to build on that. I think that employers need to understand, especially in this partial virtual world that still exists and is probably not going to go away, that engaging through communication is absolutely vital. Rather than make a healthier lifestyle proscriptive, which is not going to work, we need to engage people to make them meet them where they are and get them excited. And so one type of corporate messaging that is, developing the corporate message is to engage people in information that's trustworthy, interesting, and relevant to make them feel like it's part of their own lives. And when it comes to prevention, we have for so long appropriately focused on early detection. But early detection is just a snapshot. Can't do it all the time. Very difficult to get everybody to engage in diagnosis. It's costly. And also, I want to point out that nobody wants to willingly find out how they might die. So that is not something that most people are going to opt in for. And that's where communication comes into play. Earlier, I said, Q&A session, how do we change the lexicon on cancer? The war on cancer, if you're a fighting person, absolutely. But actually, that's not what consumers want to hear. Consumers want to hear, we are trying to restore health. We're trying to heal the body. And I think that that's an effective message for cancer patients, cancer survivors, and people who don't want to get cancer.
And I would just add, of course, the statistics behind screening for cancer get difficult when you get younger people, and fewer of them are going to have cancer. And Charles made this point earlier. We need tools to risk stratify them, to say who's really at risk to get into trouble at a young age. And I think we're going to use measurement science to do this increasingly. Clearly, cigarette smoking and obesity, we don't have a hard time figuring out who's have trouble with that. But some of the other exposures, there's all kinds of technologies going to deliver us what the exposome is. Turns out albumin swims around a lot. Carcinogens are absorbed to it, covalently modified to it. One of the Prostate Cancer Foundation meetings, I thought my kid finally lost his mind when we were doing dog sniff cancer presentations, but we now know what they're sniffing. It's lipid peroxidation byproducts that are involved when macrophages show up in and around the areas that spawn cancer and the macrophages that sit in the cancer. There's going to be a lot of technologies I think we're going to be able to employ to target who we screen, and it'll all work a lot better. So,
yeah, and we found scientifically that the key to motivating individuals is a personalized risk assessment that combines the genes that they got from their mom and dad and their lifestyle and their family history. And instead of saying you need to lose weight, you need to put it in the pitch that you have a 60% risk of developing colon cancer, and you should really start to get colonoscopies, know whether you have polyps, engaged in prevention and screening even before age 50. And I'll finish with one statistic. The incidence and mortality of colorectal cancer in the United States is going down in the age over 60. It's going up in the age under 50. And that's because these young people are not getting screened or entering into prevention programs. So we have to go from reactive to proactive. And this is going to be a big challenge, but I think the motto of this meeting is 2035, and this is where we need to spend an emphasis. We have the technology today, but we need to translate that into the community in wellness and prevention programs.
With that, I want to thank all of you for participating with us today, and to Esther for inviting us to be here along with Mike Milken, and thanks to this panel for your contributions.
A big thank you to Gina and the prior panel. She did start by saying she was the panel before lunch. Just kidding. We are the true panel before lunch, but I'm really excited about the discussion that we're going to have because we're bringing it to the level of the patients. It was exciting to hear about prevention and early screening and blueberries. I feel better now. I don't have to spend, $10 on organic blueberries. I can spend $5 potentially. So very excited about where the future holds. Of course, we heard incredible scientific talks, right, about the state of where science and innovation and technology is taking us, which is incredibly exciting. But this panel is really focused on patients. Okay, so all of that happens. We understand all of the scientific information. We've gone through the labs. We have some preclinical. And then we get into clinical trials and getting patients enrolled into clinical trials. And we hit incredible amount of inefficiency, right? 80% inefficiency in terms of where patients are enrolled, staying enrolled in clinical trials. Less than 5% of oncology patients, as the data say, enroll in oncology clinical trials. Despite all of the numbers that we just talked about and heard about in terms of incidence and even mortality related to cancer mortality and morbidity. So as we go through this panel, we really want to talk about not just the challenges, but what are the sets of opportunities? How do we think about the clinical trial infrastructure of the future? So much of what we're going to talk about in this panel reminds me of COVID-19, right? During COVID, we saw in such stark terms the opportunity. We had clinical trials that were opening up on the East Coast and West Coast following the virus. And then it moved to the middle of the country, and then we couldn't enroll people because we don't have national trial networks that are established in the middle of the country. People finally learned about this wonderful opportunity, but they could not participate, something we've known long before. So what I'm going to do is actually to start with, Ed, with you, to give us a picture, City of Hope. You're the physician-in-chief there. You've been thinking about clinical trials for a long period of time. You're working toward establishing a national clinical trial network. Talk to us a little bit about what does it take to do that, and where are the barriers and the opportunities from your perspective?
Thanks. First want to correct that no matter what type of blueberry in California, they're all $10. So whether it's organic or non-organic. You try to think, as someone who grew up in the Midwest, in Indiana, small town, you try to think about where those gaps are. And those gaps are opportunities, obviously. So I was tasked about 2 years ago from our CEO as we began to expand City of Hope. Right? We built a new campus in Orange County. We've acquired assets from the prior Cancer Treatment Centers of America. So now we have campuses in North Chicago, South Atlanta, and Phoenix, as well as 30 plus sites, regional sites across the country. And how can we connect these sites? And so first is the North Star. The North Star you establish is the why. And the why is because we believe that every patient who comes to City of Hope or comes to any center deserves the opportunity to be on a clinical trial. They may not qualify, but they deserve that opportunity. The second then is foundation building. What kind of infrastructure do you need to be able to enable this? Because all of these fantastic scientific hypotheses, these science breakthroughs we're hearing, they only mean something if you can get them to the patient. So what does that foundation look like? And then it's speed, scale, serve, right? How quickly can you open the study, the speed? The scale is, it needs to be open more than just at an academic center. It needs to be opened closer to where you are at home. And serve is then creating that access for these patients. And so we've been able to do that. We have a sort of a centralized, decentralized model. So we can run a study now at City of Hope. We can activate in 88 days. And that's a nice time because in your cancer institutes, you have to be under 90. But then also equally important is what you measure afterwards. And that's when is the first patient enrolled? And sometimes that's months. Ours is 19 days upon activation. We can open a trial as quick as 45. And how do we do that? We have a single IRB, single contract, single budget, single PI across all 4 of these states. We can deploy a study in as many as 40 sites or as many as few as 1. Now, we don't open every trial at every place because that's not efficient. But we've built into this framework a just-in-time model. So, practical example, patient from Florida contacted us. Young lady has a mutation in her cancer. Saw on our website that we had a clinical trial that fit her, but it was only open in California. And she could go to Atlanta, which is not too far away, if we had it open. So I was called. Do we have it open in Atlanta? No, we do not. Could you open in Atlanta? Yes, we can. And we can do that within 10 business days because we've set up all the regulatory aspects ahead of time. And now we just need to do investigator and site training. And all the companies had agreed to ship drug. So this is the type of model that we're trying to put together. If my CEO tomorrow said we acquired another site in South America and we want to get trials there, our office is prepared based on how we've set up our infrastructure to say, yes, we can implement clinical trials there. Now, we'd have to have some international discussions regarding contracting and drug shipment, but those are the logistical aspects those are the things that are holding you back, not the fact that we didn't enable this system. So it's really important to understand that when people enroll on a clinical trial, it's not a privilege to be enrolled in a clinical trial. It is actually one of the most altruistic acts that a patient can do because they are trying to further the development of an experimental drug to see if it'll be better for the rest of their community. And so we have to enable this altruistic act as much as possible. And that's our North Star. That's why we continue trying to push the envelope and want to bring even the most complex studies, phase 1, CAR-T, to all of these centers.
I mean, Ed, you said so much there that was incredibly powerful. You have established an entire process end to end where you can create those efficiencies. And Marjorie, I would love to turn to you to respond to what you just heard, because in many ways, the challenges that we're talking about solving for clinical trials across the country, that's being solved for in this model, right? The question is, how do we replicate that model? So as you are the clinical development lead for oncology for Merck, where are the challenges and opportunities from a large pharma perspective? Are we closing the gap and seeing more City of Hope models around the country, or are we still seeing significant barriers in getting patients enrolled in trials?
No, thanks for the question. And Ed, I love hearing what y'all are doing at City of Hope. And there are other groups who are trying to implement and institute similar models in the United States. And I think this will help remove some of the barriers. The barriers are systemic and multi-layered and multifaceted. Some of them come from the pharmaceutical side because of the complexity of our studies, the way that contracting is done. Much of what we do, you know, that drug development is highly regulated. And so we tend to err on the side of caution to ensure that we have gathered every possible piece of information possible. And our studies can be complex and therefore operationally challenging for sites to be able to implement and to conduct. So there's a huge resource aspect of this that goes to individual sites, to the study coordinators, to the PIs. There is the amount of data collection and our fragmented EHR system in the United States and the ability for it to go back and forth in between a sponsor like such as Merck or other kind of pharmaceutical company and the sites is very limited. And then you add in some of the complexities about how we ship our drugs, what we need from the FDA regarding 1572s, and there are lots of opportunities for us to streamline this. So when I hear what City of Hope is doing, it makes me so excited because there are groups like City of Hope that are trying to do real-time site activation, who have networks of sites that are not only in the Houstons or the LAs or wherever they are, but they're also getting out into the community because we know that 80% of oncology care is delivered in the community in the United States. So being able to reach those people is very critical. So I think that we are on the verge of things getting better, but right now, U.S. enrollment in clinical studies is still quite low. I think when you look back, there have been Transcelerate and other groups, it's less than 10% in many studies. And in my younger days as a clinical investigator, it used to be the United States and the EU were the primary sites of enrollment, and now it's actually shifted out of those regions for a lot of varied reasons. I think Ed is correct in that patients are donating their health to go on clinical studies, but there are also barriers there as well, and mistrust in science, mistrust in clinical studies. Again, it's systemic. I think there's hope and there's progress, but we still have a long way to go.
Are you saying that trust in the U.S. is declining with enrollment in trials, or are we talking about structural inefficiencies in the fragmentation that you were just alluding to that makes enrollment in the U.S. particularly more difficult, and that's why you have these multi-regional trials that are occurring in many locations around the world? What's a driving factor from U.S. perspective?
I think that it's the latter more than the former. I think there's always been some suspicion of clinical studies for very good reasons in the United States, thinking back to historical trials where people were enrolled without their knowledge and treated without their knowledge. There has been a perception that if I have no other choice, I might get my last hope, then maybe I want to participate in clinical studies. It's very different in adult oncology than it is in pediatric oncology, where most of our registration phase 3 clinical studies is something that is standard of care or something we think that's better than standard. And the other aspect of this is that there's significant heterogeneity of what is considered standard in the United States. It's much more fragmented than people realize, and what might be the most recent regulatory approval that looks like it's better than other things, you have significant fragmentation in the US of what is done in academic centers versus what is done in community practice. And then it creates, patients have opportunities to get all of these great therapies, and so they don't always feel the incentive to go on there. So it's both of them, but I do think our structure and the way that we work is probably the biggest barrier. There are also policy kind of issues and other things that play into it, but patient reluctance in the United States is stronger than it is in other sites in other regions.
Interesting. Well, that's a great transition to you, Rick, because you've observed this for 26 years.
And plus.
And plus, certainly in the last 20 with the Oncology Center of Excellence, and prior to all of that, as you see trials in cancer care around the world, what are your suggestions? How do we improve the system? Is it really a point of care? You know, you've been very much an advocate of integration within EHR. How do we transform this field that we just talked about, and we increase these enrollments that tend to be very low at U.S. sites?
Well, the first thing I have to say is you missed one thing. We're all from MD Anderson here, and all we have to include is Chuck and Andy Von E there standing there, and we'll have a whole MD Anderson reunion here. That being said, get to the serious aspect here. We are our own worst enemies, period. Okay, we have made this system way too complicated and continue to make the system way too complicated. If you take a look at what's going on in China and in Australia, and I've taken a look at these systems, they've simplified things. They've put much more power in the institutions, in institutional review boards, in scientific boards that are at the institutions to try to escalate the initiation of these trials. In industry, there's only one thing that is important, or one of the primary things that is important, and that is speed. So how do you get sites activated as quickly as possible, and how do you make things as efficient as possible? And I think here we've made systems that are way too complicated, and we have to take a look at going somewhat backwards and taking a look at what are the fundamental issues that we need when we initiate a trial, what are the manufacturing, the CMC issues, what is the steps in activating sites here in the United States. There's nothing special about China. There's nothing special about what's going on in Australia that we cannot duplicate here, but it's really taking a look at how to make this system more efficient. And I think that is one of the central processes that we really have to take a look at as in this idea of stepping backwards. I was recently at a pharmaceutical company, and the fact the name is floating around here on one of the top things. And their protocols were so complicated. I said, you know, this isn't a protocol. This is really a development plan. You put the entire development plan in one protocol here. It's impossible for people to even follow what's going on, let alone give patients informed consent. And I emphasize, you know, simple is sometimes best here. And if you get a drug approved relatively quickly, that's a good thing. It gives impetus to further development of the drug. So this idea of looking at greater simplicity in clinical trials is very important. One of the things that I have traditionally have really pushed in the agency over the past years when I was there is pragmatic trials, okay? Trying to answer questions in a very simple fashion. What is the direct question that you want to answer? We did this with the lung map protocol several years ago. It was activated by the NCI in record period of time, had record enrollment, particularly of underrepresented groups. It answered the question that we needed. When we were designing the trial, I had to basically beat back the investigators because every investigator wanted to add something on the trial. Why don't we take a look at response rates? Why don't we take a look at quality of life? Why don't we take a look at this? Why don't we take a look at this? And the answer was no, 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 and no. We just need one question answered, and then let's move on. And I think here again, it's a system approach that we really need to take a look at what the system is. Now, when you take a look at what's going on in Asia, particularly with China, you have a large population there. It's centered around major cancer centers, et cetera, and they're able to enroll record numbers of patients. I was talking to one of our neurosurgeons at the FDA recently at lunch, and he said, well, I just see like maybe one craniopharyngioma a year, maybe. If you go to Beijing, for example, they have an entire ward. They have 28, 30 patients with craniopharyngiomas there. So there's something different there that we have to try to emulate here, and that's why I was trying to emphasize the electronic healthcare record. One of the things I was trying to push the agency on was, number one, get informed consent to be central, rather IRBs, I should say, to have a central IRB. That's going to be fundamental and really push that. We can't have individual IRBs for multi-regional trials. It just doesn't make sense. The other thing that is very time consuming is really addressing the issue of central, of really a uniform contracting mechanism. Take it or leave it and let's move on. We can't spend 9 months negotiating a contract because the study is already completed. Where I take a look at the electronic healthcare record is really trying to embed clinical trials within that system, have a portal attached to the electronic healthcare system that identifies protocols for the physician, randomizes those patients if they decide to go on the protocol, have the informed consent, have the data taken directly from the electronic healthcare record, embedded in a cloud. That cloud has the regulatory agencies as well as the pharmaceutical industry has access to that cloud. It eliminates a lot of the duplication of effort. So the bottom line of what I'm saying, one sentence, make it easy and simplify.
All right, we have that as a takeaway. When you talk about embedding trials into EHR, I can't help but think of Judy Faulkner at Epic with Cosmos, where they are focused on embedding trials into EHRs with the 300 million patient records. Are you talking about something like that model, or are we talking about a different model? Because obviously trials are not ubiquitous, they're very heterogeneous. How do we ensure that we have the right patient selection based on those eligibility criteria that you just said?
I think AI could easily do that, okay, and easily identify studies that patients could go on and really flag those studies for the physician and have the informed consent contained in that portal, so to speak, so that is contained. So in essence, what I'm trying to do is put CRO somewhat out of business here, folks. Because here again, much of that material or much of that work that is being done from the site perspective can easily be done now in electronic healthcare record and take that data directly. So you don't have to have, well, was something miscopied, et cetera. That information comes directly into a cloud that the regulatory agencies have access to, not only the US FDA, but all of the international drug regulatory agencies. So really, it's a sustained process that we're looking at here.
I wanted to add one thing about eligibility, that Rick brought up, and he was intimately involved with this work, was that we are our own worst enemies. We write these protocols with a median number of 35 to 40 eligibility criteria, some of them of which are not scientific at all, based on the population you're trying to do. And so it makes you have to develop even a more complex LLM or AI to actually help sort those. I dream of a day where we can actually get down to 10 eligibility criteria on a clinical trial, because we want to see big differences in these effects, not the tiny differences. And so this was something that ASCO, Forensic Cancer Research, we spent a lot of time
When we
on.
did the pragmatic trial, we did keep it relatively simple. It was like whoever in your practice would get this drug. These are approved drugs, so you don't need any special thing here as far as eligibility criteria. If you would use it in your practice, that patient goes on the trial.
I mean, I think about how our regulatory process is divorced from our payment process. So you're adding actually a lot of data element up front that may answer payer questions. So although the regulators want to simplify it, the system itself is so complicated that more is being added on to try to mitigate for downstream effects. So that might
And we
be
have to fight
that
against
might be
that.
contributing towards that. Okay, Dr. Sharma, you are an expert in immunology. The future of cancer is immunology, as we've heard about. How do we get more patients enrolled in trials? What is your recommendation for how we transform the clinical trial ecosystem?
So first, I want to say the future of cancer is science. Immunology being one of them, of course, but science. And so when we think about science and how it's transforming the way we envision clinical care, what I want to say is we have to stop thinking about this as lung cancer, bladder cancer, renal cell cancer. We have to start thinking about it from the scientific basis of understanding the cancer. What's the driver mutation? What's the immunologic environment like? How are we going to then make a decision about running a clinical trial, not based on a lung cancer diagnosis, but based on a tumor mutation, based on an immune microenvironment? And then we're enrolling patients based on understanding of that science and the technology that we now have at our fingertips to define that tumor other than just your origin, right? And I think that's where we're missing. The technology we have today, single cell RNA sequencing, genomic sequencing, all of these things that we're doing, we have sort of siloed them into the labs, and they've not really made it into the clinic where we're making clinical decisions based on this information. And this can revolutionize how we then enroll for clinical trials and our success in clinical trials, because we fail in clinical trials based on the heterogeneity of the science. And if we can have more homogeneous data sets to say these patients are the one that have the right scientific background, whether it's a mutation, whether it's the immune microenvironment, whether it's the microbiome status, that's how we enroll the patients. The other thing I think about to help with clinical trials is that we have to stop thinking about phase 1, phase 2, and phase 3 as the only way of doing clinical trials. We have to already think about what is our, I don't know what to call it, phase 0 window of opportunity, but what is the 10 patients you are going to do your trial on to show that the mechanism you learned about in a mouse model or whatever model you're testing is the actual mechanism you're still targeting in the human being? Before we get to 300, 500, 1,000 patients, did you actually target that mechanism? And did you target it without a compensatory mechanism that's now blocking your response that you should get? We don't know enough about that, and we tend to move forward very quickly into these 1,000-patient trials. And so I'm hoping that as pharma companies develop a trial, we can push them to say, I want a 10-patient study that where, you have looked at the patient samples and collected that longitudinal data and shown that the mechanism is correct without an inhibitory pathway popping up to block it. And I think if you do that, we're happy to all then move forward with 1,000 patients and we'll have more success. And I think the academic partnership has to happen, because if you want to do that trial, it's easy for an academic institution. At MD Anderson, we see 1,000 new patients a week. So we can enroll these patients very quickly, and we can definitely do all of the advanced technology studies, but then we would have data to drive forward that. And that kind of alliance partnership between academia and pharma, I think, has to move forward as well. And then I want to echo Rick's point. We need to get rid of the CROs. They're completely inefficient. I'm sorry, I don't know if anybody in here, but they're not helping us in terms of moving things quickly. And when I'm sitting in front of a patient, I see patients once a week. I'm looking at my patient in the eye and trying to say, these are the steps we have to get through for a clinical trial. And so these are the things we need you to do. And then I have to say, oh, wait, did we get that all copied back into the CRO, even though it's in the electronic health record? So these are the points I want to make and make sure we address them.
Well, Marjorie, I would love for you to respond to that as well, the sets of recommendations and comments that you've heard. Really with this final question before I open it up for any questions in the room, how do we address all this in the next 5 to 10 years? If you think about your ideal system, what does that look like to you? How would you design such a system so that as a global manufacturer, as a global product developer, you can say, our goal is scientific. We want as many patients enrolled as quickly as possible so we can have those insights. What does that system look like from your perspective?
Yeah, no, thanks. And there has been a lot of evolution of how clinical studies are being considered. To sort of what you're saying is that now you see more pharmacodynamic biomarkers being put into phase 1 studies to know, are you hitting the target? There's more functional imaging now being put into phase 1 studies to understand before you do large studies. And I think it has to do with the evolution of science and understanding the biology of cancer better. Before, you heard before, it's like chemo, chemo, chemo. And unfortunately, for many tumors, chemo is the primary option still, often with a checkpoint inhibitor. But as that science improves and as we move our modalities to more targeted therapies, to different types of therapies, you're seeing this interest in understanding the biology and knowing, are you hitting the target? It helps with dose selection. It helps with understanding the benefits before we engage in larger studies. Going into the question, so I think, again, Merck is a U.S. company, and I would love to do our studies primarily in the U.S. and in regions similar to the U.S., as I did when I was a very young researcher. And I think to be able to get to that place, everyone needs to understand that these studies, we are answering important clinical questions for patients, but we also are doing things that are designed to make them available. And you heard access come up in there. And so it's going to take agreements between sort of like a group you have up here, representing different aspects of the U.S. system, and how is it that we can make things to where the regulations are in place where someone who's on Medicaid and participates in a clinical study, if they are given transportation money, that doesn't count towards their income, so they are kicked off Medicaid. How do we ensure that people who participate in clinical studies, that the family member who brings them can get off of work and be able to support them? How can we get the electronic health records, which are very different inside every different state? Epic is fantastic, but it doesn't cover the entire United States. How do we get people to have systems that at least can talk to each other, and then industry can work with that in a way that's compliant and protective of patients? I think we can get there in a 5-year period. And then AI can help with some of the resourcing issues that you have across all of this because of being able to look at data. It will further science because you'll be able to get biomarker and correlative information. It will help regulators have more transparency into the data. It will help with real-time monitoring so there's less burden on sites. It will help decrease the number of people because the number of people who are working with the CROs or even a sponsor like Merck, because we have everything in-source, it's a lot of work for sites. And so all of these things, so focusing on EHR, getting the AI systems in place, helping to remove the barriers for patients from a general policy perspective across the regions, and then working with regulators to understand what is the minimum information, because Rick and I were talking about sometimes companies misunderstand what the FDA or whatever health authority it is in the globe actually intends on things. And so simplification and streamlining, I think it's within our power to do within the next 5 years.
Yeah. And then, Rick, we have many that are advocating for an American version of a clinical trial notification system, the way that they do, where it's largely driven by the IRB. Is that the recommendation that you would have for us as we think about IRB reform going forward and getting more efficiencies in clinical trials? Is that the fundamental rate limiting factor?
Well, I think there are many issues here, and they really need to be examined. Obviously, those are the low-hanging fruit that are obvious to most people, the role of the IRBs and to have central IRBs, contracting mechanisms. But also when we take a look at earlier clinical trials, is putting more emphasis on what goes on at the sites rather than on a national regulatory agency. And that's what's been happening with China and Australia, is much more emphasis on the regulation of these trials from a local perspective rather than a national perspective. But also things like how much manufacturing information do you need about a drug, especially when it's going into a life-threatening disease, so to speak. And as we all know, patients are willing to take more chances when they have that situation. So I think that it's a very complicated issue, but it is not rocket science, okay? It's something that we've done to ourselves, and so we could correct this very easily by having a really focus on this, and I think that is real government really needs to come into play here.
Are we ready for that? Do we have that leadership? Yeah.
I hope so.
Ed, what's your vision for the next 10 years? We're talking cancer 2035. Where should we be in the next 9 years?
Well, I think we have to have discipline, right? All the lab experiments you've seen, there's so much discipline to break through these technologies. There's so much discipline that's needed to operationalize drug development, et cetera. We have to have discipline. I don't think we measure the right things. What we measure very closely in our institution is not total accruals, it's accrual rate. And that's based on when we open a study, how many patients, how are we going to follow, and a time period. And if you fall behind, then you get a little love letter from me to say, hey, you're running behind here. So we have to measure the right things. This will drive efficiencies. When we can enroll more patients than ever with less numbers of studies and not have to spend all our time shutting down studies that are underperforming, there's a reason why they're underperforming. So I think the future is, can we do it close to home? We learned during COVID, we can deliver close to home. Can we make the right metrics and make us efficient? And that will create access. And I imagine an Amazon marketplace one day where people can go find a trial, because you can find your products a lot easier right now, shoes and clothing, than you can a clinical trial. And we got to break through that.
Yeah. Pam, what's your vision for 2035? Where should we be?
I think it'll be less failed clinical trials, more successes based on real science and real data. I think it'll be an alliance between academia and biotech and pharma companies where we do iterative process in 10 patients, 10 or 20 patients, where we say, this drug is doing what it has, this should be the combination you move forward with, or this drug has an inhibitory pathway, it needs this other drug to complement it. And so before we even get to developing that big for phase 2, phase 3 trial, we've had all of these details between the academia and pharma. And this is an iterative process where then you then get to the more successes and you really de-risk the failures early.
Excellent, excellent panel. Thank you all very, very much. I really appreciate your thoughts, your vision, your perspectives, and your challenge. Let's simplify it. Thank you so much.
Thank you.
I do have instructions. We are all at this point going to take a break for lunch. So what you need to do is you get up, you go to the buffet line, you get your meal, you come back and you sit at your table. So everyone can now break for lunch. Thank you so much. All right, welcome back, everyone. Thank you so much. Welcome back. From breakthroughs in science to the people who make progress possible, we'll now like to turn special attention in our program to recognize and celebrate an individual whose leadership and dedication have made a lasting impact in the fight against cancer. I am pleased to introduce Ambassador Robert O'Brien, who is the chairman of the board of directors of the Richard Nixon Foundation and co-founder and chairman of American Global Strategies. He was the 27th United States National Security Advisor from 2019 until 2021, and currently serves on the President's Intelligence Advisory Board for this special presentation. Thank you and welcome, Ambassador O'Brien.
Well, thank you all. It's great to be here. And Mike's got just an amazing institute. I love coming here. The American dream. The American dream lives here, Michael. So it's amazing. Thank you for hosting us. And I was in California yesterday. I flew out of Palm Springs last night. The weather was fabulous. And everyone said, don't go to the East Coast. There's a blizzard. There's 3 feet of snow. And we can golf tomorrow. Yeah. But we're going to a great award to Marlene. So I said, no, I'm going to get on the plane and brave the snow. I think I brought the good weather with me. So let me first, before I get started, ask Melanie Eisenhower to please come join me, and Ellen Siegel. Now, one of the great things about the Nixon Library is we've got Chris Cox and Melanie Cousins and direct descendants of President Nixon, and in Melanie's case, President Eisenhower. I happen to be a member of her great-grandfather's golf club out in Palm Springs, and on the 11th fairway is his old home, and there's a statue, a beautiful bronze sculpture of President Eisenhower, and we always stop and pay tribute to him on the 11th fairway. So great to have you both here. Chris Nixon, unfortunately, was coming from New York, which does not have the same benefit that we have out in California, and he is under snow, so he couldn't make it. But Ellen is going to join me and take his place in presenting this award to Marlene. As early as the 1968 campaign, and then in his first inaugural address, President Nixon described his foreign policy goal as a generation of peace. During his presidency, he said that more than anything, he hoped that his legacy to America and the world would be a legacy of peace, a generation of peace. And in fact, the world had 16 years of peace following President Nixon's term. So he was right. We heard last night, as President Nixon spoke about his domestic legacy, that key legacy was the Cancer Act of 1971, National Cancer Act. He said, I hope that in the years ahead, we will look back on this day and that the action being done is the most significant step taken during my administration. The Cancer Act was the most important thing he was doing in his entire administration, including the SALT talks and everything else. He thought this was the most important. So talking about the Cancer Act, he said in a phone call to his HCW, the old HHS secretary, it will do some good. Whether there's a breakthrough, that of course is maybe too much to hope for. But they're going to make some slow progress and maybe dramatic progress. And who knows, let's just hope that they do some good. The progress that we're seeing today is unbelievable. And for all the doctors and researchers and executives here who are behind it, thank you all very much. God bless you for what you're doing. In 2021, to mark the 50th anniversary of its signing, the Nixon Library opened a special exhibit entitled A Commitment to Hope, Richard Nixon and the National Cancer Act. Now going back to the award that we're going to give to Marlene, we have an award called the Architect of Peace Award at the Nixon Library. It's not an annual award. It's given from time to time by the board of directors. It's been given to 4 presidents. It's been given to Henry Kissinger, John McCain, and others. And today we're going to start a new award. And so this afternoon, it's my great honor and personal privilege to present the Nixon Foundation's Legacy of Hope Award to my fellow board member, Marlene Malik. Marlene, come on up here. Let me read the citation, why Melanie and Ellen presented to her. Throughout her life and career as a nurse, a wife and a mother, a healthcare advocate, a community leader, a hospice home care volunteer, Marlene Malik has been an exemplar and an inspiration. 30 years ago, with her friend Ellen Segal, Ellen's here, she co-founded Friends of Cancer Research. Today, she is the vice chair of that powerful and proactive organization that has made such a significant and tangible difference in the lives of cancer patients, cancer research, and cancer treatment. She was president of the creation of this conference, and her commitment and guidance to the sport have been central to the Cancer Conference's great success. Her life, her work, and her philanthropy have made hope happen for so many, and the Richard Nixon Foundation fondly and proudly presents you this Legacy of Hope Award. Thank you, Marlene.
Thank you.
Congratulations.
Thank you.
The award is from Tiffany. The Architect of the Peace Award is not from Tiffany. But this award is from Tiffany, and it's beautiful. And let me stand next to you. Drop the Tiffany Award. Yeah, please. Thank you all. Thank you for attending the conference. And on behalf of the Nixon Library, again, thank you to Michael Milken for hosting us and sponsoring us. And continue the great work you're all doing. God bless you all. Thank you.
Wow. Good afternoon, and thank you for this wonderful, wonderful recognition. It's an honor to be with you all today. So about 6 years ago, the Nixon Foundation approached me. So about 6 years ago, the Nixon Foundation approached me about hosting a cancer conference to mark the 50th anniversary of the President Nixon's signing of the National Cancer Act. My first call was to Ellen Segal. Together, we agreed that Andy von Eschenbach was the perfect person to spearhead it. And Andy said yes. And he hasn't stopped since. This is our 5th conference now, and each one has been more successful than the last. So today I want to turn the tables and recognize Andy for his tireless dedication, bringing these important conferences to life. So Andy, thank you. So I'm pleased to be here today at the Richard Nixon Foundation and the Millikan Institute to commemorate the transformative advances in medical research, treatment, and care brought about by the National Cancer Act over 55 years ago. Spearheaded by the Nixon administration and President Nixon personally, Democrats and Republicans in Congress came together. Can you believe it? In 1971 to transform medical research and treatment. That's why I cannot think of a better location for today's conference, just steps away from where Nixon signed the National Cancer Act 55 years ago. And I'd also like to thank the National Archives and Records Administration for displaying the National Cancer Act. I don't know if you heard about that last night, and this is for the first time publicly. And so here today at this conference, please take a few minutes to see a piece of history for yourself and at the Millikan Center for Advancing American Dream. I think it's over here somewhere. I haven't seen it. the early 1970s, about the time the National Cancer Act was signed, my father died of prostate cancer. And if I can remember, the only treatment that was available was, I think it was radiation. And then a few years later, three of my very, very best friends died of various cancers, all in 1 year. And that was really hurtful. Shortly after, my mother-in-law passed away from this dreaded disease. So most people thought that hearing the words, as Michael said last night, "You have cancer," was a death sentence. I was beginning to think that cancer was an epidemic. Because of the National Cancer Act, we have come a long way, but we are still far from finished. So it is my fondest hope that we will all come away from this conference with a renewed appreciation for what humanity and technology can accomplish when we dedicate public and private resources to commit to a common goal. So thank you very much for being here.
Carl, Jim? So we now have an opportunity to listen to three young guys who have known each other for many, many decades. And I thought I might show you a short video just as kind of an introduction to this, relating to you, Jim. And it was 1997 in Lake Tahoe, and Jim gave this talk. Let's take a look at this video. I want to give you kind of my memory of your talk and then have you correct me as to what was actual. So the first thing I remember was you told everyone that your immune system is smarter than all the people on the planet. And,
smarter than cancer cells, which is the...
and cancer cells, and it had been doing a fantastic job your whole life. That you've had carcinogens in your body all the time, but that something had happened to your immune system. And if I remember, the three that you listed were: one, it had been compromised by inflammation or something, so it had been weakened. Two, the cancer was disguised and your immune system didn't recognize it as cancer. Or three, something turned off your immune system. Take us back. Are those the three that you had presented that day?
Yeah, basically, but we showed that this pathway we had discovered was the first one that actually turns off the immune system. And the reasoning was, if we could, it's kind of like the brakes, if we could just block the brakes, we could let the immune system keep working against cancer, maybe eliminate cancer. And it worked in mouse models. And I remember shortly after that, I got a visit from the cap cure in those days. They said, "Are you working on prostate cancer?" And I said, "Well, not specifically." And they said, "Well, you should." And so that started, I said, "Well, I will. There's no reason why, because we're treating the immune system, not the cancer, and there's no reason why this won't work for any kind of cancer."
So today we have two people who are alumnus of organizations and schools I went to. Jim, when I first met him, was at Berkeley, and Carl at Penn. So once I knew they were both there, I had to go to those schools long before Jim had arrived at Berkeley, however, or Carl. So today, for decades, cancer therapy meant surgery, radiation, chemotherapy. Immunology changed all that, Jim. How has our understanding of the immune system changed, Jim, from that day in 1997?
Well, in 1997, we were really focused just on T cells, and certainly they're the most powerful components of the immune system in terms of directly killing cancer cells. But what we've learned since then, and I think we knew it then, there's more complicated than that. What we know then, for example, is that myeloid cells in many tissues play a role, and they also interact with the immune system by turning it off or helping it. Sometimes they can behave as wound healers, sometimes they can help the tumor grow, or sometimes they can actually help attack it. We've discovered certain circumstances where the T cells can help that happen, but I think the next frontier is really understanding the complex interactions, the cellular interactions of the whole ecosystem in the tumor. One of the things that we've learned is that in the textbooks, what we know about immune systems are largely based on studies of virus infections in humans or in mice, and very little actually about what goes on inside a tumor. It turns out it's very different. There are multiples. There's at least one more step, I think, in cancer and T cell activation than there is normally in a virus response that happens in the tumor itself. And so one of the things now we know is that we can manipulate the system to cure cancer. There are, by some estimates, a study done by the Cancer Research Institute, there are somewhere close to 500,000 people that are alive 5 years or more after cancer treatment with checkpoint blockers in the world, over close to 500,000. And that was a number from 2 years ago, so the number is going up logarithmically. But we are finding that there are some cancers that we're not having much luck in. It's a lot more broadly useful than we thought. Now about 30% of all patients with all cancers can be treated with checkpoint blockade, with success rates ranging from 20% or so up to 75% now in some neoadjuvant studies in lung cancer and in melanoma. We still have a ways to go with prostate, unfortunately, but I think we've got some ideas about how to do that. So the field has changed a bit. It was all about taking the brakes off T cells. Now it's understanding how T cells are modulated by all the other different components of the immune system. It's a lot more complex, but not so complex that we can't understand it. And I think that that's the key thing, is we're learning more and more about the cellular events that go on in the tumor that allow the T cells to attack.
Thanks, Jim. Many of you in the room over the years had joined us in Lake Tahoe for scientific retreats. And so here's a picture that I keep kind of reminding me of why we're so focused on cancer. That's Ward Tripp Cassels, who probably went into 9 clinical trials and lived 11 years before he eventually passed away. And that's Larry Supsky, one of the founders of Schwab, with Chuck Schwab. And that's the beach in Tahoe there. And one of my shocks was I always thought all we were focused on was, what are we going to do about cancer, getting rid of it? And Jim let me know that one day at one of our scientific retreats, when this young girl, Pam Sharma, was there, that he told her that he loved her. So I didn't realize there was opportunities for interaction besides talking about medical research at that time. Right, Pam? Okay. So both Jim and yourself, Carl, we've invested a lot in prostate cancer, but neither with CAR T cells or with checkpoint inhibitors for a number of reasons that we find that successful, but you found it very successful, as Jim did, in other insights. What were your insights that led you to CAR T cells?
Thanks, Michael, and thanks for training all the people that have now gone in to prostate cancer therapy, such as Jim and Pam. And, we have this issue. Jim mentioned the tumor, and it's complex. Some tumors are hot, meaning they have lots of the immune system in there. And those are the ones that really respond well to checkpoint therapy. But other tumors, we call them cold. And basically, you can't find the immune system there. And that's where we have a big scientific challenge. And so my journey started on, could we use the principles of what we now call synthetic biology, which is using principles like of gene therapy, molecular engineering, and so on, to make products or cells that don't exist in nature so that they could overcome things where they're failing. And in cold tumors, that's a major issue, and prostate cancer is a cold tumor in general, so in general, checkpoint therapies just don't work, and so now we're looking at combining many other aspects, engineered viruses, for instance, that could make the cold tumor hot. Another would be highly engineered proteins like T-cell engagers that can bring cells into that cold tumor microenvironment, or engineered cells, and there's many kinds of cells. The initial ones are called, T cells, but there are natural killer cells being used, ways to use the myeloid cells that Jim was talking about, who can actually eat up tumor cells. So we, I think, have to bring in both the principles of synthetic biology and what Jim was talking about, very detailed discovery of the tumor microenvironment, which now AI, I think, and some new tools we have will allow that to happen.
So, Carl and Jim, both of you built your work for long periods of time with not necessarily any guarantees of success. So, the first question on like part one, what does history teach us about the value of long-term horizon scientific investment? And two, as you look back, could this time have been compressed with technology that's available with us today? Why don't you start, Carl, and then we'll go to Jim.
Well, sure, Mike. My case, I actually worked when I came out as a new faculty. It was on the epidemic at that time, which was AIDS infection. There were no drugs, and it chewed up the immune system. And so we started using, gene transfer to actually make CAR T cells for AIDS. And we found it actually had beneficial effects. But then medicines came out, and it became a chronic disease. It could be managed well. But we used those principles to end up making the CAR T cells that first treated leukemic patients in 2010. So it's one theme is long-term basic research sometimes can work across fields, and that certainly happened in our case.
Jim, let's go to you. You had this idea when you and I first met, this great breakthrough idea. Even Berkeley was thinking maybe of not supporting you much longer, but we quickly re-educated them on that issue. How do you feel today, looking back? Could your time have been suppressed with the technology that's available today?
Yeah, that's a very interesting question. The first impediment that I had was that nobody thought that the immunotherapy had any place in treating cancer at the time. And so I lost about 4 years by trying to convince somebody to help us make an antibody to the target, and was told over and over again, oh, it will never work in humans. And just it took a lot of perseverance to stick with it, because I think that, once you start seeing the opportunity to start manipulating something and see that you've got a handle on it and a button to push, a lever to pull on the immune system that can be effective, it seemed to me to be a something that just couldn't be missed. But where I think we can go, what would have sped it up a lot is if we would have had the techniques we have now for spatial proteomics and transcriptomics, and being able to understand that. We're now beginning to bring AI into those sorts of things to help understand, all the interactions and pathways that emerge when you're measuring every gene that's transcribed in a cell in relation to the cell next to it, because we're beginning to see that the cells affect the ones next to them. So that could have helped a lot, and is helping a lot now. Those techniques that allow us to realize that the tumor is a series of neighborhoods, and they all work together to give you the result that hopefully will be projection of the tumor, but you don't know that until you can look at the whole thing.
So, Jim, I remember the day when I was in Houston. There must have been 30 or 40 melanoma patients that you were there, all of them in remission. And I remember it was a pretty emotional day when that first young patient went into remission. My father, as you know, Jim, died of melanoma. And it really changed my life in that I had concluded in 75, 6 that science could not move fast enough to save my father's life. And so Lori and I moved back to California so that our children would know my dad before he died. And he died about 9 months later. But the world has changed. In that book, Faster Cures, that I wrote, there was an evening in New York where I met 3 melanoma patients, melanoma in their brain, their lungs, and their liver. Short life expectancy, all 3 of them in total remission from that standpoint. So I can't think of anything more rewarding, Jim. Carl, why has CAR T cells transformed blood cancers but not solid tumors?
That's a great question, Mike. I think so. There's a difference in how blood cancer happens compared to solid cancers. The blood cancers are generally not as many mutations, but they're what called gatekeeper mutations, which just make the cell be one continuous growth machine. And blood cancers start in the bone marrow, and that turns out that's where T cells naturally go. Solid cancers like prostate cancer, colon cancer often take a decade to happen, and they then, during that time, figure out ways to avoid the immune system. And in addition, it's harder for the T cells to get into those areas. So those are challenges we can overcome, but that explains why, there are 7 FDA-approved CAR T cells for blood cancer and none for solid cancer now.
So as we look forward here, Jim, there's this institute in Houston called the James Allison Institute in Houston. What are your goals, and how will that enable us to accelerate the solutions for cancer?
Well, thank you for pointing that out. I'm not real happy about the name. When Dr. Pisters told me he was going to start this institute and he wanted to name it after me, I said, you're supposed to be dead or extremely wealthy before they name an institute for you. And to the best of my knowledge, I was neither. I know I'm not one of them, but anyway. But the goal is really to build on, just to do whatever we can bring to bear on cancer, to build on what we've accomplished with checkpoints. Some of the cancers that there are many, like melanoma, where the 10-year survival is over 50%, up from essentially 0 when we started this work. And now that's the model, but we'd like to get that to 100. We're 40% or so on bladder cancer, other kinds of cancers, but basically nowhere still very far along on things like prostate cancer, pancreatic cancer, glioblastoma. I think that we're beginning to understand how to do those, but our goal at MD Anderson in the Institute is to bring together immunologists, cancer biologists, people involved in protein design, antibody production, and put them with a team of clinical people, from the oncologist and pathologist all the way down through there, to bring the ideas into the clinic to study with a clinical team that Pam has set up to do longitudinal biopsies and really study patients, understand what's going on, take them to mouse models, see what happens in mouse models, go back to humans, with the next step and iterate different interventions that we might have, just to try to build on the biology that's emerging. Every step we take, we know more about what's happening with the other cells. And now that we can study them all together, we're beginning to find key points that we think we can pull on myeloid cells to affect them as well. But anyway, the goal of the Institute is to do whatever it takes to cure as many people as possible with as many kinds of cancer, as we can.
Thank you, Jim. Carl, when I go back to Penn today, the medical complex has grown so much from the days I first visited you there. I feel like there's a university is kind of attached to a medical center at Penn. It's expanded. Talk a little about the infrastructure that you have available to you today, and let's compare it to what it might have been 20 years ago.
Well, there's really no comparison. The cell and gene therapies are something where the innovations happened in academic centers. And then now it does have, there didn't used to be a biotechnology industry or a farm that was interested in cell and gene therapy, but now we can have that, a transfer back and forth. I think for, cell and gene therapies, it's actually best developed at local institutions initially because of the just logistics and they're ultimately personalized. So we have basically an incubator installed at the University of Pennsylvania to be able to do soup to nuts, from designing, say, a new CAR T cell to actually implementing the trials. You heard from Karen Knutson today about the Parker Institute, which has allowed us to, normally we're on our own silos at each university, and now we can be in the same sandbox and transfer and have more rapid iteration of these early investigator-initiated trials. So I think that's where we need to do to rapidly now advance, because the science has gone ahead unbelievably rapidly, but I'm actually disappointed. I mean, the first CAR T cells were approved in 2017, and there's no approved ones since then. They're all the same second generation. We all in our labs, and this is true at MD Anderson and where I am and on the West Coast, we have many more potent cell therapies now in our labs, but they're not getting commercially translated.
So you've talked a lot, and we visited about the potential brain drain where young scientists are being recruited throughout the world and the challenges here. We've discussed here the ramping up in China and the ease of doing clinical trials there versus here. For young investigators, a young Carl June, a young Jim Allison today, if they want to go into oncology research, what would you be telling them today? Jim?
I would tell them that if they're really excited and they love it and they want to do it, they should keep doing it no matter what. If they're not so committed, I would say the road's kind of hard. It's getting harder. The funding situation is such that there was some talk about this earlier, but my experience was because I was a Hughes investigator and had other major support, I didn't compete for NIH grants for a long time, but I put a grant application in last year, scored in the 5th percentile, which back in the days when I used to get them, I did better than that, but that's pretty good. I mean, that's any other world, any other time that would have been fundable, but it was not fundable this time. 5th percentile, and the 1 in 20 grants getting funded. Turned out the pay line was at about 3%, with some people at 4% being paid. But it's right now. I haven't seen the second round since then. I don't know what's going to happen. But if you tell somebody they're going to start in a career and they've got to put in a grant application every 3 to 5 years and they've got a 1 in 20 to 1 in 33 chance of getting funded, do you think would you do that? I mean, mathematically, I don't know anymore. I'm worried. I'm seriously worried about it. The restrictions too on immigrants. The fact that it's harder and harder now to get people to get work permits to do science. We're not training people in the U.S. properly to do these things. We're going to be in bad shape in a few years. So I'm worried, and I'm recruiting people to my program, trying to raise money to help them, as an alternative to NIH money, not as an alternative, but just something that could help them get data to make them have a better chance at being successful. But I'm very worried, to be frank, and we'll have
Carl?
to see.
Yeah, there is, Michael, unfortunately, after what happened last year, I mean, our university has cut back by about a third the amount of graduate students that we admit, which means we don't have the next generation, and the other ones are going overseas. Last year, the only grant I got was from the European Research Commission because of the issues that Jim just mentioned. So we need to fund the research that's going to give us the ability for new drugs to be developed.
So you can imagine here, one of the reasons we are focused so much on this is that we see a substantial increase in philanthropic funding coming. And as I mentioned last night, it is estimated that as much as 20 trillion is going to be given to foundations and philanthropic activities here in the next 5 to 10 years, which would increase funding by $1 trillion a year. And so this transition is difficult from that standpoint to address. And so part of our efforts here are a call to action. So let's take us forward 10 years is the last question. It's 10 years from now. Carl, you have a cancer patient walking into the University of Pennsylvania. How will that patient be treated differently than today?
Well, I think, first of all, Michael, they will be treated based on ultimate personal diagnosis. So we'll have precision targets identified, and there are synthetic lethals for most cancers, and we will have on warehouses the ability to target those. In 10 years, most CAR T cells are going to be made right in the body. It won't be taking the blood cells out and complex engineering. So it'll just be the physician will order an off-the-shelf therapy that's targeted for that patient's particular tumor.
Jim, if I'm walking into the Allison Institute and MD Anderson in 10 years, how is it going to be different than today?
I think that we will have a pretty good map of what the cells in different kinds of cancers look like, the molecules they express, the targets they may have. With a little sequencing, we may be able to predict neoepitopes that could be identified, and with a combination of neoadjuvant application of checkpoints with perhaps some surgical reduction and some drugs against some of the new targets based on what we know from our cumulative studies. By then we'll have a lot of data, what are likely to be the regulatory mechanisms at play in the immune system, put those all together and come up with a treatment plan that'll involve probably surgery, some sort of immunotherapy for sure, a little bit of chemotherapy perhaps, and vaccines. I think a combination. And I think that we'll be able to cure a lot more patients than we are now.
So to me, you've outlined tremendous increases in technology, what our knowledge is. And as I mentioned last night, in 1995, we estimated eliminating cancer as a cause of death was worth $30 trillion to the U.S. economy, which was double the GDP of the country at that time. That estimate today would be higher. I don't know where, maybe 50 trillion, but it's at least 1.5 times the size of the US economy. And so we put it forth as an investment. And I just want to thank the two of you for those people watching this broadcast around the world today. First, for the millions of people that are alive today because of both of your work. And two, for a chance for a call to action that if we're going to eliminate cancer as a cause of death in the next 10 years, we have to double down on our investments, not cut them back. So thank you both for joining us.
All right, thank you so much, Mike. It was a wonderful session. I want to introduce a new talk. Welcome to the stage, Patrick Songchun, who is currently the founder of Immunity Bio. And we'll look forward to your perspective on how we transform cancer in the next 10 years. So over to you.
Well, Mike, thank you for having me. I just love listening to Jim and Carl. I don't think we've actually personally met. And listening to their conversations about the immune system is independent of the cancer type. It's one of the most important messages we're going to take back. So when Mike called me to say, would I come and speak about why we've not won the war on cancer and where we're going next. By the way, is this a slide mover? I'm not sure. Oh, okay, you got control. So this is the first time I've spoken for 10 years. So what happened was, when you think about this, now it's 35 years of work. I decided I'm going to use this mind map that I wrote, and I think Richard Pazder may be in the audience, and so Sean Cozen, because I presented to them at probably the first meetings of the Oncology Center of Excellence, OCE, where I presented to a room of this concept of the cancer vaccine, and I raised the hypothesis that orchestration of the innate and adaptive immune system will drive a concept called immunogenic cell death, rather than a thing called tolerogenic cell death, which we don't have time to go into, with the idea of durable complete remission, independent of the cancer type. So I was trying to recruit academics to my lab, and I wrote on the board in January 2016 what I'm trying to accomplish and the history. And during this time, President Biden, Vice President Biden asked me to participate in the Cancer Moonshot and said, this is where we're going to go. And I call this quantum oncotherapeutics. Because I saw the tumor and the constellation around it was forever changing. So rather than Newtonian physics, where things are static and you hit it with a hammer, what was changing was the tumor was changing itself, and you heard from Jim today of how it evades T cells. But at the same time, the constellation around it was changing, and the constellation is hugely complex, from the killer side to the suppressor side. If I boil it down to the essence, it's a battle between gamma interferon and TGF-beta, if I really boil it down to its essence. But it's much more than that. So I wrote on this board the events that we need to do and how we need to get there, but all at once. So I think of myself as a biological physicist, I suppose. I'm a surgeon that can walk, chew, and gum and talk at the same time. That's what most surgeons say what they do. But I had the pleasure of doing pancreatic transplants at UCLA, in which way I had to immunosuppress my patients. And then I did the Whipples at the VA and at UCLA, which I had to actually fight cancer, and trained under Don Morton, who was developing melanoma and putting tumors into the tissue of patients' melanoma. But I thought to myself, why do that? Why could we not use the tumor itself in the body as the vaccine and disrupt the antigens and explode it? I spent the next 5 or 10 years working on whole tumor genome, and we built one of the largest NovaSeq platforms to look at tumor normal and find the epitopes. And I realized, if you look in the middle of that little tumor thing with the red marks, there's thousands of mutations. We'd be whacking a mole. There's no way you can kill the tumor from the inside out. You have to kill it from the outside in. So this became this mind map. So Mike, if you're going to indulge me, I'm going to take the time to take you through this mind map, little piece by little piece. Next slide. Who's controlling? Next slide. I reduced that mind map to this elegant-looking graph, which I presented to OCE. And if you look at the top, and if you have time at the end, this is what I presented to all the thought leaders in 2016. You needed all those molecules from a GPS-guided, you needed metronomic chemo, you needed natural killer cells, you needed vaccines, you need fusion proteins, you need to understand myeloid-derived suppressor cells, Treg cells. You need to understand the plasticity. Every cell in your body could be an M1 macrophage that kills an M2 macrophage that suppresses it, an N1 neutrophil that kills an N2 neutrophil that suppresses it, T killer cells and a Treg cell. That's the complexity of this plasticity. And at the same time, the tumor is changing to what you're doing to it in real time. So how could we orchestrate all of that? And I realized no single company would be able to do that unless they had all that under control. Not control for financial control, but control of an orchestration of a sequential interaction in real time. As a tumor morphs, you morph with it. Which meant then you need to go to innate and adaptive immune therapy all at the same time to drive to immunogenic cell death and a memory T and NK cell. Next slide. And this is the meeting. I've had multiple meetings like this. And you could see the skepticism on the faces. Of all the thought leaders, and you see Mac Cheever, Jeffrey Schlom, and Jim was right. Getting anybody to think immunotherapy as a cancer treatment. And we held meetings and meetings and meetings like this where I was trying to convince my fellow colleague scientists. And they really thought I was crazy, actually. So I decided the only way to do is just go tell things, do this work. And here I am 10 years later. This is the first time I'm presenting, I said to Mike, the work since then. Next slide. So let me go back. Let's step back about why we're here. And there's a lot of elements that's taken us through wrong assumptions, not by any quirk of idiocy or ignorance, but just by a quirk of timing. So if you look at that chemotherapy, how was chemotherapy developed? So I knew Matt Softness, next slide, and he was working hard in developing Taxol. Taxol came out of the yew tree, the bark of the yew tree, and hydrophobically they were developing Taxol. And it almost never passed because people were dying. But the only way they got it to dissolve was in castor oil. We'll come back to that. Castor oil. Injecting women with castor oil. With the black boxes, you have an anaphylaxis regardless. But nonetheless, it was successful, it got approved, and Bristol Myers took it on. And the NCI was then charged of developing a model so they can develop 500 drugs. I tried to show this book to Jon Stewart and told him with the nude mouse, thinking we're going to have a serious conversation. He said, well, the nude mouse is a mouse without morals. I said, well, that was the end of that conversation. It broke into laughter. But what this really was, they found a mouse that was athymic, which meant it had no T cells. So think about this, that we developed drugs in a model system without an immune system. Next slide. Which then said, we also developed a regulatory strategy that says, let's go to maximum tolerated dose, MTD. Let's take these drugs that we developed, regardless of the immune system, and put it into the patient to see that we don't kill the patient and just get below MTD, give high-dose radiation, we go chemotherapy, intensive therapy, and that was the beginning of my little mind map that said that must change. Next slide. What nobody realized, this concept of lymphopenia. I'm trying to make lymphopenia famous. It's been famous forever. What is lymphopenia? Lymphopenia is the knocking out of your NK and T cells. Lymphopenia says, let's make you an athymic mouse. Let's make you a SCID person. Let's make you without T cells. Well, guess what? Next slide. Christy Mackel, who some of you know. Again, lymphocyte depletion during treatment with intensive chemotherapy, 1994. We've known that we wipe out our NK cells and T cells, the very cells that need to kill cancer with the chemotherapy. I started to say that in one or two meetings and decided to stop, to say, is it possible that inadvertently we are causing metastases to our patients? Is it possible that we are super selecting the resistant cells, wiping out the NK and T cells with our high-dose chemo? We've known this since '94. Next slide. Well, radiation is no different. Radiation is even worse. Since 1983, we've known that radiation induces lymphopenia. We've known now all the way down to this paper was in 2022, and you can go on. Next slide. Yet, a CBC that measures hemoglobin, white blood cells, red blood cell count, neutrophil count called ANC, it measures your lymphocyte count called ALC. ALC is hidden in plain sight. After millions of dollars I spent on genomic sequencing, DNA, RNA, protein, proteomics, it turns out a $10 test is available since 2015 with an ICD-10 code. Next. So what happened? Well, next, Amgen developed. Next. Sorry, you've got to press. Measuring red blood cell count if you have anemia. Thank you. And if you have neutropenia, so you look below there, RBC and ANC. And guess why these drugs were developed? These drugs were developed as a consequence of the side effects of chemo and radiation. And guess why they were developed? So you can give more chemo and more radiation. Now you think of this logic. Obviously, these are good drugs, they're important drugs. They would prevent patients from dying from infection, etc. They're not non-important drugs. I'm trying to take you through the process of how we were thinking and maybe not thinking to this missing link. And this missing link is lymphopenia. In that same test that you measure RBC and ANC, there's a thing called ALC. So what I did is I tested, and I went through this year, just this year, I would call maybe 100 of my oncology friends and said, can you tell me your patient's ALC? They said, the ANC? I said, no, the ALC. And I said, what's that? The reason there's a what's that is even today, I think you could test some of your friends. If there's nothing to treat it, you're not taught it, you don't read it, and you ignore it. So the next thing I need to make famous is, what is my ALC? Because that single test will give you the status of your immune system. i.e. lymphopenia or not. So that was the missing link. The very cells, NK cells and T cells, necessary to kill cancer. So what's the consequences of lymphopenia? Well, who cares? What was really disturbing, and I won't go into details, I had a very recent FDA meeting and I tried to convince the FDA about the importance of it. The response was, well, that's just a number. Hemoglobin is a number, PO2 is a number, blood sugar is a number, ALC is a number. But what's the consequence of this number? Your normal lymphopenia ALC levels should be around 4,000, 2,000, 3,000, 4,000. If you go below 1,500, this is 2015, 10 years ago. Paper after paper after paper, you look at the hazard ratio. If you have a lymphocyte count less than 500 for high-grade glioma, from pancreatic cancer, stage 3 lung cancer, all types of cancers, your hazard ratio goes up 200% of early death. More concerning, and I shared this with Mike just recently, lymphopenia, the question was asked, does a low lymphocyte level associated reduce the survival in the general population? Healthy general population. The answer, 1 in 5 Americans have lymphopenia. 52 million people. Is there a consequence to that? Look at the hazard ratios. From all causes, diabetes, cardiac, if you have lymphopenia with an absolute lymphocyte count of less than 2,000, your hazard ratio goes up 1, 2, 3, 4. From cancer, the increased mortality. I've been trying to convince the FDA today, lymphopenia is important. Immune system is important. Which then says, does it occur across every tumor type? This is 2019. On the right-hand side in that green bar is every one on the references is an individual paper that says sarcoma, Ewing sarcoma, renal cell carcinoma, breast cancer, non-Hodgkin's, diffuse large B-cell, and so on. The hazard ratios of early mortality is significant regardless. So the consequence of lymphopenia is real. So how did we, as again, a scientific industry, go about to this? Well, we look for a T-cell growth factor. And here it was. So my mind map said, wait a minute. If you go to this mind map, guess what IL-2 does? It stimulates the immunosuppressive cells, the Treg cells, the cells that are plastic that go from T killer cells to Treg cells. But guess what we've done in our wisdom? We approved a drug to stimulate Treg cells, immunosuppressive cells, for treatment of melanoma and for renal cell carcinoma. I know this sounds sort of illogical, but it's what I'm concerned about, or have been concerned about, still are concerned about, is enlightenment at this level of science with every level of our policymakers, including the regulatory organizations. And to his credit, when I presented my idea through Sean Cozen, invited me to the OCE, they said, you can go ahead. So you think we've learned our lesson, 1992, but look what happened, 2017, Bristol Myers spent $5 billion on putting a pegylation to IL-2. So here we are saying we are spending billions of dollars, thousands of patients, going down the wrong immune pathway, and yet we're getting all the approvals, phase 1, phase 2s, phase 3s, and asking the question, why? Well, thank God, by 2006, Thomas Waldman wrote a seminal paper. For the first time, explaining the difference between IL-2 and IL-15. Now it gets very complicated again because the quirk of timing. IL-2 as a cytokine was discovered before IL-15. So the receptor on T cells is called an IL-2 receptor, except the same receptor is actually an IL-15 receptor. Now it gets even more complicated. So this is, well, I don't have time. If you give me the time, I'll go into it. But the IL-2 receptor doesn't require its chaperone called IL-2 receptor alpha, and in so doing, it actually stimulates the Treg cells. The IL-15 receptor on the same receptor requires an IL-15 receptor alpha, and so doing stimulates the NK cells and T cells. Importantly, it stimulates memory T cells because the IL-15 receptor alpha, the chaperone, is bound to the dendritic cell, which means you really need to understand then the whole adaptive system. So the power of IL-15, and guess what he said in his paper? IL-15 activates T cells and NK cells and has a role in persistence of CD8 memory T cells. That is the Holy Grail. IL-15 activates T cells and NK cells' role in persistence of CD8 memory T cells. It therefore might be better than IL-2. So I only discovered this workshop report 3 weeks ago. 3 weeks ago. 2007, the NCI, the FDA, the NIH, the AACR, the ASH had an entire review of thought leaders of what are the most important cytokines that could cure cancer. They reduced 120 to about 20 agents, and these are the criteria in which they would rank them. Number one, potential for use in cancer. Number two, perceived by the need by independent clinical investigators. But most important, number three, the potential against different tumor types. And Jim said it in the first meeting you had with him, Mike, in that the first time I saw your video. The immune system is what you're treating, not the cancer. The most profound statement I got was from the Saudi FDA regulators, who had said to me that the work we're doing is we now understanding that the collapse is the collapse of the immune system, and cancer happens to be a symptom. If you treat the immune system treats the cancer. That's what this ranking was. Guess what it ranked? Number one, IL-15. T-cell growth factor, 2007, ranked number one. And Mac Cheever, who was there in the 2016 meeting, wrote this paper in 2008. The title of the paper, 12 immunotherapy drugs that could cure cancer. So when I say the word cure cancer, I'm repeating this paper, the T-cell growth factor, IL-15. So let's just step back and say, what do we know then? What, over 55 years, we know that through the nude mouse, we developed huge amounts of drugs, identified the NCI panel, the athymic mouse without T cells. Chemotherapy came from that. High-dose chemotherapy induces lymphopenia. Epogen was invented to enable more chemoradiation. Neupogen was invented to treat neutropenia, to enable more chemoradiation. IL-2 was invented, but it stimulates the wrong cell. And then finally, leukine. Now, this is something we really need to worry about. GM-CSF stimulates an immunosuppressive myeloid cell called the N2. So the neutrophils that we think we are increasing is actually going through a thing called the neutrophil lymphocyte ratio. High neutrophils, immunosuppressive low lymphocytes. So what was hidden in plain sight? Lymphopenia significantly reduces survival across all tumor types. Lymphopenia reduces survival in general US population. Absolute lymphocyte count is there in our face, but ignored. IL-15 was ranked number one, and IL-15 reverses lymphopenia. That's logic to me. That was what I said we need to now address this to pursue this cancer vaccine, and I approached the FDA in 2016. It's hidden in plain sight. The way we approach that is in a quantum oncotherapeutics way, and I made this lecture to some physicists that it's not Newton physics, it's quantum mechanics. Everything's moving, everything's changing in real time. The tumor is morphing in relationship to your treatment. The cells are morphing in relation to your treatment. You need to anticipate them in a real orchestrated way, treat each patient. So when Mike says, what happens when you come today? Today we have 13,000 requests for treatment in our clinic. We've written over 100 single patient INDs to give them this treatment, and I'll show you the results near the end of this talk. Fine? Okay. Tell me, did you pull me off? 2 minutes? Okay. All right, I'm going to go fast then. And by the way, okay, I'll go fast. So this is 2005. We need to get the tumor microenvironment through the GP60 caveolin 1. People thinking it was just trying to create an expensive Taxol. It was not. It was to take albumin, again, a natural product in your body, to create this thing called transcytosis, so we can drive the paclitaxel to the tumor. And this got approved in 2005. What people didn't realize, we were able to convert M2s to M1s. Now you're converting for the first time using a chemotherapy as an immunomodulating agent. That is why I asked to use this in a low dose in a metronomic fashion. You're not treating the tumor, you're treating the immune system. The next thing was the natural killer cell. Well, I wrote my first paper in the natural killer cell at UCLA in this amazing journal called Hormone and Metabolic Research. It has 3 views. If you look at it, 3 views. So the opportunity for the natural killer cell to kill cancer was this opportunity. But it turns out that all these cells express IL-15, and it is this Anktiva that allows this proliferation and allows this natural killer cell, and shown this to grow in healthy volunteers. And 10 years of work between myself and Jeffrey Shalom and Jim Gully as a creator has now identified all the actions of this IL-15. And by 2024, this, to me, was the most seminal piece of legislation approval in our package insert that says the mechanism of action of Anktiva is a binding of Anktiva to its receptor, which results in proliferation activation of NK, CD8, and memory T cells without proliferation of Treg cells. So what's happened? Well, guess what was number 2? Checkpoint inhibitors, really important drugs. And over the last 4 years, 40 approvals across multiple tumor types with single-arm trials, some of them. Here we are with the challenges facing us today is, what are you going to do? This is from ASCO in 2024. This is from the doctors at ASCO, not our slides, of no treatment for patients who fail lung cancer. Checkpoint, all that's left is docetaxel. So what if you combine 1 and 2, and we did, and showed you increase the ALC, and when you do that, you change the Kaplan-Meier plot with tripling the survival versus 7 months of docetaxel. And on that basis, we got the approval from the Saudis. Now, this is the first approval in the world in which we have 2 more minutes.
Oh, actually, yes. Because we're running over.
Okay, well, I should. Okay, well, I'll stop right here. Let me show you the.
Tell us about all of this and what it means for the future of cancer.
You're seeing it right now. So here we are, in which we treated this patient's immune system. The patient's ALC, 1,320, 2,300. HPV levels went from 58 to 19 to 0, with complete response. Here we are, the patient with HPV negative, difficult to treat, flew all the way from India, 460 to 1,560. This, I think, is really telling. In glioblastoma, this took protocol 45 years. You get glioblastoma, you get radiation, knock out your NK cells, you get chemo, knocks out your NK cells, steroids, and surgery, and then inevitably you get recurrence. These patients had no chemo. All they had is Anktiva plus a PD-L1 NK cells and bevacizumab. Next patient, so forth. And this patient has no chemo, no lymphodepletion, Waldenstrom, complete remission, now going 15 months. We've seen all these CRs, and we have completed the first preventative vaccine in the nation, in which we've taken adeno plus in patients with Lynch syndrome. 1 in 280 patients in America have Lynch syndrome, over 1 million people. So the future is cell therapy, completely agree, but different cell therapy. Deconstructing apheresis to a gamma delta T cell, an iron T cell, an MSANC cell, allowing even allogeneic, and more importantly, developing the world's first AI robot, which will be deployed in the next 3 months, to actually now manufacture these cells and democratize it. And then finally, as we learned this morning, understanding nature's intelligence. 450 million years ago, natural killer cells, and now 50 million ago, I always was really curious, why do sharks not have cancer? And why do camels not have cancer? It turns out they generate a thing called an antibody, a single-chain antibody different from us, that has a loop that allows this to be used as this next-generation targeted moiety. So with that, I will stop with this mind map, but I think if anybody wants to see this in sort of a much more simplified way, please access this QR code, because I'm being pulled off the stage. Thank you.
Thank you so much. Well, Mike did say we had 8 hours or more today, so Patrick, you were right on time. Well, thank you so much for that thorough review of the evidence, and I think we could have granted you maybe 12 more hours to go through all of that, so thank you so much. I want to welcome the next panel, which is a fantastic panel discussing the next generation of public-private partnerships that will be moderated by Margaret Anderson, who is on the board for Faster Cures, also managing director at Deloitte. So we'll get more chairs set up here, and then we'll welcome all of you to join. Okay? Yes. I'm on the back end, so you'll be fine.
I am committed to waking us up and getting our blood flowing. So I want everybody to stand up, shake it out, like we're in an exercise class. So we're all going to get up, move around, move your wrists. If you're home, stand up too. Mike, I don't see you standing up. Thank you. All right, I'm excited to welcome my panelists up here. Come on up. We are so excited to talk to you about collaboration. And I have to say, as we were prepping for the panel, having some conversations, and I was thinking about this topic of collaboration and partnership, I kept thinking, you can keep standing up if you want, that's totally fine. But I kept thinking, exactly what is our problem? Because collaboration seems very intuitive and obvious. Like, why would we compete? Why would we fight? Why would we not all be on the same team? And I think we've heard, last night and into today about some of those historical artifacts, if you will. I actually think there's a lot of things to be optimistic about in terms of collaboration, but this is absolutely not a new topic. So I brought a teaching aid, which is a document that we did at Faster Cures in 2013, and it is called the Consortiapedia. Now, why did we do this document back in 2013? Well, several of our partners at government agencies, including FDA and NIH, had come to us and said, gosh, there's a lot of partnerships out there. We're having a hard time tracking them. We bump into each other in them. Some of them are duplicative. And one topic that was raised to us was, we don't even know when we've accomplished the end goal. We don't know how are we measuring it? When is enough enough? When can we claim success? So I wanted to show this to remind us that this is a topic that we've all already been working on. I also want to follow what Greg Simon was saying earlier, which is many of the people who've been on the stage and in the room throughout this incredible meeting are visionary leaders in oncology and cancer research who have devoted their entire lives tirelessly. I'm acutely aware that we need reinforcements. We need people coming up behind us to do all of this work, right? We need to be training that next generation. So that's something I want our panelists to be thinking about today too, is how are we thinking about collaboration and partnership in the idea of training that next generation? So I'm not going to belabor the introductions. You can see that up here on the screens. We have a heavy hitter panel here that represents government, financing, pharma, care delivery. And so we really have our own collaborative model right here. So we might do a little bit of workshopping on that. I'm going to start, though, with Monica, because we talked in advance about a collaboration that you are excited about. And I think the goal here, even if Esther gave us a little bit more time, is speed. So I'd love our panelists to be pithy in their answers, kind of roll through it fast, faster cures. Tell us, Monica, about this amazing partnership that you are excited about, and why do you think it's powerful and can it scale?
Okay, so thrilled to be here. I picked a particular example, number one, because I think everyone knows I grew up in rural Wyoming. I care desperately about people who, like my own family back home, who are 100 miles from the nearest specialty medical center. And what do we do for people with cancer, like my dad, who when he needed to have radiation therapy had to move from Wyoming to Seattle? It's very important. So this is what happened. With the group I'm working with right now, Russell McCullough, we call him Rusty, who's head of one of the clinical research leaders at the University of Nebraska, came to me. And with work that we began when I was at NIH, the University of Nebraska had taken some software developed by the NIH that was allowed his entire network, the main hospital in Lincoln, Nebraska, and its 70 remote rural clinics to be linked entirely with an enterprise data management system. You heard the presentation last evening from Kaya, how all those big hospitals are joined. Well, Rusty needed this for the University of Nebraska so that all of their clinicians, nurse practitioners, doctors, everybody, could work together seamlessly and could share clinical data seamlessly. So that was number one, big thing that happened. He came to me with a problem, though. He said, we want to do better care for women with breast cancer all throughout our rural clinics. We've figured out that here at the big university, yeah, guidelines care, guidelines care gets better outcomes for people and it costs less because less low-value care is done. Guidelines care is pretty good here in the main hospital, but it's spotty for people who are out there in our live in rural locations. Can you help us make that better? So the team got together with an AI agent, decision support AI developer team, looked at the data from cancer patients with breast cancer treated across the Nebraska system, developed an agent that would look at an individual person, woman or man with breast cancer, and identify all of their clinical characteristics and then match them precisely to whatever the cancer treatment guidelines said was the next appropriate part of their care. Did that, but then took that guidelines match and gave it to the clinician and the doctor and the patient together for their discussion in clinic. Now, that patient could have been in Rapid City, South Dakota, or because, believe it or not, Nebraska has a clinic there. Could be at any of the remote locations. They would discuss that guidelines together, and then they would make a decision for what the patient should do. Important to know, guidelines don't work for everybody, right? They're never perfect. That's part of this story. So then what happens, two things. The clinician asks the patient, can we keep following all of your data to see what happens? That immediately is a consented registry for this patient to be followed. And then what happens downstream? every time that patient needs a new decision made, their data get refreshed, they and their doctor get a brand new roadmap based on guidelines, the actual utilization of care for that patient is tracked at every single step of the road so that the team can see, is that patient getting care that the guidelines said they needed or something different? And then the ultimate outcome of the patient is being tracked to see if their cancer is returning. I know I got to finish. Last of all, who are the partners here? You're going to love these partners. In the for-profit space, it's the AI developer. It's a payer, one of the big payers who says, geez, if you have people on this program, we want to be part of this. We will exempt University of Nebraska from prior authorization. So it's the AI developer, it's a payer, it's a commercial provider of the cloud-based enterprise data management and analytics platform. In the nonprofit space, it's the health system, and it's the creator of the cancer guidelines. And in the government space, it's the creation and delivery of open source software upon which all of this system runs. That's collaboration.
Thank you. Jean-Charles, we were talking at the break around collaboration, and I was posing the same idea of what's the problem? Why, is there a problem with collaboration? And you came up with a gardening metaphor to describe how we need to tend to collaboration versus letting our garden get a little bit out of control. Do you want to elaborate on that? And do we have a problem? Is there an unruly garden? Is that a bad thing?
Yeah, thank you. Ecosystems are complex and they need attention. And the oncology infrastructure and clinical trials we have in this country needs attention. We are obviously losing part of the challenge and the competition to other areas of the world. And this is especially and acutely true for early oncology trials. And that's very important because that's where the new medicines meet the human being, and the way the patient responds tell you what's the biology behind. So it's disproportionately important, and I think we need to attend to our garden. It's not because it looks beautiful from far away that there are no weeds that we need to prune or put more fertilizer. And I think we need to come with a system that allows the US to again recompete with what is happening in Australia and China. And we need to have national oncology trial acceleration initiative consortium, whatever you want. And there are very simple levers to look around that, correct? You need to have sponsor sites and regulators that agree and say, okay, we need to come with a system where we have a centralized IRB, because this idea of having IRBs all over the place does not make a lot of sense. We need to have a fast track with the regulator. We need to have pre-agreed IP and what is the compensation for those trials. We need to agree on quality norms and speed. That can unlock a lot of opportunities.
How are we doing in the United States?
Well, in the preclinical space and the discovery space, we, are in a not very good shape right now. The East is taking over massively. And certainly, China doesn't copy anymore. It invents as much as we invent. In the early oncology space, we're losing ground very, very rapidly. It takes too long to do those trials here. And those trials are crucial because the quality of the signal there defines whether you're going to go and do phase 3s. The reconciliation of the phenotype of a responder with the underlying biology is essential to give you trust. And we are losing momentum there too. So we really need to react.
So my other panelists, how do you think we're doing? Anyone want to jump in?
Well, I'll jump in on the issues that we talked about here, but also in the morning. I think part of the challenge we have is that we put in systemic barriers to the collaboration that we're talking about. So one of the areas that I'm interested in having, practicing our practices in Southern California to start, and now, as you heard from Ed, we're in multiple sites. But under the banner of value-based care, we somehow have pitted the academic centers against the community. Whereas when I practiced medicine 30 years ago, we were working together. Now, I think basically looking for contracting power and unit price, they've tried to negotiate that we want to have a narrow network, so we want to have the lowest cost provider. And they put economic pressures to not let the cancer patient leak out of the system. So if you think about the problems we discussed today is getting information to the community, getting it to rural sites, we're actually sabotaging that because we're creating it around a payer construct as opposed to around a patient-centered construct. And when I talk to patients, one that comes to mind was one I talked to like maybe 10, 12 years ago, was a patient dying of esophageal cancer with stage 4, knew he was dying. And I got to know him and I asked, well, what part of the system didn't work well for you? And the reason why this story is so poignant to me is he said, you know, my dad died of esophageal cancer about 25 years ago. And when he had it, his oncologist called every university in the area looking for help. My oncologist gave me the website for NIH.gov and told me I was on my own. There's a polarization, and I think we need to look for solutions, and this is where the collaboration comes in. What separates us is we don't have an economic model to reward the academic center and the community practice for working together. Because if you're a patient, and we heard last night such poignant stories, and as well as today, you want to have a system that supports you to get your care close to home as much as possible. But when you need that CAR T, or you need that complex surgery, you need that research trial, you don't want to have barriers put up. You want to have facilitated access. And we just don't have that today. And you can imagine as we move more into the narrow networks of HMOs and value-based care, we're going to continue to expand that gulf between the community and the academic center, and we should be doing everything we can to shrink it.
Harlan, you're bringing up such important points. I mean, I wrote down Rick Pastor. I thought he was just so eloquent and simple in his language. And he said, we are our own worst enemy, and we need to make it easy. And I think you're talking about both of those factors. I'm seeing you nod your head on that, David. Are you thinking the same thing? I mean, where are you on that sense of how we're doing with these collaborations? Again, we are seeing phenomenal advances. I spoke with you last night, you know, a product that your company has produced, my husband is taking and has no cancer right now, thank God. So thank you. I mean, thanks for the innovation that the whole system is providing, but is it enough? And what's getting in the way?
And thank you for sharing the story of your husband, and it's wonderful to hear those. That is really the fuel for all of our work and the soul and the things that we do. No, we're not doing enough, but I want to come at it perhaps from an angle of where I spend my days, and that is certainly I'm cognizant of the investments that we're making in clinical trials and the speed and new science, but my job is the delivery of medicines across the globe and to get them approved and get them reimbursed. And so to my mind, our job is evergreen until all eligible patients for a medicine are able to actually receive those medicines and to be able to do it in a way that manages side effects, results in best possible affordability. And what I've found is that the focus on outcomes has actually been a really galvanizing force for public-private partnership. There's nobody that's that interested in me getting more market share of my medicine, nor do I expect them to. My boss cares about that, but other than that, like in terms of, you know, the ecosystem, that's a little bit less of an area of focus. But we can find lots of people who are interested in improving outcomes for lung cancer. Jean-Charles and I, together with Garden and together with the IASLC, now several moons ago, had an idea of the Lung Ambition Alliance. We created a public partnership, which the whole goal of this was to, how do we drive screening? How do we drive more precise and timely diagnosis? How do we do more work to invest in grants for quality improvement projects? These are things that Karen and I call ground shots. These are the things that are making a difference. They're pre-competitive. And I guess what I would say, and I do pay attention to all the comments on science that have been made today and the funding and the challenges. So what I'm about to say is not immune to that. But I do think science is less of the bottleneck to the challenges that we have, and alignment across regulatory and financial incentives and politics get much more in the way. I actually have enormous confidence in the great science that we get a chance to hear about all the time. And I think what we have to unlock is the ecosystem in which we need to deploy it.
I agree about the promise of the science. It is palpable, it's powerful. We're seeing it working in real time. We've seen many presentations on that today. Pablo, talk about it from the avenue that you come in terms of financing, looking for these opportunities, and the whole model that you created, which was stunningly innovative.
Sure, thanks, Margaret. So yes, I come at this from a completely different perspective than my fellow speakers here. We're all about funding the incredible drugs that you're developing for patients. And it started with us collaborating with academic institutions, which are a really important part of this ecosystem, research hospitals, where we started by advancing, giving them an upfront payment and advancing 10, 15 years of potential royalties that we're going to collect. And what that resulted in many cases, MSK, for example, built a 20-story research center in New York with money they got from the Nupogen royalty. It was mentioned today by Patrick. UCLA, over $1 billion on a really small royalty, 4% on a prostate cancer drug that actually Mike and the Prostate Cancer Foundation was involved with. And many more in the case of cystic fibrosis, not cancer, over $4 billion of cash upfront for the foundation, which allowed cystic fibrosis to really do bold things, as the CEO explained, to really find cures for cystic fibrosis. But what's happened with our model, Margaret, is that we have actually continued to push the envelope and really try to change it always, not stay still, but find new ways to fund this ecosystem. And about 10 years ago, we started to now fund clinical trials for biotech and pharma at scale. We've invested about $27 billion over the last decade, of which about almost $12 billion are in products that are being developed. And what we're doing there, and actually I'm very proud about a transaction we did last year with Revolution Medicines. Mark Goldsmith, that spoke today, was looking for money. His alternative was to partner with a big pharma company that was going to probably take more than half of the economics in his drug, leave the biotech with less than half, but then also influence a lot the development of that product. And what we ended up doing with Mark is that we were able to deliver $2 billion of committed capital for him to have enough money to fund the phase 3 trials for his drug in pancreatic and lung. And importantly, it's a mid-single-digit royalty, so he was able to keep a huge portion of the economics in the product, but importantly also really decide himself with his team as to how he was going to develop the drug, have complete flexibility. Now, I'll finish just by saying that the other thing that's started to happen over the last 5-8 years with our business model is that we've recognized that data is so important in everything we do, that we've invested a huge amount of money every year in data and built a data analytics, data science team and we've done it because we use it for our own purposes, but what we've started to do is collaborate with biotechs that we work with, sort of sharing perspectives that we gain through our data science team and all of this data, and then help them think through the design of the trials and commercialization. And it's something that many biotechs cannot do themselves because they don't have the capital. It's not only having the money to spend money on data, but having over a dozen people that are going to be analyzing the data. So you have to build a data science team. We do it because we use it throughout the ecosystem. So it is a model of extensive collaboration with all of the different parties in this ecosystem. And I still believe that we're sort of at the beginning of this. I always think that there's so much more we can do. And I always push the team and say, we have to always come up with new ways of interacting with everyone in this ecosystem.
Thank you. So I am going to go to the audience for questions. So I'm going to let you think about that for a minute. Monica, I want to ask you, in your journey from, you described yourself as a nerdy girl starting out, which thank God for nerdy girls. We just wish there were more of us out there who were taking care of business. Anyway, when you were just starting out, what was it like then versus now? And then what do you want it to be going forward in terms of this collaborative glue that we're talking about? Because I think you even described yourself as maybe not as collaborative as you wish when you were practicing.
The world was just so different. You know, I was head down in my lab originally when I was, a beginning academic doing basic fundamental biology. Then I took this little side trip that ended up being pretty transformative to run a large cancer clinical trials group. Boy, that is where I really learned the power of collaboration. And I think what you're referring to, for me, it's the collaboration between the big academic centers and the whole rest of at least in the United States and increasingly the world. And a recognition in those clinical trials groups that there was equal power, truly equal, in terms of what was bringing to solve the problem from the academic centers and the little, sometimes really little, community practices and networks. Why? Because the real goal is transforming people's lives. And that's what it took to accomplish those trials. So I think that's what you're referring to.
Absolutely. I mean, Harlan, it kind of relates back to what you were bringing up around parts of the system, and I'm not trying to pick on any one part. I mean, you picked your part. Where can we be doing better? I mean, this second time it's come up about academia. What's disincentivizing this collaboration or joining into creating new collaborations?
Well, I think I mentioned some of the disincentives for collaboration, but I do think there's optimism out there. I want to tie it back into something Karen asked about in the earlier conversation. One of the drivers of change in healthcare, whether it's disease management or wellness programs, are the employer group. Now, the employers are interesting because they do care about affordability, and more so in recent times, but they care about the outcome. They care about the quality. They care about time away from work and the patient experience. So they're actually a great partner. And if you listen to what they say, as an academic center, yes, they want you to be a center of excellence, but they also want you to share their information. And I think for too long, academic centers haven't heard the second part. So center of excellence meant you come to me. So about 7 years ago, City of Hope started exploring what would it look like if we went to the community. So we started a company which was to support employers, their members, or their employees and their family members with cancer, and we would give NCI-level advice to community oncologists with zero expectation that the patient ever show up at City of Hope. And this thing grew so quickly that we quickly spun it out, and we were joined by multiple other like-minded NCI centers, many of whom are represented in this group or have been mentioned. Johns Hopkins is a key one. The Hutch was one of the early adopters. And the hard part, because there are 57 NCI centers, the hard part was finding ones that were truly committed to being a reverse center of excellence. So what we do is we use AI, well, back then technology alone, and now AI-driven technology, identify complicated cases, and we looked at what didn't work on those remote second opinion programs. It was giving them to the patient only. Because then you're asking the patient to negotiate with the same person that they're trusting their lives with, and they don't have the power. So we set this up with NCI experts giving written and if the doctor wants, verbal support to taking care of the patient in the community close to home. And it's grown. About 800 employers now use this, 90 of the Fortune 1000, Fortune 500. We cover over 10 million members, and this is growing. So this is just an example of employers hearing what they want and NCI centers, academia being willing to collaborate with each other. And we talked last night about compromise. So it wasn't just win-win, it was win, compromise, and get the bigger win. And by the way, the latest generation of this is going to be helping people find clinical trials, because we realize there's people who aren't in academic centers, their doctors don't have time to identify, and we're now creating systems, and that Access Hope has launched that this year. So we're really trying to solve an industry problem, and no one's going to be the big winner except the patient. And that's been the goal and the true north, which is creating patient-centered solutions for those with cancer.
Fantastic. So do we have any questions in the audience? We can get you a microphone. There were a couple people I mentioned I might call on, Karen being one of them, Cliff being another one in terms of collaboration. Other hands out here? Yeah.
While we're waiting, I'm going to sneak in a little comment here. One of the things that is just really beautiful about what you said, and I also think that this University of Nebraska team has taken this very strongly, is whatever happens in this network, number one, the patients are part of the solution. They're actually contributing, and the system feeds back, like you've been talking about. You know, it's something gets launched, something happens, there's this matching, there's this program, but that information then comes back to better inform the program. And that design feature is built in from the very beginning. If you try and add it later, it doesn't work.
I do just want to add, on this Access Hope company that I just mentioned, the patient has the opportunity to opt in. It's just that the uptake is so low. And we know from all of the disease management programs, people participate if there are doctors involved. So we try to create the program so both can be involved.
Karen, we're going to get you a microphone.
I mean, these are, am I on?
Nope.
But we can hear you.
No, that's my way. Okay, I think I'm on now. These are such great examples of public-private partnerships and collaborations that are meaningful for patients. So thank you for what you're doing. We've talked a lot today about technology and how it is that we make science go faster, how it is that we match patients to clinical trial, that we make sure that they get guideline concordant care. How do we take technology and turn that into a match.com for collaboration? How do we make it so that it's very clear that University of Nebraska doesn't have to hunt you down to let you know that they're trying to make sure that they increase concordant care for their breast cancer patients? All of us, we're all running businesses, we all have strategic goals. So where is that, and maybe this is a Milken Institute thing, sorry guys, but you know, how do we create that, here's our need with a capability that someone else has so that we reduce the friction points and use technology to do that, and so that we can all move faster as a field?
I love the Match.com for opportunities, although I think you're dating yourself. It's Hinge now, right? Not Match.com. So there you go. How do we create these, you know, sort of this master list of opportunities so that we can swipe on it and find partners? Is it as easy as that, or are there? Yep. Yep. Yep.
I mean,
I love
think
that.
Karen's, I don't know the answer to the marketplace or the way to connect, but I appreciate that very much. I do think that you're highlighting one of the core success factors for public-private partnership, which is you've got to have alignment on objectives. And I love what you're articulating, which is there a way that we can find alignment of objectives and be able to get there quickly so that we can, I mean, you're a get after it kind of a person, so that we can get after it. And I think it's also the common challenge that you have, where we can get a number of people in a room who are moving in the same direction, but then we can find ourselves very quickly having our own cottage issues that we have. It's a bit like when Mike was describing that they needed to have 2 years of asking everybody to not be asking for funding and just count on us and we'll raise the NIH funding. So I like your idea of how can we move through that quickly.
And Rick Pastor was talking about it as well in terms of you know, continually adding to the roster of a trial or an agreement, and how do you not topple it over? But I really like what you're saying too, which is this marketplace concept for collaboration. Because I also heard that example about lung cancer screening and wanted to broaden it to lots of different screening that we know people aren't doing. I'm sure at American Cancer Society, you all were studying this. What was the uptake? Yes, we're going to detect more cancers, but we're going to get it sooner and have more opportunity to jump in.
So you've just given, you just raised the most important reason why I'm so thrilled and honored to be entering the leadership of the National Academy of Medicine, okay? And the National Academies were created in the Civil War, in the middle of the Civil War, to advise the nation at a time of dramatic societal change and a need to go forward in a very united way from a divided nation. Gee, are we sounding pretty similar right now? And the other thing about the National Academies is it is a convener. Its learning health system, which has been around since 2007, chaired by Mark McClellan, actually chaired by Mike McClellan for a long time, that's its job, to create, to build, to convene everyone in the ecosystem to work together to create a learning health system. And it's kind of been almost mocked because we have failed over the last 20 years in all the objectives for really achieving a learning health system. And then finally, you talked about technology. That's what's getting us our learning health system. Finally. So the moment is now, and the National Academy can be a convener for this, but the National Academy doesn't do it. The National Academy needs to convene everybody here, sit in a room, work together, and then make your task list, make your commitments, and then move on and get it done. So I'm giving you all a challenge.
I think the answer to so it's not going to be a homogeneous or a single answer, but I think we need to define what the it is. When you're on the end of the spectrum of curing disease that has already occurred, people in this room can do that. When you're talking about really a cultural change to focus on wellness and prevention, because you can have all the screening you want, and we know people don't sign up for it, it's a culture change. And if we look through history, we think about the fact that despite education, it wasn't until there was a campaign to stop smoking, and with John Wayne and others, that it really became part of the culture of the U.S. Same with littering. There was that, the famous commercial on TV, a public service announcement about littering. I don't think people understand the disparities in cancer care today. I don't think they understand in lung cancer, roughly 50% of metastatic lung cancer patients don't get the right treatment, whether it's because of lack of genomic testing versus getting the right drug. I think we're going to have to start to educate our children at a young age in school about why it's not just cosmetic to stay healthy. So we have a long way to go. And I think until you engage the public and get the emotion and change the culture, I think we're going to be on the tip of the iceberg, but we're not really going to change the health and the utilization patterns of screening and cancer care.
I think we have another question in the audience. Cliff, somebody was pointing in your, okay, not you. Cliff's like, quit picking on me over here. Can you identify yourself, please?
I'm Jackie Gerhardt. I'm a family medicine physician at Epic, and I just wanted to highlight what Monica just said. I've been so impressed at how the National Academies of Medicine have brought together multiple different stakeholders, both from technology and industry, but also from academia and throughout government. And to go back to the Match.com comment that you made, it's such an opportunity that we have now in AI and automation that just like you can put your preferences in for dating onto an app and then be able to have that match you, you can do the same thing in your MyChart to be able to do it with cancer trials. You can do the same thing with being able to make sure that you're getting all the right treatments. I, as a physician, in practicing family medicine, can see my patients and know exactly what screening they're due for, exactly based on their guidelines, exactly from the most recent things, all directly put into the EHR. And so this is possible today, and as we talk about what's coming in the next 10 years from now, it's really this beautiful healthcare intelligence where we're taking AI and guidelines and all of the data we already have and bringing that to insights to then better advance care. So thank you.
Thank you. In our final moments, I want to ask you all to reflect on what is your sort of wish and hope for collaboration going forward in oncology so that we can do this faster, better, cheaper for patients. So your wish and your hope, it could be something micro or macro. Pablo, I'll start with you.
Be very open about collaborating. That's the only way we're going to solve the very complex problems that we're facing. And maybe that's going to also bring this country together again.
Human engineering is much more complex than any more atomic resolution or molecular resolution or immune resolution. So my hope is that we will align the incentives so we bring people together.
I think the convergence of science and data and technology is remarkable and more than we've ever seen before. And I hope that that combination coming together allows us to democratize the delivery of guideline concordant care in a way that improves outcomes for so many more patients across the globe.
I hope that we realize that this science is outpacing the systems that support healthcare, and we need to change them. And I agree with you completely about the convergence of science and technology, but I would also add like the humanity, understanding the psychosocial aspects of cancer care. And we have the ability now through technology to kind of bring these all together at a patient-specific, with a patient-specific solution.
And perfect segue to me, human in the loop. Always caring human being in the loop, because when you have cancer, you don't want to have to go find an app. You want somebody who really cares about you to be available and to have everything they need to take care of you. And we can also make that happen.
Someone was saying earlier about this incredible opportunity that the clinicians in the room have had to look across the room at a patient and be able to help them. And I think that, to me, is the essence of this collaborative spirit we're talking about. I was also reflecting before the panel that it's something we talk to children about all the time. We teach children how to collaborate. Teachers are on board, parents are on board, caregivers. Really, the whole system is about, hey, kids, let's learn how to figure out how to play together. And I literally do not think anyone, again, wakes up and says, I'm not going to collaborate today. This is, a terrible idea. But I do think there are things that happen in the system, that just create scar tissue. And so my hope is that we can work through that, kind of get past that, knock it out. Because we're clearly at this moment where the science is there, the tools are on fire. You heard about the Kaya, the Cancer AI Alliance last night, and lots of other amazing things. I think, hopefully the scientific infrastructure in terms of funding is going to stay resilient. There is this international aspect that's hanging over. Jean-Charles, we talked a little bit. It's, there's some things that the United States really needs to be focused on, but what an amazing time. And I also just want to continue to give a shout out to Mike for bringing us together. And one of Mike's thing that I brought up in the earlier question is just how do we keep that young talent, whether it's young scientists, young anyone. I look around the room, many of us want to be young, but maybe we're a little less young, and no one's cracked the code to live forever. So we've got to be bringing along, that would be my challenge to all of you, is who are you bringing along to these conversations, to the work that you're doing? If you're not bringing younger people in, that is the whole model at a place like Deloitte, and it's one of the reasons I was thrilled to go work there, is just being exposed to young minds. They need it now more than ever. So lots of different plugs. Thank you, panelists. Thank you, audience.
All right, that was a terrific session. I owe you a break, but I'm not going to give you one. Sorry. I'm trying to catch up on time. So, what I expect folks to do who are here in the room, if you need to go and get a coffee, a beverage, go to the restroom, please do so. And of course, those online watching can do so at any time. But we're just going to continue with the program because we have so many different talks and panels and sessions for the rest of the afternoon that we do want to catch up a little bit in our schedule. So I am so pleased to introduce Bill Doyle, who is the executive chairman of NovaCure. I heard a talk that he gave just a few weeks ago, and it was terrific on where we are with really difficult cancers and how we can treat that through chemistry. So excited about that. So welcome to the stage. Thank you.
So thank you, Esther. Thank you, Mike, for inviting me. I'm going to describe a completely different modality for treating cancer, although it is related to a lot of the topics that we discussed today. And I'm going to try and give 25 years of research in the next 10 minutes. So if I can switch over to the slides. Someone can switch into my slides. Oh, I'm going to go back. So, but in order to do that, I have to drag you back to freshman physics and remind you that in physics, we talk about exerting forces at a distance in terms of fields. So gravitational fields are the attraction between masses. Magnetic fields are the attraction between magnet and iron, nickel, and cobalt. And electric fields are the forces of attraction or repulsion between charged bodies. We've used electric fields in medicine for decades. It's well known that at low frequencies, electric fields stimulate nerves and muscles. And this is the basis of things like pacing. Any of you, if anyone in the audience has a pacemaker, you're getting a low frequency electric field delivered to your cardiac muscles. At high frequencies, electric fields create heat. And in years past, I worked to develop the systems that are used to treat cardiac arrhythmias. So if any of you have had an ablation, that was a high frequency electric field delivered in order to create a block in a place where you were getting an aberrant signal in your heart. But the intermediate frequencies, frequencies between muscle stimulating frequencies and heating frequencies, were thought to be biologically inactive. The key insight that allowed for what we now call tumor treating fields is that intermediate frequencies can be tuned to enter cancer cells. And in fact, electrically, the cell membrane acts like a capacitor. So, you know, it's been pointed out, there's a lot of gray hair in the audience. You remember the tuner on a radio? That was, all the radio stations are in the ether, right? You were literally tuning a capacitor to allow one frequency into the amplifier, and then you heard a radio station. Cells are just like those radio stations. And once we can get an electric field into the cell, then we can push and pull on the charged proteins within the cell. And it turns out, for instance, tubulin is the highest and strongest dipole in the body. So when we get an electric field inside a cell, we can align the tubulin in the field and prevent cell division. And this is profound. We can observe this. So this is not a theory. You can see these are lung cancer cells. You can see on the left of this panel normal cell division. And then in the presence of a tumor treating field, I think the scientific term here is all hell breaks loose inside the cell. And importantly, and I'll go back to Patrick's talk, this is immunogenic cell death. So what we've learned subsequently is that we are affecting the tumor microenvironment, and we are turning these cold tumors hot when tumor treating fields are applied. Now, the real gift here, and one of the questions is, okay, that sounds good, but what about all the normal healthy cells? I'll go back to my radio station analogy. Each cell type is a different station. And it turns out the healthy cells are way down at the end of the dial, very far from the cancer cells. So we can also treat regions of the body with no effect on the normal cells, no systemic toxicity. So how do we deliver these cells? And this is the reason I asked Mehmet my question this morning. So while we do phase 3 trials, and I often get asked that, you know, this is a medical device, oh, it's easy to get through the FDA, right? No, we do randomized phase 3 trials just as if this were a new drug, new compound. But our therapy is delivered by a wearable medical device. The device has 2 components. There's a box, which today weighs about 1 kilogram, and it's attached to these patches, or what we call transducer arrays, that are placed on the skin. This woman is a GBM patient, surrounding the region of the tumor. And we are delivering, with this medical device, up to 2 amps across the tissue, safely, with no sensation, to create those electric fields inside the tumor. But the policy issue here that I raised this morning is because it happens to be in a box and not in a bottle, we don't have reimbursement, and there's not a reimbursement pathway through CMS, although we're working on it, and we're working very hard. I get these now every year, holiday cards from GBM patients. I get them on motorcycles, you can see on sailboats, skiing, so patients can undergo all the activities of daily life while they're receiving continuous cancer therapy. So let me look at some data. The first cancer that we went after was glioblastoma, GBM, the deadly brain cancer that we've heard so much about. A ice-cold tumor, highly heterogeneous, not a successful phase 3 trial since the Stupp protocol 30 years ago when temozolomide was introduced. That's still the standard of care. In a randomized phase 3 trial, we brought the 5-year survival from 5% to 13%. But what I'm going to point out here, and what is one of the things that's the most interesting, when this therapy's on, it's working. When it's not on, it's not working. For those patients in this randomized trial who use the device 20 hours a day or more, their 5-year survival was raised to 30%. And you'll notice that line is flat. These patients received therapy for 2 years and then stopped everything. And that is the survival data. So we're working on a number of things today to continue to increase that 5-year survival. One is on the engineering side, just making this thing a lot easier for patients to use. It's electronic, so guess what? It's going to become smaller, lighter, easier to carry. But back to immunogenic cell death, the best data that we have seen, and by we, I mean our community has seen in glioblastoma, was developed in a phase 2 trial by David Tran at USC when he combined pembrolizumab with tumor treating fields and rose that Kaplan-Meier curve in phase 2 data to double that level. And we're now in a phase 3 trial. We're recruiting very quickly in a cooperative trial with Merck, combining Keytruda plus tumor treating fields in first-line GBM. Some very exciting news for the company. Last week, we received FDA approval in locally advanced pancreatic cancer. This is another, we know, incredibly difficult cancer to treat. In this case, it was just with chemotherapy, it was gemcitabine plus tumor treating fields. We see a statistically significant increase in survival, although It's 3 months in the treated group, so this is not a cure, but also an extremely long increase in pain-free survival, which for those of you who treat these patients, your ability to provide other therapies is often a function of maintaining that pain-free status. And in March, we will release top-line data from a large phase 2 combining tumor treating fields with a checkpoint inhibitor and metastatic disease, which is really the future here, is immunotherapy plus tumor treating fields in these tough cancers. I'm going to stop here because I'm down to 24 seconds, but maybe the last thing that I will tease you with perhaps, clearly we heard from Revolution Medicine, the big news in pancreatic cancer is going to be the RAS inhibitors. And they provide a much needed extension in overall survival, but they're still not the cure. We have shown already that we are synergistic with the RAS inhibitors, meaning 1 + 1 = 3 in our in vitro models. We'll have in vivo data, again, by the end of this month, and we're starting our collaborations with RAS inhibitors, immunotherapy, and then tumor treating fields to create this immunogenic cell death just as quickly as we can get it going, but this year. 10 minutes on the nose.
Thank you so much. That was terrific. Really appreciated staying to time, but also importantly, congratulations on all of the FDA approvals. I am delighted to introduce George Yancopoulos for our next talk. George serves as Chief Scientific Officer at Regeneron and certainly one of the most influential scientific leaders in biotechnology. So over to you, George.
Thank you. Great to be here. Last night, Mike said something that was very moving and meaningful to me when he said that it's the immigrants coming to America that renew our faith in the American dream. I believe in things like faith and belief, and I think that they are some of the most important things that we have. It's certainly that belief in the American dream is responsible for everything that I've been able to accomplish in my life. I was raised in a poor immigrant family in New York City that came to this country because of war. My parents never finished their high school education, but they believed that if they could come here and give their kids all the advantages and opportunities that this country offered, their kids could make a difference. And in fact, they told me to never forget all the blood that was spilt just so I could be alive, and that I needed to do something meaningful with my life to give back to all those who had sacrificed before me. I displayed an early interest and ability in the sciences, but it was at the age of 13 when I decided to go into science to cure my grandmother, or my Yaya Urania. I'd like you guys to remember that name. Yaya Urania means grandmother Urania. She was my primary caretaker, as is the case in many immigrant families, and she started suffering from dementia. My ability to maybe believe that I could actually cure her took a lucky break when I took a test. I was in one of the worst school districts in New York City, in Long Island City, but I took a test that selected me to go to the Bronx High School of Science. That really changed my life. It was there that they had an incredible science research program for students. Back then it was called the Westinghouse Science Talent Search, and I started a high school science project on regenerating neurons with the goal of regenerating my grandmother's neurons. In 1989, still interested in this concept, I joined Len Schleifer to co-found a biotech company called Regeneron. In case you don't know it, the name Regeneron stands for regenerating neurons. During all those years that are on that slide, I never imagined how little progress we and the entire world would make against Alzheimer's over the last 50 years, nor that I would be entering into the age range where I would have to be worrying about this, and there's really nothing available to really give us great hope. So I know there has been a lot of progress. We've talked about so many things that are giving us hope, but I think that we do have to remember, and I want to highlight and give you some facts to remind you that curing human disease is arguably by far the most difficult scientific challenge that humans undertake. And I do think we have to really ask ourselves what we can do to actually do better at this task. So just to give you some of the sobering numbers, there's over 5,000 biotech and biopharma companies in the United States alone. The rate of new FDA approvals has not accelerated over the last 10 years. 10 years ago, there were 46 FDA-approved medicines that year. Last year, there were 45. And most of these are not big first-in-class blockbusters to treat the most important diseases like Alzheimer's or cancer. Therefore, rare and orphan diseases, which are important, but it reflects how hard it is to really make a difference in the most important diseases. These sobering numbers are highlighted by the fact that less than 1 in 100 biotech company ever invents a single FDA-approved medicine, let alone a major first-in-class blockbuster. So I do have to say, despite our lack of progress in neurodegenerative diseases, which has been our major area of focus at Regeneron for our entire existence of almost 40 years, despite that lack of apparent progress, at least from the outside, we have actually distinguished ourselves in our success rates. Over the last 15 years, we've averaged 1 FDA-approved medicine per year, going way against the odds. We've been pioneers in many new fields of biotechnologies. I do want to point out, since much has been made about this, we were among the first to believe that the human immune system was maybe the greatest natural learning machine that had ever been developed and was more powerful than anything us humans could come up with. And together with my mentor, Fred Alt, we wrote a paper in 1985 that said if we could just take the genes for the human immune system and put him into a mouse, that mouse would be the greatest drug discovery factory ever. And unbelievably, 20 years later, we created exactly such a mouse, and this velocity mouse has arguably been the most productive biotechnology ever invented, leading to almost all of our approvals. Why? Because it takes advantage of nature's most powerful natural learning system. We have a lot further to go with AI to catch up to what the human immune system can do, agreeing with what you heard coming from Jim Allison and others before. So among the various 15 drugs or so we've invented and developed, several are first-in-class and blockbusters, including 2 of the world's top 10 leading medicines. One is known as Eylea, which treats the leading causes of blindness in America, and Dupixent, which treats the leading allergic diseases in America. It's the #1 treatment, biologic treatment for asthma, atopic dermatitis, and a number of other diseases, related diseases. And we've been able to do it with one of the smallest and most efficient research teams in our industry. And one point that I want to come back to, it's not just about keeping people in science. It's not just about process. It's not just about, funding. It's about identifying the best and the brightest, because to do true discovery science, to really change the world, you need true human genius, which is probably the rarest talent we have on this planet. And that's something that I want to come back to and talk about a little bit. But just to show you what an impact drugs can actually do, Dupixent, which, as I said, it's actually the leading antibody biologic treatment on the planet. It treats millions of people a year, the most widely used antibody. It's approved and the #1 leading treatment in 9 different allergic-related diseases, from asthma to atopic dermatitis, shown on this slide. It's approved for individuals, including children as young as 1 year of age, who have moderate to severe atopic dermatitis. Means that they have this horrific, very itchy rash. Patients describe it as having poison ivy that never goes away, covering up to 50% or more of their body. Before Dupixent, there was really nothing for these poor children or adults. With Dupixent, it's really been a life changer. Like I said, I believe in faith and destiny and those sorts of things. Though I was never able to cure my grandmother, obviously, I named my oldest daughter after her, and ironically enough, she could have been the girl on the previous picture. She suffered from severe atopic dermatitis as well as asthma, was on 6, 7, 8 different medications, none of them really treating her. What are the odds? I went into science to cure my grandmother. I invented the very drug that gave my own daughter her life back. That's destiny, that's faith, that's belief. You can't make this stuff up. Well, lost the slides. Do I press the button or can you guys? Okay. All right. So getting back to this notion about how can we do this? I mean, what is it that I think we've done well at Regeneron, but what can we do better, not only at Regeneron, but throughout our entire ecosystem? And the first thing, and I'm going to get back to this maybe on my last slide, I don't have many more slides, is I think we have to understand that real breakthroughs depend on rare human genius and talent. And it's not just about, keeping people in the system and so forth. It's doing a much better job of identifying, nurturing, and engaging the best and the brightest young minds. We have to acknowledge that not everybody is a genius, but there are geniuses out there, and we damn well better find them, because if we don't, no matter where they are, we're not going to save our human race, okay? And we have to talk about how we can do a lot better at doing that. The other thing that I think we need is we need much better data that can act as a national resource for the life sciences and healthcare. And we've heard so much about AI. Everybody talks about AI. What everybody has to understand, and some people have touched on it, Newbark talked about a way to try to do it, Pam talked about it, and so forth. We have to all understand that AI needs data. Its successful applications for advertising, for self-driving cars, and in playing games like chess and Go that we heard about from Newmark, all dependent on the exploitation of constantly self-updating massive data sets. That existed in all of those fields. Those data sets do not exist, and they are not constantly self-updating in the life sciences and the healthcare business. Of course, things like EHRs and so forth that we heard about, those are there, and we heard about some efforts and so forth to engage and incorporate and integrate those sort of data sets. But what we know is in the life sciences, the most important data is not available and it's not constantly self-updating. And what am I talking about? It's the omics types of data, genomics and transcriptomics and proteomics that can really unlock all the secrets of nature, biology, and disease. And we have to actually make an active process to create such a data set, and I want to get back to it. But I think this should be a really national imperative because it can not only revolutionize healthcare and healthcare delivery, but drug target discovery and also clinical trials and so forth. And I'm going to touch upon that shortly. So with all of this aspirational stuff and talking about how difficult it is and so forth, of course, we all know there are, and we've heard some of them today, we just heard one from William Doyle, there are advances constantly happening all the time. I want to tell you a little bit about what we're doing at Regeneron in terms of cancer, where we're going. We heard a lot about prevention, but I want to talk a little bit about our slightly special or different approaches that I think are a very interesting way to really make a difference. Okay, prevention is not just identifying things and using existing tools to use them, but talking about using breakthrough new game-changing approaches. So yesterday, we heard a lot from Kathy Gusty, who leads the Myeloma Foundation, about what a terrible disease it is and how challenging it is and so forth. And we've also heard about bispecific antibodies. Regeneron is the company that put the first bispecific antibodies into humans, and we're very much believers and leaders in that space. But in particularly in myeloma, we developed a very powerful, we think the most exciting treatment in the history of myeloma that has generated incredible, greater than 50% complete responses in last line. These are 4th, 5th, and 6th line patients. But the really exciting thing to me about it is, as we would all imagine, the earlier you go in cancer, the easier it is to treat. In most cases, though, you don't take the most toxic therapies, the chemotherapies and so forth that you're using in the last stage patients and take them to the earlier lines patients because there's a therapeutic benefit or risk possibility or problem there. In the case of bispecifics, and this particular bispecific, it is actually so benign in terms of its profile that we can actually go into the pre-malignant state. That is not only first line, but before that, before you actually have cancer. And you heard Kathy talk about that yesterday. And so we've gone into both smoldering myeloma, but even earlier into what is known as MGUS, or monoclonal gammopathy of unknown significance. And there we take not only the same bispecific antibody, but we take it at 10% of the dose that you need in the last line patients. And you go from 50% complete responses to 100% MRD negativity. This is part of this definition of potential cure that Kathy was talking about yesterday. This, to me, is a way that we can really change everything. It turns out, many of you may or may not know it, I look around, there's a lot of us in the room that are over 60 years old. 5% of the adults over 60 in the United States have this pre-malignant condition. It's easily identified if we had a national database that had everybody's proteomics in it. If we could identify each and every one of these patients, we could give them potentially a short course of an agent like this bispecific and completely eliminate the possibility of developing myeloma. I think these are the sorts of approaches of identifying and actually pre-treating with short courses of benign agents to eliminate cancers that could really change everything. We have very related approaches that I could talk at length about to prevent disease in other cancers, also in the pre-malignant settings. I'm talking about treating every male over the age of 50 or 60 to shrink their prostates and prevent prostate cancer or its possibility. Same thing with skin cancers and so forth. So I think this is a way to change things. But in order to really do it and to do it effectively, you have to identify the patients who are at risks, because we know we're not actually seeing them. So even if today, which we might have, I mean, we're in trials now to prove that we are potentially actually curing these pre-malignant conditions in myeloma and in these other settings. But if we do it, the next big challenge is, how are you going to find all the patients at risk? So my dream is, if we had a new national healthcare database, we could actually identify. The dream is, what if we had such a database and we could build the possibility of identifying the 5% of the population who will account for 95% of any particular disease, and then we tailor approaches to not only treat, but to actually cure and prevent the possibility of those diseases. That's the dream. So in terms of such a database, this is something that we've focused a lot about at Regeneron. We invest in what we believe in. We've made the largest private investment in making such a database a possibility. We created what's called the Regeneron Genetics Center. It actually has created the largest private database of human sequence linked to health records and so forth, involving millions of people. We actually, for those of you who are aware of and use, it's the most widely used genetic resource on the planet. We're the ones who provided the sequencing and the proteomics and a lot of the funding for the UK Biobank, and we made it publicly available. but we have a much larger private database. We believe that having these large-scale databases would allow incredible, innovative, large-scale data analytics. It would really allow AI to really be powerful in our business, which right now, I'm sorry to tell you guys, it's not. But if we had such a database, it could allow incredible predictive algorithms, it could create novel genetics-based drug discovery capabilities, and it could revolutionize clinical trials. Just think about it, such a database, you could both instantly enroll your trials based on all the necessary enrollment criteria, but regarding what Pam Sharma was saying, it would allow you to also then understand how a particular treatment affected somebody based on their biometrics, their omics capabilities, and so forth. So we believe it would change everything. So this is my last slide, just to finish up on, I think, the two most important things that we can do in this ecosystem to really change things. The first thing, like I said, is to inspire, engage, and find the best and the brightest young minds out there. I'm a child of the 60s. I consider my president, JFK, I think he was the most aspirational, inspirational president that we've had in the last many decades. And I think that he fostered an environment so that I would argue that the 60s was a time where the best and the brightest young minds were engaged and went into the sciences. And I think we've done a much more terrible job since then, because it starts at the top and it starts with leadership. And I think we have to acknowledge, if we don't get those minds in there, we're not going to get, the results that we need out of it. And like I said, the other thing that I think that we could really get together and do, and I think that this is going to depend on a public-private partnership. I started with this effort, as Francis knows, more than 10, 15 years ago, going to the Obama administration. I've been dreaming that we could get the United States together to do this. I was disappointed that we had to go to the UK to work with them to do the UK Biobank. I think this should be a national imperative. If we don't do this, okay, we will not be making a difference in the long term. AI will not be that powerful a contributor to what we could be developing. And, if we don't do it, then I hope somebody else does it. I hope China does it. Why? Because the world needs it. And, we're all going to be dying from diseases, and somebody better do it. But I'd like this great country to figure out how to create a public-private partnership to really create a great database that could really make all of our lives easier and let us fight back against disease much more powerfully than we are doing right now. So thank you for your attention, and that's all I got for you.
Well, thank you so much, George. There were a lot of references to the audience being over 60. I have to say there are many people in the audience that are not over 60. And I'm really pleased to invite Lou Borio to the stage for our next panel that represents the under 60 crowd. They will talk about AI and accelerating innovation with the use of technology. So really excited about that. We'll give them a moment to get the stage set up. Thank you so much.
Good afternoon. Yeah, it's the under 60 over here. I'm so thrilled to be here. Like George, I'm an immigrant, and I was so touched that I've been included in the mural. It's beautiful, and I hope you have a chance to see it. Very touched about that. Thank you, Michael. But I have to say that what really made me laugh yesterday was that there's a book that goes with the history. And it lists the challenge that every immigrant was able to overcome, I guess, to be included. And mine was, it said, overcoming the US bureaucracy. And I have to say, I don't know if I'll keep trying. But for now, this is it's perfect that segue to George's, talk about. We heard so much about progress and future, and what's ahead. And here we're going to explore a little bit of why hasn't it been faster, right? And to set the stage, let's think a little bit about the progress that's been made in cardiovascular disease over the last few decades. So now heart disease and cancer are two of the leading causes of death in the United States. In many age groups, cancer is now number one. And whereas we've made extraordinary progress in cardiovascular disease, mortality has dramatically fallen due to better risk factor identification, modification, advances in treatment, etc. Cancer mortality has also fallen, not insignificantly, but at a much slower pace. So about 30 to 35% since the 1990s. Real progress, but incremental, much work to be done. And we know innovation is happening, but why isn't it happening faster? Why aren't we bending the curve faster? So with that, I will love for Grant and Helmi to introduce yourselves and tell us a bit about what you're working on. Helmi, what problem are you trying to solve?
Yeah, so I love that question because I come from the engineering field. I was an electrical engineer. I worked on semiconductors, and we always think about Moore's law, Wright's law, how we move faster, how we sort of decrease the time it takes to essentially close the loop around a cycle of learning. And it's what we're seeing with AI and with autonomous driving and all these things, the exciting impact when you apply leverage and compounding to fields. And so when I got to healthcare, I was working in the Human Genome Project and then sequencing, reducing the cost of sequencing from 100 million to 10,000 to 1,000. And so I always thought leverage was an inherent part of science. And I realized in healthcare, somehow that doesn't work. We think it is, but it's not. And so what we worked on at Guardant was we realized if you could see disease in blood, cancer in blood, we could decrease that cycle of learning. We could go from diagnosis to understanding the effect of the disease, how the cancer is changing under therapeutic response, detecting it earlier, and so on. But we had intellectual humility, so we knew that early cancer detection would be probably a hard problem. I think dozens of people and thousands of people and dozens of years have been applied to early cancer detection. So we basically said, let's start with late-stage disease. And so we started the company in about 2012, and we said we'll develop a blood test to help late-stage patients. There are about 1 million late-stage cancer patients in the U.S. The big challenge there is you get diagnosed, what drug should I apply to this patient? What are they, what could potentially be beneficial for that patient? And so we basically pioneered this concept called liquid biopsy, and we launched the first liquid biopsy that was clinically available, commercially available in 2014. And it was an exciting moment, but there was a lot of skepticism. Everyone said, oh, this is kind of snake oil. This stuff doesn't work. It's not representative of what's actually in the tumor. And, maybe I'll tell a story of the 11th patient we tested was in the Bay Area. She was a 48-year-old woman. She was diagnosed with pancreatic cancer. She had a mother of 2. She was told that she had 2 months to live. She should just go straight to hospice. She went to another university, another cancer center to get a second opinion. And we had been working with that doctor, and he said, oh, there's this new blood test out there. Why don't you try? Why don't we try it? It can't hurt. We ran it. We found mutations that were not consistent with pancreatic cancer. They're actually consistent with ovarian cancer. They tested other markers, say 125 and so on, and found out indeed she had ovarian cancer, was put in a drug that's been around for 30 years, and had a complete response. And at that moment, we sort of knew that healthcare is extremely data starved. Sometimes just a little bit of extra shred of information is enough to change the course of humanity, to change the course of a single life. And so then, when that test started really taking off, now 30% of US cancer patients have that test. It's part of standard of care, part of guidelines, and so on. But we use the information, the data from running hundreds of thousands of those tests to improve the sensitivity by a factor of 20x. And so then we launched a test for 18 million cancer survivors, MRD, in the solid tumor setting. These are early stage, let's say, breast cancer patients. You want to test them every year, make sure the surgeon got it all, make sure that the cancer is not coming back. And then we use the data from that, we sort of compounded on that to develop a test for early detection of cancer. This is the first FDA-approved test. We got FDA approval in 2024. The first, and that test is about 5 times more sensitive still. So we went from 100x improvement in sensitivity over 10 years of compounding on the data. And that test is approved for first-line colorectal cancer screening. There are 50 million Americans who are not screened every single year, and 50,000 deaths, 76% of those deaths coming from those unscreened. And so we're finding this test, since we launched it, is the most successful test ever launched outside of COVID testing. And now 100,000 people have been screened, 20% of them in rural areas that almost have never been screened before. And that's what's really been important for us, is to make sure no patient is left behind. Most people in this room can afford best medicine, but how we truly bend mortality curves and make sure that we change healthcare as we know it is to make sure no American gets left behind. So it's really exciting that in this last 12 years, we went from something that was just a hope to something that is quickly becoming a standard of care and truly changing cancer care as we know it.
Great, congratulations. So Grant, what problems and bottlenecks are you trying to solve? And tell us a little bit about yourself and background as well.
Sure. Thank you. So I usually say I'm the token millennial in the room. So I'm happy to be the token millennial here with my panelists. So I was born and raised in this area. Actually, someone put up the blood slide from Crystal Makel. That was my first boss. I got a fellowship in high school and worked at Building 10 in the National Cancer Institute, in part because some mentors, Rick Klausner, Francis Collins, others, said they didn't care. You didn't have to go to college. So I said, great, let's put that to the test. To their credit, they let me in, and then they kicked me out. No, I'm kidding. And so fell in love with medicine, got to see the bench to bedside research, and then got to see and just fell in love with neurobiology and the intersection of neurology and oncology. Then blew my knee out playing sports in college, had 21 surgeries on my right leg. And when you juxtapose Building 10 and the bench to bedside research to the way the average American gets healthcare, I got to see that with my knee. I had a surgery. Those of you seen Lindsey Vaughn's issue, my knee is very similar to hers. It was not as bad as hers. But in my case, I blew it out. And then much like the thesis we've heard, which is that we're very data starved in healthcare, part of the surgery that I had was as simple as you shouldn't do it on a patient who's still growing. So I didn't need some complicated AI. I just needed to say I was still growing, which at 21, the fact that that was not clear, I suppose, is also surreal. But so I dropped out of college and tried to take my background in neurobiology and apply it to AI and machine learning. So I'm a self-taught engineer by background. Reinforcement learning is kind of my specialty and background. And it really goes to that concept of data and being data starved. I have a saying that everyone knows that it's not mine, but it's about garbage in, garbage out. And I think the combination of the garbage in, garbage out model on data, and an example of Garden is a great example. Because of your iteration and because of your data, you 100x'd the infrastructure, you dropped the price, perhaps even more, and democratized access. And I was saying the story to Lou. I sold my company to United Health Group, was the first chief digital officer there, and my #1 priority was democratizing access to the roughly 8 petabytes of data that we had at United Health Group. I did not succeed. And one of the things I wanted to do was imagine if you could have had something like your test for just the fully insured population at United. And the math was we only needed to get some of the prevention that we've seen in early detection to pay for itself by a tune of 10x. But the problem at the core was an incentive issue, which you had payers who had some stake in the game, sort of maybe, but they have a financial stake long term, but then they have all these other things like PBMs, and all of them have gone to acquire physician groups. For those of you that didn't see the managed care CEOs in their testimony in front of Congress, they all raised their hands for, are you a payer? Are you a provider? Are you a PBM? Are you negotiating drugs? All 6 of them raised their hands. And so I think that is probably the best example of the bottlenecks in America, which is the incentives have been for a sick care system. The incentives have not been for a system that it focuses on prevention, that democratizes data, that allows us to 100x opportunity and infrastructure. We always said Moore's law was dead. When you think about compute, the same should be true for things like access to garden tests. And so I'm an entrepreneur by background, and now really focusing on that data problem and how do we link multi-omic data with real world data. The average academic medical center produces a petabyte of data a year. Less than 5% of that is used in any patient or provider facing application. And so we are very focused on democratizing access to that data and then taking models like we heard from Royalty Pharma and just saying, well, how do you reimagine infrastructure where you can create an ecosystem where you can create the right incentive? And just because the people that came before you had 30-40% of the market, of the royalty, does that mean you have to have 30 or 40% moving forward? What if you create a rising tide that can lift many boats? What if you created drugs that had multi-product access, multi-patient access? What if you could link that to rural health and what telehealth can do? One of the issues I ran the home health business at United, and if you guys knew how often we send a clinician to a patient's house and say, I'm going to go edit that patient's prescription. Oh, wait, I can't do that because I don't have the ability to edit that prescription. That still is a billable event, and so that gets tacked on the top. And so how can we bring intelligence to say the right drug for the right patient at the right time and in the right care setting? And so for us, we think the combination of democratizing access to drug discovery coupled with early detection and prevention, then you can start to bring in the power of agentic AI. And what we've done is gone to academic medical centers and say, what if we could, our $1 trillion idea is, what if we could just double the time clinicians had with their patients? And the things that we've done is a place like Duke, we saved about 6 minutes of time per patient, per prescription, per week, which might not sound like a lot, but that rolled up to 250,000 minutes that was spent nearly 100% on administrative crap, that now they got to go spend time with their patients and look at things like how do they get access to patients that don't come to Duke. And that's where you can start taking this agentic AI opportunity and start to fundamentally rebalance the supply and demand curves in healthcare, because we still haven't figured out how to create more clinicians at scale. So we've had things like nurse practitioners, physician assistants, but those are not 100x improvements like the sensitivity and costs that Guardant's built. And so that's what we want to really focus on. And we think the agentic AI revolution can fundamentally reimagine incredible things like oncology, gerontology, places where we have a lot of clinicians, they're retiring. So just like there's 10,000 seniors aging into Medicare, there's a number of clinicians that are retiring. And how do we think about the combination of the incentive, the data in, garbage out, and then on the other end of the rainbow, how do we put as much infrastructure that is highly repetitive into the hands of the agent so the clinicians can get back to doing what is still, despite all the technology, and I'm not a doctor, I got, two years into college, but it's still, in my personal opinion, far more art than it is science. And getting back to the art of taking care of patients in the right place at the right time, and then creating democratized access to these drugs with an incentive that aligns to outcomes. I think there are no miracles of science required to get to things like 100-year life expectancy. It's a function of incentives and then access.
Okay, well, it's almost like you covered the whole thing, the whole
I
gamut.
went as fast as I could. You were
But-
nice enough to send the questions ahead.
You got nervous that I wouldn't ask follow-ups. But so it seems that both of you are disruptors. So there's part of me that thinks it's one thing is to innovate when there is a vacuum, and the other one is to innovate when there's a legacy system around you that is really resistant to change. And how much does that contribute to slowing down adoption, like this extra hurdle? I mean, I still see physicians saying that, colonoscopy is the way to go forever. And physicians who realize that there is no bandwidth and they cannot serve patients, but they still don't really want to adopt a novel model.
Change.
So,
Yeah, it's interesting. It's we've always thought that working within the system is best. So we've always taken a Trojan horse strategy. It's, can you put something into the system that replaces something or is better than something that's there, but like a small entry point, and then expand from there. It's kind of like how I think you think about a drug like Keytruda. You start with a beachhead indication, and then you expand rapidly and so on to many other indications. We think of sort of healthcare the same way. It's why when we tackled 2012, a business plan was annual, multi-cancer early detection at an annual physical. Like that was always the business plan from when we raised money from Sequoia and so on back 13 years ago. But we knew that it's very hard to sort of establish sort of new methodologies, especially when clinical utility hasn't been established in certain disease types. And you tend to need mortality studies, 10-year studies. And being mathematicians, we always said the transitive law is one that we love. So we said, let's start with colorectal cancer, because there's a regulatory pathway, there's a reimbursement pathway. There are studies that have shown that both FOBT and colonoscopy lead to long-term positive outcomes, not just lead time bias. And start from there and then expand. So I think there is an art to how you take this, and I completely agree with what Grant was saying, that we have a sick care system, we have a system that pays for interventions and doesn't pay for data. You can't right now get a code for an algorithmic improvement or AI improvement right now from the AMA. So there are roadblocks all across the system. I'll give you one more example of like how difficult the system is. We generate tons of data with every test, these beautiful reports, like color, all these different artistic kind of graphs in it and so on. And 30% of our reports have to be faxed. And this is the same for Quest and LabCorp. And because of, I think, meaningful use and so on, those providers then take those reports and scan them back into their EMR so that it's EMR connected. And so, just to tell you how much data we're producing, in a year and a half, we'll have 1 exabyte of data. That's 1,000 petabytes. We generate way more than Visa or these, and yet we then have to compress it into a grayscale fax, page and so on when we submit it to these providers. So I would say the biggest challenge is we don't think about closing the loop. So I'm also an investor. I invested probably in like 60, 70 companies. Many healthcare companies are doing AI. And they use amazing simulations and so on to find new drugs and exquisite science. They're using all these ASICs and sort of like amazing hardware to develop new targets. But then if you still have to take 5 years to go through phase 1, 2s, and 3s, just like any chemical reaction, your bottleneck is the slowest step, is the slowest reactant that's there. And so you'll have to think about the full loop. You can't just sprinkle AI and hope that the system will take care of itself and that it'll go faster. And so that's one of the big things we've thought about is how do we really leverage, compounding is about reinvesting principal. I used to trade futures and, early on, and I learned compounding the hard way, both the good and the bad. And I don't think we invest the principal in healthcare. And that means taking all of the data, everything that you provide, and reusing it for essentially for the next innovation and the next one and the next one.
And just like doubling down, right?
Yeah, so, you talked about the need to close the loop, but Grant, let's talk about AI per se, like the promise versus, what, despite the promise, it's been kind of frustrating, I guess, to see the number of.
Yeah, and a great example is when you look at someone like Garden, people like the FDA would say, oh, it's a device. That's not a device. That's a data company. If they've got the exabyte of data, but yet we look at it and we force these great companies to put something through a fax. And I mean, I went through this process where almost every academic medical center is doing prescription refills at scale with faxes. And when I say at scale, I'm talking 50 to 100,000, a month or a quarter. And so when we would go into some of those exact bottlenecks, when we would go to talk to folks at academic medical centers about liberating and democratizing that other 90 or 95% of data that's not used in patient or provider facing application, and you talk about AI, you get into all these things like we were talking about human in the loop. Part of our thesis is you can't expect a healthcare system to automate something that you can't show the chain of auditability. But you also need to be able to, if you have, let's say, 1,000 to 1 or 100,000 to 1 or 1,000,000 to 1 agents to people, how do you manage them? What do they spend their time on? And so for us, that's where, going where the data is rich, but then not too dissimilar like Garden, we take that data and we use it to be able to land and expand in the academic medical center. And part of what we do, much like his thesis, is when you land and expand, we would go in and say, why don't we just remove the facts? And we'll give you all the data that comes with it. And you'll be able to meet patients where they are. And providers hate doing faxes. Patients, does anybody here have a fax at their house? Okay. I saw that. But there was every single academic medical center has a fax that is doing massive amounts of PHI and PII at scale. And so I think part of the problem is the combination of the incentive. We heard earlier when Patrick was talking about centers of excellence, the problem that underpins centers of excellence, you get into, well, that's my data. What about your data? Is it the employer's data? Is it the patient's data? Is it the payer's data? And the answer is it's the patient's data. We've just come up with all of these different ways to monetize it. And then when you take Helmi's awesome point, they're not doubling down on the data. When they find something, they then take that as their core advantage because healthcare is not a few multi-billion-dollar transactions. It's millions and millions and millions of small transactions that are rolled up at scale. And so you'd think that, you could just put AI in and solve a few things. I will not say the company, but like prior authorization should not exist in the age of AI, period. If you look at some of the incredible things AI can do, why do we have prior authorization? I used to say when I was the chief digital officer at UHG, every day that you wait to approve a prior authorization, and I would get people back, but we approve it 95% of the time. I don't care. Between the day that you put that document out and it's approved, your net promoter score goes down 10 points a day. And that's the reason why healthcare companies have the lowest or second lowest net promoter score behind only the telcos, because they're fundamentally allowed to get away with a business model where they don't have to focus on the outcome of their patient. And the strategy involved is not how to make healthcare better, faster, cheaper. It's how the incumbents keep it in their little sandbox with their toys and their market share. And I think the AI promise and opportunity, as you heard from Regeneron, requires data, but it can fundamentally lower $2-3 trillion out of the American healthcare system, but we still need to know right patient, right time, right therapy, right setting.
So we're almost out of time, but I want to ask a few questions in rapid answers. Like,
I see you're focused on me
you
for
can
that.
choose who. So give me one bottleneck that must disappear by 2030.
It's hard. So many. I would just say that, like, I think the future is bright in terms of what we've seen. Like, I think we truly are in the chat GPT-2 era. We've built a lot of architecture. I don't think a lot of people see it yet. Just to give you an example of where we're going, I think later this year we'll have a test that's 50 times more sensitive for cancer survivors, that we'll see tumors less than a millimeter in size in blood, which is exciting. And then we're seeing signals for many other diseases. So I think the machinery is there, and I think we're in the right direction, and things are exponentially improving.
Yeah, I mean, one of the things we've talked about is a model called shared savings. What if you got to participate in the outcome that you delivered? So what if you went to a health plan and an employer and a provider and a payer, excuse me, and a pharma, and you could say, I will democratize access to this data, but we, the AI company, only gets paid if you can show a lowering of the total cost of care. And so one of the bottlenecks would be we need to come up with really interesting new ways to finance that infrastructure. Like, what is the royalty pharma for the agentic revolution focused on getting data access into the multi-omic future? That's what?
Appreciated lever that we should think more carefully about how to share the gains and align incentives.
Yeah, and you know, as you do that, as you share, you know, it's the old Warren Buffett, show me the incentive and I'll show you the behavior. I think we've seen the model for the last 50 years of what the sick care system looks like, where it's built on intervention. What if we just started to look at a model that said an ounce of prevention's worth a pound of cure, and I'll let you participate in that upside?
So to finish the sentence, cancer mortality in 2035 will decline because
It's a garden health option.
No. Early detection and better prophylactic interventions.
Yeah, that's why I was being a little bit flip. But I have a friend who has a world-class cancer team, and the drug that she is taking is a perfect example where she had a garden product. She was not an obvious patient for that drug, but because of all the data, it was sort of, and she was very sick, stage 4. She now just takes one pill and gets a garden test. So if he can deliver that scale, I think the art of the possible is incredibly exciting.
in Georgia's database.
Yeah, I want that data.
can't
I
forget
need that.
that.
Yeah, hit those 2 databases we got to go get access to.
Thank you. Thank you so much.
Thank you.
Thank you.
Delivered and on fax machine. On time for sure. All right, I want to introduce our last talk of the day, and then we will close with our 2 final panel conversations. Let me invite Preenha Narang to join us on stage. She is the professor in physical sciences and electrical and computer engineering at UCLA, and she'll give us a talk on quantum technologies delivering real breakthroughs in human health. Preenha?
All right. So I know it's the end of the day and you're wondering, is there more AI coming? And no, we're going to talk about quantum for a little bit. I'm going to start by thanking Mike for having me here. I'm a trained physicist, not a trained physician. Makes a big difference. So I may have the word doctor in front of my name, but the wrong kind of doctor. And I'm excited to tell you about what quantum can do. Of course, this is a leading question. You know, what can quantum technologies really deliver in terms of breakthroughs for human health? So when we think about quantum technologies, and I use the word quantum technology rather than just saying quantum computing, because to me, it has 3 different components. There's computing, and that's what gets most of the ink in the press, and maybe you've read recently about how quantum is going to change your life. We'll talk about that here in a second. There's also quantum sensing, which very naturally connects with what we're talking about here today. And quantum networking, of course, when we think about networking, you could connect lots of things very far away. You could also think about a network of quantum sensors, which has interesting capabilities, again, for healthcare. So the promise of quantum technology has, of course, been around for a while. And the promise of quantum computing is especially relevant now that today we can talk about devices being large enough that problems that are of interest are actually able to fit on these devices. So when I first got into quantum, it was this esoteric thing, and most people said, "Great, that you're going to have a fun experiment that you work on in your lab, but it's not going to be a technology." Today, we're talking about this as a technology. You can get time on these devices, whether you access them on the cloud, whether you access them on-prem. These are effectively technologies that could not only solve problems that we can't easily solve classically, but also allow us to accelerate some of the workloads that we've seen come in from the AI piece of this. So when we think about quantum computers in particular, this is almost a menu of options, and they all look very, very, very different, okay? So there are superconducting qubits, and you've perhaps, I use my hands to describe a lot of things, so maybe I'm gonna put my glass down and use both my hands for this. So you've seen the photos of quantum computers. Those are those large chandeliers, and you would think that all quantum computers look the same. That's not the case. That's just the superconducting quantum devices, okay? And most of that chandelier is a way of cooling the device that sits right at the bottom. That is a very different kind of platform than thinking about trapped ion quantum computers, which have effectively a lot of lasers, trap something, and you're using these ions then to do the computation. They're spin-based qubits, they're photonic qubits. This list goes on for a while. And for each of these technologies, there are companies out there that'll tell you that here's my device, here's what it can do, and here's how you effectively run an algorithm on it. So I want to tell you a little bit about the work that we're doing, particularly in using some of these trapped ion quantum computers in conjunction with classical supercomputers in order to solve problems of interest to folks in this room. So I see that there are distinguished members from NIH here today. We were really lucky to win one of the NIH quantum computing challenges. I have never been fortunate enough to get an NIH grant, by the way, in part because, again, physicist, not physician. We proposed new algorithms that would allow us to not only look at new molecules, this is one of the biggest promises of quantum computing, but also think about their interaction with the environment. This is effectively called open quantum systems, or simulating open quantum systems. And of course, we needed a cool acronym, so we said we are going to quad solve it, okay? Our partners for this challenge are Quantinuum, which makes these trapped ion quantum computers, as well as NVIDIA. You might have heard of this company that makes these large classical supercomputers. And we said, let's think about algorithms that can, with current devices and devices that we have access to in the near term, actually solve problems that are relevant in drug discovery, and think about kinds of interactions that we can simulate. So we have been working on some of these algorithms, and I want to tell you a little bit about not just the algorithms we've worked on, but also what the field is doing in this context. Now, discovery of molecules, thinking about the interaction of molecules with the environment, that is one of the biggest promises of what you can do with these quantum computers. It's certainly not the only one. There are other ideas that have been proposed, ways of incorporating a combination of AI. We heard about that from the previous panel, as well as quantum computing. This could be for predictive healthcare analysis, personalized medicine, but also ideas in diagnostics, and taking, by the way, some of the predictions from quantum computers and using that as data that can train new models. So let me spend a little second on that, since we heard so much about the kind of data that doesn't get used. There's types of data that we have never trained models on that is actually generated by these quantum computers. These are ways that we could train new kinds of foundation models, and that's actually something that there are folks out there working on. Okay, so I digress from where all of this comes together for healthcare. When we think about some of these new molecules, of course, the molecules themselves are really, really large, and as you might imagine, the types of devices we have access to at the moment cannot simulate the entire molecule by itself. at least the quantum computers can't. But you can think about coarse graining the problem, which is a fancy way of saying I solve the core of the problem using the quantum resources we have access to, and then the rest of the problem using access to classical algorithms. And this combination of hybrid quantum classical compute could actually unlock some of the problems on this slide in the very, very near term. So let me give you a smidge more detail on that. And I was told no equations are allowed for this talk. So there are no equations, do not fear, no math. But I'll say that there is inherent power of prediction that is enabled by quantum computing. And this promise goes back to famous words from Feynman that said, we're simulating quantum problems, might as well use quantum resources to do it. And of course, the scale at which you solve these problems, the complexity of these problems goes to the heart of the work happening in algorithms in quantum today. So these are, these molecules or systems on this slide might look embarrassingly small to those of you who think about, real proteins, real molecules in drug discovery, but these would then form the core of the problem that you're solving quantumly together with classical compute. It's not just all compute. I want to just say that the intersection of AI and quantum is, in fact, so it's not just computing something quantumly. This intersection was initially framed as a competition. I'm really glad that that era only lasted a couple of years, and then folks realized, actually, you could integrate AI into scaling quantum hardware, controlling quantum hardware, into error correction, and actually, very importantly, and this was not actually anticipated in the early days of quantum computing, you could think about the energy implications of AI being, in some ways, lightened by the quantum architecture. So effectively, if you look at, instead of time to compute, you look at energy to compute, there's an opportunity to use quantum devices there. And this is relevant because now the next generation data centers that folks are talking about, particularly those that will be built in the near term, will incorporate a combination of classical and quantum compute, and that includes traditional chips, photonic chips, and quantum devices, including trapped ion devices that I've mentioned already. And this intersection, of course, could also allow us to get to this practical quantum advantage point much, much, much faster than was originally predicted. So previously, folks said, well, sure, we'll solve problems, simple chemistry problems, material science problems, maybe slightly complicated optimization problems, and eventually we'll get to things that look like real problems in pharma and healthcare. That is no longer the case. The fact that this crossover has now, for the type of problem size, again, depending on how you account for that, that is very near term. In fact, Department of Energy recently announced that we expect a fault-tolerant quantum computer in the next few years, and that would bring this crossover effectively to the next 18 months to 24 months, depending on how ambitious you feel on a particular day. Okay, so in addition to that, and I know I'm running out of time here, I promised to not get us further behind time. We also went the route of quantum sensing, and you might think, well, what do quantum computing and quantum sensing have in common? If you have a great qubit, you use it for compute. You have a crappy qubit, you use it to do sensing. Okay? Anything that interacts too much with the environment turns out is actually a great sensor, and you can show rigorously, again, no math on these slides, but I'm happy to walk you through it, that there is an advantage to quantum sensors relative to even the best possible classical sensor that you could make. So some of those same qubit technologies that I was showing you on the very first slide, now imagine them as being used as sensors, particularly the spin-based qubits and the photonic qubits. There are ways of incorporating those into sensing technology that we are looking at. And we said, well, when it comes to sensing, you don't have to completely replace every classical sensor. You could have quantum enhanced sensors, and that actually might give you more of a near-term advantage. So this is something we're working on, and we have a few different partners for this challenge, and there's an opportunity here to bring these sensors to life and perhaps to your labs in the near term. Now, We don't know, at least as quantum scientists, how to think about clinical trials. I sat through some of the panels earlier today, and I was trying to take down the jargon and the acronyms initially, and I said, oh, I gave up at some point. I said, I'll just say this in my talk. If you know how to bring a new sensor from something that is, in my lab to something that could actually be useful in a clinical setting, please come talk to me, please write me, because that is something that we have lots of kinds of sensors. We think they're useful, but we don't know exactly which scenario and which kind of detection they would be best for. Okay, so with that, I just want to jump to my last slide here and say that there's a company that we recently, and this is a cancer convening, so I couldn't not mention this, we've started working with that is looking at ways of tracking metabolism, thinking about cancer metabolism that could provide critical information. This is using the kinds of spin qubits that I talked about very briefly, and I can tell you more about this, but this is something that we think could be useful. That's something that a bunch of physicists working at this company think could be useful, but I would love to hear from folks who are actually working on cancer diagnostics as to how this might make your life better. So with that, thank you so much for listening, and happy to take a question. I see you have 90 seconds for it. So. No, wait, okay. All right. I will
Yeah. Thank you. Thank you so
thank you so
much.
much.
Yeah, really appreciate it. Yes. All right. Well, thank you so much for that. It's wonderful to hear from other disciplines and how we can apply that in cancer research. And I loved your comment that you said you couldn't understand the jargon in clinical trials. I think we can flip it the other way around too, where the audience will need to interpret a lot of what's happening in your field relative to cancer research. But thank you so much for that. I do want to introduce our next panel on technology as a force multiplier, delivering innovation at scale. And that will be moderated by Sharmila Makija, founding dean of the Alice Walton School of Medicine, and she will introduce her panel. All right, thanks.
Well, you guys are troopers to still be here. So we promise to be very succinct, to the point, to get you home soon. So thank you for staying here. And as Esther said, we're going to be focused on looking at AI technology across the cancer ecosystem and how does that ultimately help improve patient outcomes. We have an esteemed panel here from various backgrounds, from pharmacy to EMR to strategic consulting and cancer centers. And I have to have a shout out to you because I'm a Sloan Kettering grad. There was a lot of MD Anderson here today. So, but you are from MD Anderson originally, so okay, we'll let that pass. So why don't we just go ahead and jump right in? And you can just spend maybe 30 seconds introducing yourself before you answer. That might be the best way to use our time well. So, what are some of the technologies that are beginning to enhance cancer care as we see it now that we didn't see a decade ago? And then what do you predict 10 years from now of what it'll look like? So Lucille, if you'd like to start.
I oversee the CVS specialty pharmacy operations and also the chief pharmacy officer. So definitely are very much engaged with our oncology patients. What I would say is it's unique right now is we leverage a lot of EPIC or EMR technology to help in getting the patient started. Our goal is to get the patient quickly started on new medications. Obviously, when they're highly sensitive to a new diagnosis, we want to really start them fast. And if you all know, we heard before, prior auth is one of the areas, but also affordability and the ability for patients to find access to cost-saving opportunities such as copay assistance and foundation support. So we try to do all of that very quickly. And what I've seen us do that's really definitely different than 10 years ago is being able to leverage AI to get this information as fast as possible. So being able to scrape the EMR to grab all the data that we need in order to populate the prior auth, to get it out as fast as we can. The copay assistance now is also available in a way that you can go in, I'll call it an AI agentic agent just for each copay card. And then also the ability to scour foundation support to support the copay and the affordability. I mean, if we can get those three things done really quickly, our mission is to actually see if I could start a patient within 24 hours. And in today's world, it can take possibly 3 to 5 days, sometimes longer. It depends on the plan and depends on the design.
Hi, everyone. I'm Jackie Gerhardt. I'm a chief medical officer at Epic and a family medicine physician by background. So in the last 10 years, or even further back in history, how many of you have MyChart or a patient portal? That's nearly everyone in the room, which is outstanding. That means you not only have access to your data, but you also have the ability to connect with your caregivers and connect across different instances where all of your data live. And that oftentimes is one of the biggest barriers to making sure that people can actually get timely information and good care. So I've been thrilled to be able to see my patients and message with my patients in that way, to be able to provide them care that really is centered around them and their families. Coming up in the next 10 years, I am most excited about AI, and I'll go back to what Dr. Oz said earlier this morning about being a 10 out of 10 enthusiastic and hoping that this is really going to be something that changes the way that we do things. And I feel that's true from three different aspects. And how we think about AI at Epic, there's sort of three domains. The first is improving workflow, so things like ambient listening or making sure that you're getting things done in your in-basket. Then agentic workflows, so what would it look like, as we mentioned earlier today, to have someone that was acting on your behalf, an agent that was acting on your behalf, to try to collate all of the information to make the right thing to do, the easy thing to do. And then lastly, healthcare intelligence. So how do we take real-world evidence and all of the guidelines and knowledge that we have and be able to apply it actually in workflow, so that no matter where you live, no matter what care you're getting, you can have really good standardized and personalized care for you. And leveraging that, I think, is really the low-hanging fruit that we all want to be able to provide to all of our patients.
Kimberly? Hello, everyone. Kimberly Myers. I'm a partner at Deloitte, where I lead our health and science nonprofit practice. I'm also a scientist by training. I have a PhD in virology and then spent 5 years working at the National Cancer Institute before coming to Deloitte. What I'm most excited about is honestly what we heard a little bit about last night and have heard some about today, which is federated learning. And so when we think about the Cancer AI Alliance and what is being enabled there, that I think we would have dreamed about 15 years ago when I was at the NCI, for example. And so thinking about how we can start to learn from large, diverse, real-world cancer data sets at scale, and being able to do it without compromising sensitive patient information, I think will enable multi-institutional AI validation and development at scale. And I think that's super exciting. And if we fast forward then 10 years from now, what that might look like to be learning from that platform and to think about some of the continuous improvement we will see in care as that system becomes smarter and smarter as we accumulate more evidence and more data.
Aniezo Fodley, I'm a surgeon, a health policy researcher, and the chief strategy officer at Sloan Kettering. So I think what I'll do is I'll try and paint a picture of how care happens today at places like MSK. So a patient, man, woman, with any of the big four, so like cancers, let's pick colon, for instance. That person comes to MSK, they get genomic profiling, that is AI-enabled to some degree, actually. If we're able to identify a driver mutation or an alteration that is sort of informing that therapy, we're now able to use a knowledge base, also AI-powered, to match the patient to the right therapy based on guidelines and or available clinical trials. Now, based on that same data set, we're able to predict disease trajectory, predict toxicity profiles, right? And moving forward, we're also now able to post-regimen have nice sort of like long-term follow-up based on MRD as we heard about today. So this is what's happening right now. And each of these steps in the value chain of this patient episode is powered by AI. And that was not the case 6 years ago. Now, looking forward, and it's been touched on a little bit today, what I would love to see, and I think is less of a technical problem as it is culture, infrastructure, and systemic, but how do we get all this data, as George referenced, the omics data, environmental data, clinical data, imaging data, billing data, how do we get a unified decision-making framework, right? One that is personalized, proactive, right? And one that is also maintained longitudinally and able to be scaled to all patients everywhere. So I think that's what I'd like to see us go to in the next 4 to 5 years, not 10, and that's super exciting. But that's sort of where the state of the art is right now.
That's great. Did you want to say something?
You know, it's really interesting. We also, when we're treating patients and interacting with them, we're also pulling a lot of data. And that data also is leveraging like certain types of outcomes. It would be really great of all of the millions of patients we're interacting with on a daily basis in our pharmacies, getting that information, how we can all kind of leverage it to take it on for better outcomes. I mean, I think if we all were able to consolidate all that data in a way, wouldn't that be like a really tremendous database of George that he's looking for from just an outcome is like the end point of interacting with the patient, getting information. I'll share, we do system checking with them digitally, and I've seen patients become extremely digitally engaged in the oncology space.
To that point, I think the comment was made earlier about healthcare being relatively data poor. I like to reframe that and say it's actually insights poor, right? I think a lot of these data exist. They are nonlinear, they are not integrated, they're not deeply phenotyped, and yet they're not longitudinally maintained, right? So in many ways, I'll say healthcare is not built to be AI native. That's one thing we need to solve for. But more importantly, we need to sort of increasingly perceive data as a strategic asset, right? And how we steward that asset should be on par with clinical quality. And I think that's where the puck needs to move. So we have the data, is how we curating, maintaining, and leveraging it in service of our patients. I think that's the real ask for us.
And you know, as we talk about these advances, what are the barriers to actually deploying this across healthcare systems, right? Because it's one thing to have the technology, but how do you actually get this to work across? And maybe Jackie, if you'd like to talk about it. You know, I know earlier there was some discussion about the clinical research infrastructure, and Epic was brought up with Cosmos. Do you have anything to add to that?
Absolutely. So at Epic, we have a customer collaboration. So it's a voluntary role for each one of our customers that they can choose to contribute to Cosmos. It's a data set of over 300 million patients. And really the founding principle of it was to bring insights back to care. So I love the comment about, I do think we actually are quite data rich. And I think if it's curated in the right way, it can create some amazing insights. And then to take those insights and actually embed it into the point of care in your actual workflow in front of a patient is the next step. And that's what I'm most excited about. I want to be able to take the screen, turn it towards my patient during the exam and say, hey, you have a rare disease, or you have a constellation of symptoms that we've never seen before, or at least I've never seen before. And instead of the old school idea of me going to the physician's lounge and asking my friend, instead I can leverage the 300 million patient records and the knowledge of the clinicians that have treated those patients and be able to come up with a faster treatment, a faster diagnosis, and really get them to the next step, which to me is really the promise of it. I love the idea of being able to take the data and be able to do research. But as we learned earlier, sometimes it takes 10 to 15 years for that to be from research to actually get applied into practice. And that really shouldn't be the time from an insight where it's written to the time that it actually is something that can be taken into patient care. So narrowing that gap is what I'm most excited about.
And if I could build on that a little bit, I think that, I think many of us are aware that generally data and often the technology aren't the rate limiting steps, right? Those generally aren't the barriers. It's the other things that go around it. And so we've talked about some of the constraints around the data, right? Getting access to the data, the need to liberate the data in a lot of ways. And part of that is also we need better trust frameworks and architectures. And so, thinking through interoperability, governance, what are the things that we have to put around this so that data can flow and we can use it in all of the ways that we're talking about. I will also say just the operational adoption is highly important, and I think is something that is particularly slow. And that is often just having the workforce that knows how to manage this, having the governance structures, having the workflow. So all of those pieces around operational adoption are really people pieces and have very little to do with the data.
I would say some of the other barriers as I sit in the pharmacy and work with multiple payers is that many different systems all payers are on and don't really talk to one another, right? And that's always a hard part, as well as to be able to work with payers in a way that makes it simple. And I think, similar to what we talked about earlier, how do we make this simple is we have to be able to talk to each other systematically in a way that a payer can see what you're trying to do, get an approval, and move forward. One of the things that we've seen as well at CVS Health that I'm excited about is what we call PA bundles, when a diagnosis is created from a doctor, that once that diagnosis is approved, all of the PA work that we talked about earlier that can cause such constraints are all taken away. So just think about, you can get all your diagnostics done, and then you don't need to get a prior auth on your drug or any of the downstream steps, and that would just removes a whole number of steps. So I think if we can get smarter about how the workflow goes through, on how things get approved and move through the system, I think we would be in a much better place as well.
I'll quick add to that if that's, oh, go ahead. I was going to say, what I've heard from both sides of me is the issue of trust. Trust in data accuracy, trust in the people that you're bringing to the table. I know as a provider, I often was scared of payers. And even at Epic, we have a lot of our healthcare organizations are traditionally, ones that are also worried that something might not be approved or worried about a prior auth. But recently, actually, over the last few years, we've brought payers and providers together into the same room at the same time. And at first, it was a little scary. And we were worried, are they going to fight? What's going to happen? And the reality is they're all trying to do the right thing for patients. They really are trying to get data to flow to the right places. And I think if we are able to have this common ground of trust and then realize the technology already exists to allow this data to flow, a lot of these problems could be solved such that people can get faster treatments.
I just want to call out that certainly AI is a totemic technology of our time, but there are other technologies, robotics, mobile, that are very salient to healthcare. But I think AI is a good use case, and I'll not repeat what has been said. I think a lot of the things are not particularly sexy, but are super important, like governance, like you said. I'll also add to that change management. I'll also add to that reimbursement models. I think sort of a lot of AI algorithms have no clear pathway to payer coverage, as you mentioned before, and that is a major break on scale, right? And the last thing I'll comment on is actually scale, just that. I think a lot of the problems in healthcare, specifically oncology, what we need to get to the end point certainly spans one institution. And how do you think about frameworks, federated frameworks like Kaya and others to sort of help us get the scale we need to drive real value creation? I think scale is something to think about as well.
If I can add in, since you talked about trust and improving on the workforce, I will throw in that at our school, we've just started our first class last year, and we've incorporated into the curriculum health system sciences because we want to expose the students early on, how do you work in an infrastructure? How do you make an impact? How do you actually work together? Because we're taught to think independently but work as a team, and we aren't taught how to do that very well. And our sister institution is the Heartland Whole Health Institute, which is working at that actual modeling of the payer modeling. How do you work in a community? And so we're we're putting those students in that mind, the frame of mind of how to work in an ecosystem and make an impact. So trust is always a discussion we're talking about. Providing compassion and teaching compassion, the whole person care. Because again, as technology continues to advance, that humanistic side, and we heard some of that earlier, is going to be even more important. So we're bringing that back to front and center with how we teach students. So I think we can't do one without the other, is our point to our students.
I would also add, our clinicians are really overworked, right? We need to find ways to simplify their workflow and taking out the steps that AI can do. Automation of certain types of verification, certain types of clinical drug utilization reviews where the pharmacist doesn't have to go through all these different edits, that we can serve up all the interactions in a very simplified way. So I do think there's just so much more we could be doing to simplify the workflow in order to give more time to these clinicians to spend time with patients.
I can give a couple examples if that would help. I think sometimes we talk about AI and we think of what's happening in the future, and we forget that we've been using AI for a very long time in healthcare and in your general lives. So even thinking back to something as simple as a drug allergy medication or a drug medication, that is a form of AI. It's rules-based logic. It's on what we call the deterministic side of things rather than the probabilistic side of things. And we are very focused on this generative AI end of the spectrum right now, but don't forget that we've been doing predictive algorithms for a very long time and trying to help care in those ways. And so going to just a very simple workflow one that we were able to develop, there's plenty of organizations that are looking at how to read x-rays. But what if you just did the low-hanging fruit, which is take the radiology report, have AI read it to find, oh, there was an incidental finding on your lung x-ray. It recommends a CT in 6 months. What if it would actually put a scheduling ticket to the patient to schedule their own follow-up appointment so that it actually could be found potentially earlier if that was cancerous? And so we did that, and Christ Hospital, for example, they implemented that, and they were able to take the amount of detection of cancers, incidental becoming cancers, up to 69% in early cancer detection, whereas the national rate is about 42%. So to the point that we've been talking about all day, simply just reading a report and getting something scheduled, that's so easy, and yet we could be really changing the early stages of cancer to be caught earlier.
I want to add something. I think Jackie makes a really good point. I think when we think about any technology, the evidentiary standard for adoption should be actually outcomes. Right? It shouldn't be process-based or utilization-based, but like outcomes. Are you really moving the needle? And I think sort of taking that frame of mind, which will apply to any new drug, certainly that's something that's going to help drive better traction in healthcare.
So if we look at health system leadership now as it stands, how does that have to change in order to embrace this technology to move us to the future? Pretend you're the CEO, and what would you do differently?
I'll start, and then I'd love to hear each of your thoughts. So when I think about AI in healthcare organizations, and I'll start with AI, first thing you want to ask yourself is, do you actually need AI for it? And do you already have technology that could solve this problem, that either it's a person issue, a change management issue, a workflow issue that you just haven't implemented? Because that's no time, no money. That is simply turning something on and helping your organization work towards putting that into your workflow. That is something that you should absolutely do on day one. So let's say you've closed that chapter, you've already know everything that you already own, you've already are working at the top of your workflows. Then the next question is, what use case are you trying to solve? It's not what shiny object in AI do you want. It's not whether or not you are going to be the first person using it, or that you've figured out that you want to be on the hype part of the curve or the early adoption part of the curve. It's what is something that you innately need to solve for your patients and for your caregivers? Is it reducing burden? Is it helping patients get access to care faster? Is it being able to make sure that scheduling is easier? Then once you've chosen your actual use case, then determine, do you actually need AI? And if so, what does that look like? What is the easiest way to implement that? It doesn't need to be complicated. It should be something, and we keep coming back to this, simple. It needs to be simple, something that patients can simply do from their MyChart, or that providers can simply do from the record. So really, as I think about what to put in, it's getting back to basics and being sure that you're solving the problems that have always been there, but might just need AI to take them to the next level.
Yeah, I'll just say, just to put a fine point on that, people need to be clinically driven, right? We're tech savvy, but clinically driven, which means that the use cases need to match the needs, and it can't just be AI for AI's sake. I would just add to that, and I'll go back to this governance piece. Like, I think we need, as much as we need like the innovation and the big minds and the big thoughts that we've heard, we also need some pragmatists, particularly when it comes to governance, when it comes to operations. We need individuals who will think about, what are the decision rights? What are the workflows? How do we make those things work? Because those are the places where we often miss a step, and that often ends up costing significantly. And then I will also emphasize the patient centricity component. I want to hear about patients more. I want patients to be at the center of everything we do. And then the collaboration models. I think individuals who are coalition builders, particularly as we think about AI, as we think about large networks, as we think about federated learning, individuals who have the ability to be coalition builders and galvanize people. I want to know who are our next Mike Milkins in the room. And how are we threading that needle? Because I think it's going to be necessary as we think about the future and move towards this next 10 years.
So a few quick comments. As of today, the majority of the healthcare workforce are millennials and younger, so digital native. The next 10 years, they'll actually become AI native. So the fact of the matter is the expectations brought in by our workforce to meet this moment are unavoidable. At MSK, over the last 18 months, we've actually brokered 2 partnerships with hyperscalers. One is with AWS, and most recently, we're an early sort of like test site for HIPAA-compliant ChatGPT healthcare. We're one of about 8. And both of these relationships were actually in service of a strategic plan. So taking a step back, I think like most technologies, AI is a tool. There's no sort of independent AI strategy. There's an AI enablement of our strategy. So when we looked across our org and what are the key things we said represent an institutional bet over the next 5 years, drug discovery, provider patient experience, new care delivery models, then we reverse engineer to say, okay, what relationships, what partners can allow us to get to that goal? So for AWS, things in that relationship entail data curation. We now have access to a pre-market asset that's analogous to like isomorphic AlphaFold. And we're using that to sort of think about drug development timeline shortening. So we have a target that we validate, we give it to AWS, and in this asset, they give us back a de novo compound to prosecute that target. So things like that is how we're structuring our relationships in service of a strategic plan. So that's how we think about it. And last but not least, I think any healthcare executive of a firm more than 100, that's inherently a data company. So fluency at the executive level and accountability. So at MSK, there's certain metrics across both of those partnerships that I'm accountable to deliver on. I think that's of how we structure these relationships. And I think moving forward, that's probably going to be the norm.
I would also suggest in our schools, as you mentioned, being able to start educating the leaders of tomorrow with what is collaboration, the human part and the technical part. I think a lot of it has been, they are very savvy in technology, but they haven't yet seen it always in practice, and how to be able to showcase behind the scenes what is happening with the technology to be able to simplify the workflow. Because I do think in the world that we're in right now, where we don't have enough clinical support, in our healthcare system, and we have to simplify the workflow and the capabilities. And a lot of it is that behind the scenes work that the technology does, that if they don't really quite learn it, they'll never really understand what the role of technology is in healthcare. So giving them that education is also important.
Yes. And, you know, I would add in that, especially coming from a rural part of the country now, that not forgetting that part of our country, that we can't look at just, because a lot of these major academic centers are in major cities, in the urban setting. And so to not forget about our rural folks that live out in the rural areas, how do we use technology to better serve them, to frankly even better serve the providers that are there, the nurses and the doctors, to help support them. And that's some of the things that we're looking at very deeply on how to use technology to support the entire system and address the needs of a community.
I think that's a great point.
Yes.
The reality is 80% of cancer care happens in the community, not in places like MSK and Johns Hopkins. So the responsibility on all of us, particularly AMCs, is how do we disseminate our expertise in near real time, and some of that is relationships. So at MSK, we have a program called Care Partners where we do just that. So we sort of deploy our SOPs, our protocols, our disease management teams to community providers. Some of that is decentralized trials. Unlike most chronic conditions in oncology, a phase 1 trial is a path to treatment and cure. How you think about virtual trials, decentralized trials in oncology, in those communities, the ones that make sense, I think that's also critically important. And also virtual tumor boards. So how we think about sort of like partnering with communities to elevate their care standards, I think that's sort of where we need to move as well.
I would love to see pharmacists be part of that versus just consider, your local community pharmacist is in your community, very well respected and trusted. So how can we also be leveraging that strength that we have in their clinical knowledge to be able to be more advocates for oncology patients in their own little communities?
That's such a good point. It's often that we think about our community or our expertise. But if we were able to take clinical knowledge from academic centers and able to take knowledge from pharmacy and pharmacists that may only exist in certain areas of the country and really have that data, then be able to just help us with insights that then can actually change into clinical care in some of the most underserved and rural areas that we have. It's just like democratization of data then goes to democratization of insights, and then democratization of actually having care that is just as excellent as the next person.
I mean, my dad used to get all his information from his pharmacist. He knew everything about her, and she knew everything about our family. And so it's very well respected and reliable. And I think that we can't forget that. So,
Thank you.
well, thank you very much. Really appreciate all your input, and thank you for staying.
Good afternoon. It is February 24th, 2026, and we are completing 2 days here in Washington, D.C., with a goal of eliminating cancer as a cause of death in the last 10 years. 55 years ago, President Nixon declared a war on cancer. The National Cancer Act of 1971 increased investments and rallied a nation around science. His own goal was that the most important domestic decision he made during his presidency, history would prove, would be the creation of this Cancer Act. More than 30 years ago, we put on the very first Cancer Summit here in Washington, D.C. And a few years later, 500,000 people came for a march on Washington to stop cancer. This has been followed by numerous other types of things as we focused on other events to really focus the country's effort and commit our country to medical research and one of our crown jewels, the NIH. It was 15 years ago at our retreat in Tahoe where two of our closing panelists, along with many others, 82 others, gathered for 2 days to try to reimagine medical research in our innovation retreat. It led to the creation of a new center at the NIH, the National Center for Translational Research. Over the last 2 days, we've heard a lot about prevention, early detection, immunology, AI, clinical trials, public and private partnerships, and quantum computing. Science supporting our efforts on searching for an end of cancer as a cause of death have been accelerating faster than ever. For me and many other people around the world and in America today, 1 in 2 men being diagnosed with cancer, 1 in 3 women. It brings it home to every family. And so our goal today is to figure out what steps to take. Over 2 days, we've recorded many of the most innovative ideas that are available today in the world of science and hopefully will be applied towards cancer research. Those in the room and those hundreds of thousands or millions that are watching us stream this to you today, we thank you for your participation and hope you'll hold our speakers accountable for their presentations over the last 2 days. In our efforts, there are 3 people here who could be defined here in closing as all 5-star generals. Combined, they have led the world's largest and most important biomedical research organization over more than 2 decades. Elias, Francis, and Monica have had that responsibility of the leadership, not only for the health of people in America, but for the health of people throughout the world. So today, we're going to step back and think about some of the issues from the past, but particularly focused on the future. Elias, let's start with you. How would you describe the changes in the biomedical innovation system over the past 5 to 10 years?
I think that fundamentally the system evolved following the compact that was created in 1945 by Vannevar Bush, which was a compact of alignment between the goals of the government, universities, and industry as an engine of development for the whole country. And it's been true pretty much until a year and a half ago, when people started to question exactly what the value of science was, and then there was lost in trust in science because of the effect of the pandemic. But I made a slide for you. So I don't know if you can see the slide, if you could project the slide. And because I've been asked this question before, how does it work? Why is it that over 75 years we've become the top biomedical research country in the world? And how does that happen? Well, nothing happens by itself. There's an ecosystem. So I'm explaining it to you very quickly, if I may. At the top is the federal government. And federal government funding is essential. It starts the wheel. And the money goes to federal laboratories, about 10%, 15%, and the rest goes to universities. What do universities do? Well, they are the ones who do the discovery and train the research workforce. They publish, they patent things. Also, remember that there's one category, one characteristics about the American system is that we actually depend on immigration. You know, we're only 350 million people. And Georgi Yancopoulos was saying that the number one thing about success in science and technology is genius and identifying the smartest and the brightest people. Well, we're 350 million people, but we basically produce 25% of the economic output of the world. How do you maintain such a large economy when you're 350 million people? China is 1.4 billion, and India. Well, imagine that a genius comes once in a million times. So how many geniuses do we have here? For 350 million, that means we have 350, right? That the rest of the world is 7 billion, and keeping the flow and the selection going gives us access to a much larger. If we could go back to the slide. And so basically, the universities are in the middle, and then the industry is at the bottom, and that's the relationship. But universities also lead to startup ventures supported by venture capital, and on the right side is philanthropy. At the end of the day, FDA regulates all of this, and then products come to markets, and taxes go back to the government. So I was always criticized when I was the NIH director, I'm sure you heard that the budget of NIH is being wasted, given to industry, for industry to benefit. And I pointed out to senators that, in fact, the return from industry taxes was greater than the NIH budget, at least at my time. Maybe in your time it wasn't, but I don't know. What is the point I'm making? We are, in the past year, we've really gone through a perfect storm. Every single component of this ecosystem has been challenged and under attack, whether it be federal funding, whether it be universities, whether it be industry, whether it be philanthropy now is taxed. Endowments are taxed. It was never imaginable that we would do this. And venture capital is down. And so the whole system is basically disturbed. But there is good news. The good news is that this year, the resistance from patient groups united for cures and from scientists united for science have been successful despite all the headwinds to convince Congress that all the drastic cuts to the NIH budget were not justified. And Congress came through and passed a budget that actually restores and increases both the NIH budget and other budgets. The battle is not over, because there are things in the budget, such as full funding, which really reduces. It's a poison pill. It reduces the number of scientists. So they're spending the same amount of money, but on fewer scientists, which is exactly the magic powder that we have, is the scientists. And the second thing is, obviously, indirect costs, and also distributing the money as block grants to everybody who wants some money across all the states. You know, ideas that have never worked. The government cannot pick and choose. Let the scientists do that. Let the industry do that. Let the best and the brightest be in charge. So I am optimistic that, in fact, this year we're going to turn the corner, as we have already begun to do that in this past year. I stop right here.
Thank you. So, Elias, we are so lucky that you came here from Algeria as a young boy, and I think you're symbolic. There are more than 50 million people in the United States that were not born in the U.S. The next country in the world is Germany, with closer to 15 million people, and took a lot of people from the Middle East during the wars. It is estimated that the social and human capital of the United States The productivity of the people here ranges between a low of 1,500 trillion and a high of 2,000 trillion. So when you talk about what we've achieved and people that have come here and how they've built not only the United States, but have helped build the health systems of the world, the value of the talent of the people in the United States is 50 times to 70 times the value of the economy, which is 30 trillion. While all the financial assets are around 250 trillion, so it's 6 to 8 times that. And so the best and brightest, if we assume that intellect is evenly distributed throughout the world, but opportunity is not, we have benefited, Elias, from you and others that have chosen to come to the United States with the feeling that they will rise to their ability. And as we sit here in the Hall of Dreams of the Center for Advancing the American Dream, it's only symbolic as we sit here that we recognize the contribution of so many people that have come to this country. Francis, we've heard all day about the amazing potential of future advances in cancer research. But we are at a difficult time in the U.S. where public opinion is polarized in so many areas, and that includes the increase on distrust of science by so many. It's a topic you and I have spent more than 30 years on, but this issue is greater today than it has been in any of those 30 years. What should we be doing to help the American public better understand the value of medical research and why they should trust us? We've attempted to do that in an economic model, letting them know that just eliminating cancer was worth more than double the size of the entire economy in the U.S. What ideas do you have today?
Well, Mike, thanks for bringing up this really important topic, because I don't know that we've talked about it a lot today. We've kind of been adopting a model that if we develop fantastic technology and science advances that is based upon strong evidence, that will mean that the public will embrace those opportunities and all will go well. Do you remember COVID? The development of the COVID vaccine, the mRNA vaccine, will stand, I believe, as one of the most amazing achievements of humankind, saving 3.1 million lives in the United States alone. And yet, more than 50 million Americans, despite the evidence from the rigorous phase 3 trials that were conducted on that vaccine, said, no, thank you, I don't trust this. 230,000 Americans are now in graveyards because of misinformation and distrust about a vaccine that could have saved them. That's not my data, that's from Kaiser Family Foundation, but it's very well worked out. So we have a total crisis right now in terms of distrust in this country about medical research and about scientists. Recent poll would say only 36% of Americans trust scientists to be giving them information that is worth their believing in and to have their best interest at heart. Newbar brought this up, I think, earlier today, that let us not imagine that just because we're doing all this great set of advances in cancer, that will also be recognized as trustworthy any more than perhaps the COVID vaccine was. So yes, we need to work on getting that information out there. Elias, I'm glad you talked about the fact that the Congress this time, and we had Senator Capito here this morning talking about it, were able to stand up against a frontal attack on medical research coming from our own administration. But how fragile that resistance is something we should worry about. Does the American public actually engage with this? When a breakthrough happens in American medicine, do people understand how that came about? Does, those farmers in Nebraska you were talking about, when something like that happens, what's the understanding? I suspect it's pretty limited, and the data would say that, well, maybe that was a company that did that. and oftentimes it is, but based upon what might have been years of federally funded research. Or they might think, my university did that, not realizing that the support for that university came from their own taxpayers' dollars. So we have a huge deficit there in that understanding. This might seem like a strange place for a guy who served as the leader of the Human Genome Project and for 12 years as the NIH director to now put 100% of my effort, but this is where I am. I can't look at this situation and not feel obligated to try to take action. So what to do? How do you break through in a circumstance where so much of the public resides in what's been called the exhausted middle? That's about 2/3 of the country. Read More in Common in their analysis of our society. That's what they say. They're somewhat blue and somewhat red, and they're kind of disgusted by all the animosity and the grievance-laden conversation they see on cable news and in social media, and they've kind of checked out. But they're good, honorable people who have been benefited by medical research without realizing it. Most of you all know probably 99% of the drugs they find in their cabinets only came about because of federally funded research that ultimately then led to a company taking that forward and getting FDA approval. But that's not something that's realized. So how do we start to change that? How do we move that needle? That's what I'm hoping to do with a very small team that is still somewhat limited in its capitalization, but hopes to get more so. So anybody who has a deep pocket, I'd be glad to hear from you. This effort has done a lot of research to try to figure out how do you break through in this kind of noise situation. And there's a pretty clear answer. It is not people like me complaining. It's not even having people sit in a room like this and go, wow, that sounds like cool science, because it'll be hard to figure out what's really going on. Those folks are not probably, if they're listening to this discussion today, being particularly inspired by it. We're in a bubble, folks. How do we get outside of that bubble? It's one way you can do that, and that's patient voices. That's people whose lives have been profoundly benefited by medical research, who understand how that in a certain way came to be, and who are ready to tell that story in an authentic, straight to the camera, here's what happened to me, in a fashion that can be readily distributed through all kinds of media, especially social media, because that's where most people get their information. Here am I, a guy who hates social media, and now I'm advocating this is going to be our best avenue for trying to change public understanding of something that really matters. Because it'll be great to have some leaders in Congress understand that, but the grassroots of America doesn't appreciate what we're doing. I'm not sure how durable this turnaround is going to be. So we've started this effort. We've done a lot of research. I have 2 social media companies that have been hired to bring all of their expertise and skill to this. And how can we learn from what has worked in social media with the outrage Olympics and try to apply it to positive messages? And we have some pretty good ideas about that. And how do we segment the audience so that there is a message for the soccer moms that's maybe a little different than for the veterans or for the young men who are like trying to figure this stuff out? All of those are audiences we have to think about. I just want to show you very quickly a 3-minute video of some early examples, and this is still early, of how we might try to touch hearts and minds with individual stories. So I hope that video might be queued up, and you could now run it for us to see examples of people who have really compelling stories to tell. Can we run the video, please?
I used to be a dead man walking. I used to live in a hospice state because of my disease.
I had no symptoms, and I was pretty certain that this would be a fluke.
I started chemotherapy. I ended up relapsing twice, so standard treatment just wasn't working for me.
Not knowing what was causing it was really stressful.
And he said, no, I'm sorry, we just don't do that for people with stage 4 because we're really literally trying to preserve your quality of life.
The doctors told my parents that I wouldn't make it to 40.
So I Googled, how far has research gone? It was just an act of desperation. And NIH was the first thing that popped up, and they introduced the concept of gene therapy.
My daughter found a study that the NIH had been doing for at least 3 decades.
In that clinical trial was my last option. Without it, I wouldn't be here today.
They said, hey, we want to try immunotherapy. It's not been tested in esophageal cancer yet.
And I was a candidate for immunotherapy, which 10 years prior had been in clinical studies.
The biggest change in my life was researchers finding out what the defect is with cystic fibrosis, actually to the genetic level.
It was comforting just having a plan and knowing here's what we're going to do to tackle this.
Most days I'll be forgetting that I ever had sickle cell.
Now it's 3 pills a day.
I was cancer-free within 22 days, and it was decades of medical research and work that came to me.
We can actually live in these worlds where we have full control over our biology.
Sometimes it's helping very few people with very rare diseases. You don't get to choose what ailment or condition you get.
I'm definitely living proof of that. I'm about to turn 40 and healthier than I've ever been in my entire life.
There are so many other stories, there's so many other people who wouldn't be here.
Medical research keeps the birthdays coming, and there's so much life, to be had.
So those are just a few. The goal is to collect hundreds of those patient stories, to utilize social media influencers, a network that we're building, to try to get them out there in front of people all over this country so that they become aware of why this is something to care about and raise their own level of interest and pride in the fact that this is an American success story and their taxpayers' dollars is part of the reason. And by the way, also elevate their familiarity with medical research, which might make people more interested in taking part in clinical trials and taking better care of themselves. So that's the goal. Again, we need stories. Anybody listening to this who knows of stories like this, I want to hear about it, francis.collins@gmail.com. And anybody who has additional ways of supporting this, because we are well enough funded right now to kind of get it started, but to scale this up, we're in need of additional resources. So yeah, thank you for asking, Mike.
So, Francis, I think we should contribute those videos we did at the Celebration of Science in 2012. Amazing stories, and we don't have time to run them, but we might put them on the website for you to look at. It's hard for me to forget the story of a young woman that day who told her story, Francis, that at, I think she was 19, went to model in Europe during the summer. She was raped. She didn't tell her parents. She didn't tell anyone. And then she started not feeling well, and the result of tests showed that she had HIV/AIDS. And she commented that her first thought was not that she was going to die. Her first thought was she would never be a mother. And that video in that day, due to advances where you went from 90% chance of passing AIDS on to your children to less than 2 today. And we saw her with her 2 miracle babies, Francis. So I'm just thinking of a few of those stories we've already captured here. This is maybe at a peak today, but it's not new. When I first met Frida Lewis Hall many, many years ago, she was the chief medical officer of Pfizer. And she was the face of the pharmaceutical industry. She had that regular show with the doctors on the air. And she went home, and she was the best student in her town. And she went to medical school, and she worked for a biotech company. But when she went home for Thanksgiving, she was working for Pfizer. And all of her relatives around the table said, Frida, why did you sell out? You were the smartest kid in our town. You were the smartest African American kid in our community. And now you sold out working for Big Pharma. Her father, who told us that, and her uncle were both on Lipitor, the drug of the company she worked for. So she had tried to educate them over that Thanksgiving weekend that they were living normal, healthy lives. This is not a new thought, Francis, but it's brought to a new peak, I think, today. Monica, we've heard a lot about AI at this meeting and how it's transforming medicine. And when we look at all the projections of what's going to occur, the investment in AI, and it's possible that the clearest benefit for AI that we see is in the field of healthcare and medicine. You will soon be leading the National Academy of Medicine, an organization that's produced important guidelines for this technology. We've linked one of those to our QR code. Now that the National Academy of Science has produced this guidance, what happens next?
Yes, thank you. And I love talking about medical AI and its opportunities and responsibilities with cancer experts. Why? Because people who care for patients with cancer understand about balancing benefit and risk. And that's where we need to be in how we think about this exciting new technology, just like we had to be when we had to think about the possibilities of the first immunotherapy, which was so terribly toxic and could hurt people. And, how we had to learn how to deliver better, safer therapy, how we are still learning how to deliver better, safer therapy. AI is exactly the same thing. And so, the basic principles, the roadmap, and you'll see this in the document that you have a link to, are how do we do this? Collaboration, training, and oversight are the pillars of what we need to do. Collaboration, because it has to be part of Elias's ecosystem to do anything we do. Training, because we need people to understand and know and bring along the next generation to be able to use these tools properly. And oversight, because these technologies only work if we teach them, if we give them the information they need to deliver what we ask them to do. So, quick example, can develop, let's say we develop a tool to help doctors and other clinicians take care of somebody who's got back pain. Well, if it's trained with data that comes from a very large, multi-million patient orthopedic practice, it's going to say, when you have low back pain, get an MRI, because we might need to take you to the operating room. If you train it with data that comes from a very big, large health insurer, it's going to say, let's get some physical therapy and maybe some non-steroidal, anti-inflammatory agents and see what happens. But what we all need to worry about, and both of those answers are okay. My point is, what data you feed it is what answer you're going to get. So that's important. We need to build that ecosystem and collaborate to deliver the data that's going to make the answer that delivers what's very best for the patient. And frankly, we don't know the answer to that right now. And this tool might actually finally help us get some of those answers that we've never been able to get before. So that's the opportunity. But here's the responsibility. We're cancer doctors here. What if the patient had the edge cases? Always pay attention to the edge cases. What if that patient has low back pain because they have a tumor in their spine? These are the kinds of things we also think about as we bring on these new technologies and tools, and we must think about, because we have to think about every single patient. So incredible opportunity. 4 things that need to happen. Focus on delivering the best result for every patient. Reduce utilization, healthcare. We need to drop our costs. Use these tools to start to rein in low value care. Handle the edge cases. And then finally, learn, continually learn as medicine changes every day. Thank you, Michael.
So the benefits are around us. We see them every day. And I think what we're hearing is, Francis, you've given a little disconnect from what they know and what they're linking it to. 1990 in America, 1990s in America, as we went around and recorded members of the House of Representatives and the Senate laying the groundwork for the march, they all felt the big C related to death. John Wayne, everyone they knew. 20 plus years later, we have Romney and Kerry run for the President of the United States. Both had cancer. Not even an issue in the election. What caused that to occur, obviously, is medical research that occurred. Another disease, HIV/AIDS. Magic Johnson, one of the more beloved members of the sports community and the world, announced he has to retire from basketball because he has HIV. What is the reaction? The reaction is Magic Johnson is going to die. And if you go online and want to see it, a really emotional video to look at of Larry Bird, his arch enemy on the basketball court for all those years, with tears in his eyes, thinking that Magic, when he heard the news, was not going to make it. At our 2012 celebration of science, 20 years later, Magic was there, bigger than life, with his smile, talking about it, and the world had changed. I'd like to now ask each of you starting with you, Elias, if you were starting out today and you were that young scientist, what would you be thinking about in your future career? Would you be optimistic? Would you be concerned? And what would you be telling your young self?
That's a great question. First of all, I'd be optimistic. I've never seen as many technologies coming up, as many approaches to understand biology and to act on biology as I've seen today. I wish I was 30 years younger and went back to NIH to run NIH. It's probably the most exciting things you can do and help with, right? So what would I say is the most critical thing? Number one, I think we're at the junction where we have essentially a tension between the complexity of biology, the power of computation, and the precision needed to treat any one patient, right? So let me talk about complexity. So when you heard about AI and how the game of AlphaGo was resolved, you wonder, how many combinations of the game are there? Well, it turns out it's like billions, right? And then you go and you say, how did they figure out AlphaFold 3 when they figured out the structure of proteins? And we only knew a few thousands. They used that, they learned with a way that we don't understand, but they were able to extract the rules and essentially solve the structure problem. You know how many combinations of structures there are? 10 to the 30th. So it's almost like as many galaxies and planets and and suns that you have in the universe. And then you go to biology today, cancer biology, and you know that very well. So we're talking about 7,000 diseases. Cancer is not one disease, 2,000. And then you look at the combinations of molecular pathways, and it's enormous, right? If you look at the antibodies you can produce, you yourself, is 10 to the 18, so it's a billion, right? If you look at the number of small molecules we can develop, it's 10 to the 40 to 10 to the 60. So why am I saying that? I'm saying that because the future, if I was to be again able to, give it a 15-year effort, is based on decomplexing or decomplexifying biology so you can actually use it. And to do that, you need AI. And I think we heard it today. You don't have enough of the data to make AI intelligent enough to solve the complexity of biology and apply it to you. You look at your fingerprints. His and I are not the same. You look at our irises. His and I are not the same. Well, in fact, no one on Earth has exactly the same fingerprints, the same iris, the same genome, the same cells, the same neurons. So we're unique individuals, but we come out of a very, very complex system, which probably has rules we haven't figured out, just like the game of Go or the structure of proteins. So that's my vision. But to do that, you need a different way of doing research, attracting the best people across the sciences. This is what I call convergence. You need to marry things that did not date before. The disciplines are silos that put peoples in cage. And you need to have different structures of research where the teams are multidisciplinary, coming from physics, from mathematics, from biology, from computing, from data sciences. And you need to create that new culture of research, which isn't an isolating things. And Gary, I know that Francis and Monica also understand the fact that scientific teams of the future have to be different and also supported by a completely new generation with completely new thoughts. But the scale is what I'm trying to convey to you. This is the only field of human endeavor that has the complexity that no one at this point has ever mastered. Going to the moon is easy. We know where it is. We know rockets. Elon Musk has an easy job. I mean, going to Mars is going to be a piece of cake compared to what we have to do. Thank you.
Francis, what about that young boy that grew up in a house without running water and was homeschooled? And what would that young boy be thinking about now about the opportunities and promises of the future?
Well, that young boy thought he wanted to be a truck driver, but it didn't turn out that way. Yes, that was me. I fell in love with science because I could see it was a detective story, and young people are still going to be falling in love with science for that very reason. You get a chance to spend your life solving mysteries, figuring out how things work, knowing that there is truth there to be discovered in nature. If you do the experiments right, you're going to figure it out and maybe see something that nobody else saw before, and maybe even in the process help somebody to alleviate suffering and save lives. There can hardly be a more compelling reason to devote yourself to a profession than all of that. But it is a tough time, as Elias very eloquently said, for people to both see the paradox here, that this is the golden era of scientific opportunity in life science. It is unbelievable, the kinds of things that we can do, much of it driven by technology, to be sure. We have induced pluripotent stem cells. We can do all kinds of amazing things with them. We have CRISPR and gene editing. We have things like spatial transcriptomics, which I never would have dreamed would be possible in my lifetime. And we have AI to make sense out of all that data, as well as all these other kinds of omics that are going to feed into our databases. So it is the moment, if you're trying to figure out how to sort things out. Take neuroscience, for instance. We've talked about cancer today, but talk about neuroscience. We're going to figure out how the brain works. those 86 billion neurons between your ears, which seems sort of so impossible to imagine that we could sort out their circuits. That is lying ahead of us here in the coming years. Wouldn't you want to be part of that? So I think the lure is still going to be there very strongly for that kid like me that's trying to figure out how do I want to spend my life. But we have to convince them that that is actually going to be possible. And here's where I think there's a lot of hope. Because supporting science that's going to benefit the human condition and stimulate the economy is on the right side of history. You can't be against that for very long. It doesn't make any sense. So even though we're going through a pretty difficult, unprecedentedly difficult time in the last year and a half or so, we are going to get through this. And that's what I keep saying to the young scientists around me who are wondering whether they still have a path forward. They do. We will figure out, and all of us who have the opportunity to keep making that case need to do so. And let's not be too down and discouraged and depressed about what's going on, because we may depress the young people even more. And they need to hear from us that we're going to be okay. We're going to get through this because the case is so strong.
Thank you, Francis. And so there's that young girl that grew up on a cattle ranch in Wyoming. Her parents were from Italy and France and immigrants to the U.S. She went to Princeton in biochemical engineering. What is that young girl thinking about today about the opportunities? Monica.
So, first of all, Michael, the American dream is very much alive. Thank you also for your tremendous role in making sure that it is elevated. Second, I am the luckiest person in the world. I feel that every day. You know, in 1976, the admissions department at Princeton University called me up. I was a beginning high school senior, and they said, "We want you to apply." I wasn't going to apply to Princeton. Are you crazy? Second, I get a letter January of that year saying, "We want you to come and we're giving you a scholarship." That transformed my life. That opportunity. And how did that happen? Well, now I know, it took a lot for that university to be able to do that, to have that ethic, to have that money, to give me a scholarship, the whole ecosystem, again, that we all talk about. That completely transformed my life. And we had a nation that could do that to that cattle rancher's daughter in Wyoming. And that's what we need to continue to be able to achieve in this country. We need the very best minds and the very best hearts able to do this work. So thank you.
So we all want to make sure for the American dream that that little boy who could hold his breath a long time under the water from Algeria, that little boy that didn't have running water in his house, and that young girl from a cattle ranch all have that opportunity. So in closing, we're going to put you on the spot now on 2035. So when we look at what you said today, a decade from now, my goal is that my great-grandchildren will have to look at the history books to learn about cancer. Will cancer rank among one of the top 5 leading causes of death in 2035, Elias?
Well, I don't think you can, in my view, I'm sorry. I don't think we should say cancer. I think there will be cancers that will be cured, no question. We already cured a few. And then you heard today about the prevention, not the prevention, but the preemption of cancer. That is going to grow because our diagnostic capabilities are getting better and better and better. And so you'll be detected early, or you'll have a pre-cancer condition that will help reduce the burden of cancer. Some cancers may not be at that time cured because of the complexity of reaching, for example, the brain. I think brain cancer will be a difficult one, or very solid tumors that have a very protective layer around them. But on the other hand, I think that the knowledge of cancer would be at the point where the limit is going to be the technology to beat it, not our insufficient understanding of his biology, right?
Francis?
Well, I'm a cancer survivor, and I think what we are seeing, but want to see happen even more, is that when cancer does happen, it becomes a treatable disorder that then does not create a difficulty with your ability to flourish. We talk about lifespan, but we also should talk about health span. The difference between health span and lifespan might be called sick span, and we want the sick span to be shrunken. And a lot of what maybe is causing people to lose quality of life now is the consequences of cancer. Let's have as our goal that we greatly reduce, maybe even try to eliminate that for the common cancers. It's still the solid tumors that challenge us most, but what I heard today makes me more enthusiastic and optimistic than I have ever been about the ability to tackle those as well. But let's be clear, as Elias said, we're talking about 1,000 different diseases, and some will be more difficult than others. But I think by 2035, we'll see a very different picture.
Monica?
Here's what I want for 2035, and I know we can do this. Today in America, the county with the highest rate of deaths for cancer is a very wealthy one, Summit County, Colorado. A county with, lowest death, lowest death from cancer, Summit County, Colorado. The county with the highest death rate of cancer is a county in the Texas Panhandle, in the Florida Panhandle. There is a 4-fold difference in death rate from cancer between those two locations. By 2035, we need to make that difference completely go away so we do not have disparities in survival or incidence or any of the harmful effects of cancer in this nation.
So 3 of the 4 of us on the panel are cancer survivors. We're very symbolic of the country from that standpoint. And with 80 being the new 60 and 60 being the new 40, we have a lot to live for. So on behalf of the Milken Institute and Faster Cures, we'd like to thank our co-hosts, the Richard Nixon Foundation, along with our speakers, all of the participants, those watching us on streaming, and everyone involved in the critical work of eradicating cancer as a cause of death and suffering. And thank you for joining us today.